तो ये सब खो गया ना पीपीटी वगैरह।
So मैंने भेज दिया ग्रुप में। Each and every one of you, on behalf of Department of Thai Chikitsa, all in the Institute of Ayurveda. Today, we are gathered here for a workshop of utmost significance. Today, we are gathered here for a workshop of utmost significance, a workshop dedicated to addressing a health concern that affects millions around the globe, latent tuberculosis.
Title: Promotion of Ayurvedic Medicine and Rasayan Therapy for Management of Latent Tuberculosis (LTBI) in Indian population.
मैडम का पहले पीपीटी में लेके डॉक्टर रघु राम राव जी इज गोइंग टू बी फर्स्ट स्पीकर। ठीक है मैडम, इसमें पास ले लीजिए, ये पेन ड्राइव में लेके इसमें वो स्पीक कर माइक एक बार दे दो मैम। ये वाला कहाँ है?
उनसे बोल
भैया आराम से
मैम हिल जाए।
हाँ वर्किंग है। Hello, am I audible? So all participants are here. We welcome you in the All India Institute of Ayurveda. Now, as per the schedule, we are going to start our first session sharply from the 9:30. There is a little bit change. The first speaker is Dr. Raghuram Rao ji. He is a additional assistant deputy director from the Ministry of Health and Family Welfare, and we are really very blessed that sir is here to share all the new proceedings which Government of India is doing under the heading of Ministry of Health and Family Welfare. You are free to ask any question to improve your skill, because government is planning all the things only to build the capacity to improve your skill in this area. So best of all, best of luck for all of you. We are going to start. So डॉक्टर रघुराम जी का वो है ना आपके पास सीवी मैंने दिया
जी
था?
मैम है
वो सब है। तो आप स्टार्ट कर दो सीवी, मैं सर को नहीं बोल के, और उसके बाद मैडम पीपीटी देंगी, पीपीटी को इसमें लगा देना, उनका प्रेजेंटेशन सारा कुछ मैं ऐड कर दूंगी, ठीक है ना? सर आने के बाद सीवी बोलना है ना? हाँ सर, क्या वो लगा पीपीटी लगा, और तब तक के लिए सभी स्टूडेंट फ्री हैं, सबको बुला लो।
आज तो सबकी ओपन है, आज फ्राइडे है। ये बात बोल दो ना मैम, हम नहीं बोल सकते। देखो ये इधर वहाँ रख देते हैं, की जरूरत पड़ेगी तो। रुपेश चाहो तो एंकरिंग के लिए दे दो फिर। नहीं वो माइक तो नहीं देख सकते हैं। सेकंड सीवी लगाने ना, आपने कहाँ कॉपी पेस्ट कर रखा है बताओ मुझे। फाइल्स में है। ये माइक ले लीजिए, बोल के मंगवा लो। ये इसके पीछे ही वाला है ना? ये आपने डाउनलोड्स में है ना? ठीक है, नहीं मैं यहाँ डाल दूँगी, सब कुछ एक में डाल देती हूँ प्लीज़। वो हमसे पीपीटी ले ली थी, वो पेन ड्राइव ले ली थी उनसे। नहीं अच्छा, उनसे पेन ड्राइव लेना, मैम का उससे लेटर करना है ना? ठीक है ना? हाँ ठीक है। क्या बोल रहे? ये सर की पीपीटी है ना, रघुराम राव सर की? हाँ नहीं पीपीटी का आप लोगों ने से वी तो बनाया। किस नाम से? आप डॉक्टर रघुराम राव, आज का डेट है प्रेजेंटेशन। आप मुझे एक सेकंड, आप मुझे सीवी बताओ। टीवी प्रेजेंटेशन ना, टीवी प्रोग्राम ये रहा। ठीक है एक्चुअली क्या है ना, हमें ऑपरेट करना है, तो एक बार अगर हमें पता होगा ना, ठीक है स्लाइड शो कर देंगे। हाँ अब आप वो पीपीटी लगा दो इसकी। जाएंगे ना एक साथ। अच्छा लगाया ही नहीं। कौन सा है?
You can directly open from there.
नहीं है, कोई नहीं, डायरेक्टली उसी से ओपन कर लेंगे।
स्क्रीन ब्लर्ड है, इसको क्लीन नहीं कर सकते, ताकि पीछे बैठे हैं उनको नहीं दिखेगा। मतलब
वो एक्चुअली ना वहाँ पे टीवीज़ हैं,
ओके,
है ना, तो वहाँ पे डिस्प्ले होगा वो सारा।
बट इसका रिजोल्यूशन पे भी फ्रॉम दिस सेटिंग वी कैन चेंज।
आईटी में से किसी को बुलाना पड़ेगा।
फर्स्ट प्लेट रहने दीजिए, वो लाइट जाएगा तब बस प्रोग्राम स्टार्ट नहीं होगा ना, वरना ये सब जाता है।
ओके ओके,
स्टार्ट नहीं होगा।
टीवी प्रोग्राम का शेड्यूल कहाँ जा रहा है आपने? वो
ओके आ गया ना।
हाँ,
दैट्स इट, थैंक
थैंक यू। टीवी प्रोग्राम का वो करें।
उसके लिए फिर से फोन कर। नया वाला भेजा था क्या मैम ने आपको?
भेजो आपको दोबारा
मेल कर दो।
मेल। अच्छा ठीक है, एक सेकंड।
अच्छा ये बता
याद नहीं, चेंज नहीं दिया। स्टार्टिंग से
नहीं डर किसी का आज, नहीं डर किसी का आज, नहीं डर किसी का आज। एक दिन हो मन में है विश्वास, पूरा है विश्वास, हम होंगे कामयाब एक दिन, हम होंगे कामयाब, हम होंगे कामयाब, हम होंगे कामयाब एक दिन। हो मन में है विश्वास, पूरा है विश्वास, हम होंगे कामयाब एक दिन, हम होंगे कामयाब एक दिन, हम होंगे कामयाब एक दिन। कामयाब, हम होंगे कामयाब, हम होंगे कामयाब एक दिन। हो मन में है विश्वास, पूरा है विश्वास, हम होंगे कामयाब एक दिन। होगी शांति चारों ओर, होगी शांति चारों ओर, होगी शांति चारों ओर एक दिन। हो मन में है विश्वास, पूरा है विश्वास, हम होंगे कामयाब एक दिन। हम चलेंगे साथ साथ, डाल हाथों में हाथ, हम चलेंगे साथ साथ एक दिन। हो मन में है विश्वास, पूरा है विश्वास, हम होंगे कामयाब एक दिन। नहीं डर किसी का आज, नहीं डर किसी का आज, नहीं डर किसी का आज एक दिन। हो मन में है विश्वास, पूरा है विश्वास, हम होंगे कामयाब एक दिन, हम होंगे कामयाब, हम होंगे कामयाब, हम होंगे कामयाब नहीं डर किसी का आज, नहीं डर किसी का आज, नहीं डर किसी का आज। एक दिन हो मन में है विश्वास, पूरा है विश्वास, हम होंगे कामयाब एक दिन, हम होंगे कामयाब, हम होंगे कामयाब, हम होंगे कामयाब एक दिन। हो मन में है विश्वास, पूरा है विश्वास, हम होंगे कामयाब एक दिन, हम होंगे कामयाब एक दिन, हम होंगे कामयाब एक दिन। कामयाब नहीं डर किसी का आज, नहीं डर किसी का आज, नहीं डर किसी का आज। एक दिन ओ हो मन में है विश्वास, पूरा है विश्वास, हम होंगे।
Good morning to all the dignitaries present. It is with great pleasure and honor that I extend a warm welcome to each and every one of you on behalf of Department of Kai Chikitsa, All India Institute of Ayurveda. Today, we are gathered here for a workshop of utmost significance, a workshop dedicated to addressing a health concern that affects millions around the globe, latent tuberculosis.
Titled Promotion of Ayurvedic Medicine and Rasayan Therapy for the Management of Latent Tuberculosis (LTBI) in Indian Population. Now let's start the very first session of the workshop with utmost enthusiasm. I invite Dr. Raghuram sir
On
to the dais.
It is my honor to introduce our esteemed speaker for the upcoming session, distinguished figure at the forefront of the battle against tuberculosis, Dr. Raghuram Rao sir.
Dr. Raghuram Rao sir currently serves as an Assistant Director Journal in the National Tuberculosis Elimination Program (NTEP), Ministry of Health and Family Welfare, Government of India. His extensive experience spanning over 20 years reflects profound commitment to public health, particularly in the fields of tuberculosis, HIV, leprosy, environmental health and health systems.
In his current role, Dr. Rao sir spearheads various crucial portfolios within the NTEP, including Nikshay, direct benefit transfers, policy and planning, and the integration of newer technologies like artificial intelligence in TB management. He is a key driver behind flagship schemes such as Pradhan Mantri TB Mukt Bharat Abhiyan.
Dr. Rao sir's expertise extends beyond administrative responsibilities. He has co-authored numerous scientific publications in high-impact factor journals, demonstrating a dedication to advancing the knowledge base in the field.
As we delve into this session, Dr. Raghuram Rao sir's insights into the National Tuberculosis Elimination Program, along with his comprehensive understanding of various schemes under the Ministry of Family and Health and Family Welfare, will undoubtedly provide us with a nuanced perspective on the ongoing efforts to eliminate tuberculosis in our nation.
Please join me in extending a warm welcome to Dr. Raghuram Rao sir. We are privileged to have him share his wealth of knowledge, and we eagerly anticipate gaining valuable insights into multifaceted approach to tuberculosis elimination. Thank you.
Please, sir.
Thank you. Thanks. Pardon me for my coughing. Very good morning to everybody, and to all the young ladies. Bed jai, So on that side, so that you can see. So thank you all. Thank you. To all the Ayurveda acharyas. From across the country and from one of the premier institutes that we have for Ayurveda in our country. It's a pleasure to be part of this, orientation and training package, and to also appraise and orient all of the audience on what efforts are we making as a national program in trying to end TB. In the country, it has been there for ages. It is there, mentions in the Puranas. It is there in, found in Egyptian mummies, where the body, the postmortems of those also indicate tuberculosis. So there is a lot of, I would say, focus now in trying to address tuberculosis. These SDG goals, which was introduced in 2015 after the achievement of the Millennium Development Goals, that targeted to end tuberculosis by 2030 globally. And what does it mean by ending TB? What it means is that there should be a 80% reduction in TB incidence, which means the new cases occurring should come down by 80% from what it was occurring in 2015, as the baseline. Similarly, to reduce mortality by 90% and ensure 0% out of pocket expenditure. So this is the overall global goals for tuberculosis that all countries in the UN have committed themselves to. India has gone a step ahead and committed to achieve these SDGs by 2025, 5 years ahead of the global goals. And it's not a commitment that has come from an individual or a program. It has come from the government. Our honorable Prime Minister has been leading this initiative way back in 2018 when he first made this announcement of advancing the SDGs, and just as recently as the last World TB Day in Varanasi, where once again Honorable Prime Minister reiterated the commitment of the country to achieve the SDG goals by 2025. So as a program, this is a very, very old or national program, among the oldest one. It started way back in 1962 as a national tuberculosis program, and where the district centers were started to be set up. Prior to this, there was no national program, but there is something called as a Tuberculosis Association of India, an NGO that was created with seed money from the Englishmen who started developing tuberculosis centers, which now also is there in some places called as the TB sanatoria, where the patients were admitted, left over there for a long period of time, and whatever treatment was available at that time, chemotherapy had not even come, in 1930s and all. So that's when tuberculosis intervention started. But as a program, it started in 1962, and then it in 1993 the globe also identified, and the WHO declared TB as an emergency, global emergency, and then that triggered a lot of actions across the world as well as in India, where the programs then started becoming more scientific, with chemotherapy coming in, drugs being made available. So DOTS, it's famously called as DOTS, which almost everybody knows, which is directly observed treatment short course. Now that's an important strategy that was introduced because of the long duration of treatment. Today we have 6 months treatment, but at that time the duration of treatment was even longer, and for that adherence was a very important issue for making sure that the patient completes his treatment and cures himself. So that is why the direct observed treatment was introduced at that point of time, and it was scaled up across the country, and then the program got renamed as Revised National Tuberculosis Control Program. It was slowly, now the talk was moving towards controlling, and instead of just stopping at identification and putting them on treatment, which means a little bit of preventive efforts started. In 2017, along with the 5-year plan, the national strategic plan was made with all newer diagnostic tools that came. Otherwise it was only sputum microscopy, where we used to physically, or what we call as microbiological confirmation, look at the bacteria in the slides in a microscope. But then with molecular diagnostics coming in, now the DNA and the RNA of these bacteria can be isolated, and those can be detected. What it means is that these new technologies can detect tuberculosis at a very, very early stage, with a minimal bacterial load also. In terms of just for macro level understanding, a sputum microscopy, we need minimum 10,000 bacteria to be there in that one field of the microscope to see. And this molecular diagnostic can detect even if it is as low as 5 to 10 bacteria. So that's the sensitivity of these newer tools that came in. Newer drugs also got introduced, and in the involvement of the patient was where the ownership of the patient and the community started coming into the picture, and that was one of the key patient centric approach that the national strategic plan took in 2017 to 25. And that was when the first time we also started talking of elimination, and this is when the SDGs were made, and the program got renamed once again in Jan 2020 as the National Tuberculosis Elimination Program. Initially it was TB program, then control, then revised national control, and now it is a tuberculosis elimination program. Slowly going forward, someday we will land up being a TB eradication program also, right? So, of course, then there was heightened interventions with multiple campaigns being launched. But to understand how much of TB do we have in India, right? So these are estimates, and these estimates were made using mathematical modeling basis multiple evidences in terms of burden. Prevalence surveys happen in the community, and basis that the last prevalence survey first when India did was in 1958 to 1960, and then in 2018 2019 we started the prevalence survey once again in the country, and basis that we had newer evidences available of the burden. If you see these lines, the blue line, the red line, there are 4 lines actually, and these are all older reports multiple times. So every year when there is newer evidence generated, the estimates become more strengthened, and you'll see that now the 2023 data, which is the red line on the right side, you'll see that this is also now already just last month published by the Global TB report, the World Health Organization, and the incidence of TB now, as we understand, is around 196 per lakh population in India, and it has reduced by 18% from the 2015 baseline of 235 per lakh population. So it's in that range that we have been able to reduce. The global decline in the same period has been around 9%, but the decline in India is almost twice the pace as we see, right? And that is something which of course is some acknowledgement of the efforts that the country has put in addressing tuberculosis. So the current national strategic plan follows some key core principles. First is detect, which means that when the 196 per lakh population which we mentioned, find where are they, catch everybody, detect these cases. So find all cases, right? And the various tools, be it X-ray, be it sputum microscopy, be it molecular diagnostics, through all mechanisms, and of course clinical diagnosis that happens when it's in some cases we are unable to find a sample also, but that is something where including in the private sector, right? So all those things have been introduced, and it's part of that. So for the private sector also, it will come in the subsequent slides. It is mandatory notification. Anybody who diagnoses TB, put somebody on treatment, has to mandatorily notify to the government and do that. Once identified, everybody should be put on treatment, and the standard national algorithm for treatment that has been prescribed for first line, then resistance, there are multiple regimens basis that, and there is a diagnostic algorithm and a treatment algorithm, so that there is standardized treatment. The challenge with tuberculosis and a bacteria of this nature, which is so old, and is that it mutates very fast, and it is very chronic hardcore bacteria, right? So it gets used to the drugs that we start giving, and that is why we don't give one single drug, we give a combination of drugs. So it's called multi-drug therapy, and that is why there are minimum 4 drugs that we give in the first line of treatment, and then we keep on adding newer drugs if there is resistance to a particular stream of drugs that we are giving. Third key pillar for the national strategic plan is prevention. Now we don't want anybody new who has a latent bacteria, which is the theme of this workshop, and it's very very important that this latent bacteria that we have, that should not break down and start multiplying to become a disease. that's where the prevention efforts will come in. So there is some treatments also available, preventive treatment that can also be given to prevent the breakdown of TB. These are newer drugs that have been introduced into this, and of course make sure that there is adequate system capacity within the entire public health system that we have in the country, right from the medical colleges, district hospitals, CHCs, PHCs to the sub-health centers. Everywhere we should be able to build systems to be able to provide these tuberculosis services that we speak of. So in the detect component, so the screening, how it happens in the program is at the community level. We have the frontline workers, which we call as ashas. All of you all must have interacted at some point of time. They and the next unit is the sub-health center, which is at a population of around 5,000, and that sub-health center has been upgraded to become an health and wellness center. Okay, and now it's called as Ayushman Bharat Health and Wellness Centers, now has been renamed as Ayushman Arogya Mandir. And this unit is where a new cadre has been posted called as the community health officer, and then there is an ANM, and then there are ashas to support them for every 1,000 population in the field. So these people, when anybody in the community is symptomatic or any we think that there is presumptive TB, from there the screening starts. The samples are collected there at the sub-health centers, transported. Multiple states, multiple districts have multiple mechanisms for sample transportation. Somebody has a courier, somebody is a volunteer, they give per sample paisa, and then they go and pick up. Somebody uses the postal services. So there are multiple mechanisms, but sample collection happens at the most peripheral level, moves to the next level where there is a microscopy. Primary health centers, around 25,000 across the country, have what a microscope, and that is the most traditional method of diagnosing TB, and that is the first center. And then above that, at the block level, at the CHC level, which is around 30 bedded hospital, is the molecular diagnostics that have been put, right? So these samples then get accumulated, comes there, tested, gone there, medical officer prescribes, and the medicines are given. And why are we doing molecular diagnostics is that we also need to identify drug resistance as early as possible, so that we put him on the right appropriate treatment. So the strategies for case finding is not just restricted to the hospitals. We don't wait for the patient to come. There is also a component of active case finding, where these peripheral workers go house to house in different time points through the year and try to identify symptomatics in the household and get them to the testing centers and do that. Private sector engagement is a separate intervention, where all cases who go and seek care in the private sector are also actively reached out to make sure that they have the drugs, and also make sure that the public health actions that is required in terms of contact screening for their household members, in terms of the comorbidity testing, all those things are also offered for that. I'll come to the private sector in the subsequent slides. In treatment, the first line of treatment now is a daily regimen. DOTS initially was, in 1990s, was alternate day treatment, if you all remember. Now it is a daily regimen, and the pill has a combination of all four first line drugs. So it's called a fixed dose combination. It has INH, isoniazid, rifampicin, pyrazinamide, ethambutol, all four in a single pill. In pediatric formulations, the ethambutol dispersible, because the FDC needs to be dispersible. So ethambutol comes separate, and INH, and the other three drugs are in a single pill, both dispersible. But this is how the first line treatment is. It needs to be taken daily for 6 months. First 2 months is intensive phase, and in the continuation phase, it is only HRE, the INH, rifampicin, and ethambutol as a continuation phase for the next 4 months. So that is the line of treatment that we give as a first line. Almost 96% of the patients in the country fall into this category. They are drug sensitive and they are able to take this. If you remember, there was injections also, for ones who were not responding to treatment. After 2 months the sputum was not converting, then we used to start streptomycin, and then again after that, with newer drugs coming in, injectables were all there. So now all these have been done away with. Now there are newer drugs which are oral drugs, bedaquiline, dilaminide, and linezolid, and there are multiple drugs, around 13 of them, which are all oral drugs. So the drug resistant treatment also now is injection free. So these also are around 2% of all the new cases that we find are drug resistant and fall into this category. The treatment success, because erstwhile, the treatment success rate was when we had a sample, we knew we could see bacteria. After giving the medicines, we once again do the microscopy and see that there is no bacteria now. So we say it is cured. But now with so much of extrapulmonary TB coming in, there is clinical diagnosis only there and all those things. So the denominator, or for calculating sputum success rate or the treatment success rate, is now all TB patients, not whether you have a sample or no. So the objective or the target for the program is, irrespective of the type of TB, 90% treatment success rate should happen, whether it is cure or treatment completed, where you have a sample or no, but still make sure that 90% of them successfully complete treatment. So that is the goal or the target in the national strategic plan. In terms of prevention, of course, now with COVID coming in, everybody knows what is prevention, right? Same what we did for COVID: physical distancing or social distancing, mask, avoiding coughing in public places, and then early seeking care, making sure you test and treat, and isolation, so that you don't infect to others. These are the normal preventive measures that we have done for COVID, is what is required for TB also, be it in the household or in the workplace or in the community settings. Also, as part of preventive efforts, when there is one case of TB, we call it an index case. When there is an index case of TB, what we do is we go and look for the contacts. When I say we, it is the ANM or the ASHA or the community health officer at the health and wellness centers who go to that patient house, look at other people, screen them, so that see if they also have tuberculosis and put them on treatment. If not, we can put them on preventive treatment. And then in terms of building the capacity, so this is the fourth pillar, where the involvement of the community, the multiple campaigns, the Jan Andolan campaigns that we have done, all these are targeted towards participation of the community in joining us to that. There is an immense need for raising awareness on tuberculosis to move and improve the health seeking behavior of the population to come to the facility and get screened and tested, right? And then there is, of course, TB cannot just be a test and treat intervention. There are so many social determinants: poverty, undernutrition, the working conditions, the living conditions, all impact the transmission of tuberculosis in the community. Hence, there is a lot of work that we do with all these line departments with the Ministry of Urban Affairs, with the Tribal Department, with the Ministry of Panchayati Raj. All these departments work together for tuberculosis, and they're all part of the Prime Minister's or the Pradhan Mantri TB Mukht Bharat Abhiyan. So just for your information, in terms of the diagnostic infrastructure that we have, laboratory infrastructure that we have. So like I said, at the bottommost level, the first place where we are able to test is a microscopy center, that is at the primary healthcare level. Above that, the molecular diagnostics, which we call as NAT, is nucleic acid amplification test laboratory. There are multiple technologies now. Erstwhile it was only Gene Expert or CBNAT. Now there are newer tools also that have come in. So that is at the block level. Then at the district level, for those who are resistant to the first line drugs, then the additional investigations we do to look at resistance for the second and third line drugs. So those these are BSL 3 laboratories, and hence requires a very strong infrastructure, and it's a level 4 pathogen that we're dealing with, so it spreads. Even when if you test in the laboratory without a mask, we require an N95 mask and a full gown, so those lab technicians have to take a lot of precautions, and it's a BSL 3 lab, which means there is unidirectional airflow so that the infection doesn't spread outside the lab. So there are a lot of security features in these labs. So these are different types of tests that can happen, and then there is national reference laboratories with the ICMR institutes and Government of India institutes who are the national apex laboratories for that. But basically saying that these are multiple types of laboratories that we have spread across the country, and it is among the largest TB laboratory network that we have in the world, where no country has these many 5,000 plus molecular diagnostic machines. Nobody has 80 odd culture DST laboratories. This is the largest one. Also, we are the highest burden in terms of absolute numbers. In terms of rate per lakh population, we will be around 37th in the world. But in terms of absolute numbers, because of the size of our population, we have the maximum burden, and hence the infrastructure also has been built up to that extent. And like I said, the progress that we have made, you can see the cases with these laboratories and strengthening and all. The blue line is on the estimates of cases, basis the WHO report and the mathematical modeling that we do, and basis that the detection of the program with public and private efforts, we were able to reach almost 24 lakh cases against the estimated 27 lakh cases in 2019. Then came COVID, right? So there was a almost a 25% drop in efforts, and it was natural because of the efforts and the containment measures that was required for COVID. All other programs had to be managed in a different manner. It was not stopped. The existing patients were ensured treatment and diagnosis, but then there was obviously a restriction in population movement, and there was lesser cases that we were able. But now again, post COVID, we have been able to reach and saturate, and this year we may land up even crossing 25 lakh cases against the estimates, and we should be bridging and closing the gap of all cases, which is the first step in the national strategic plan, right? Detect, find all cases. So this is part of that. So have we found all the cases? Yes, almost, not all. There are still cases out there which are not yet detected. But these entire cases, all these things, we have an IT system called Nikshay, Ni and Kshay. So that's again Sanskrit, and everybody knows about it. So that software captures every TB patient's details, be it in the public sector or private sector. All the information is available in that system, right? And when I said public and private sector, so these two lines, if you can see how much of the cases that we get are from the public sector, how much are coming from the private sector. So you'll see that almost 30% of the cases are coming from the private sector now. And if you see the orangish bar on the top side is the private cases that are getting reported. In 2015 we got reported around 1.8 lakh cases, while in the public sector we were getting around 14 lakh cases. Now see the difference. Now we have almost 7.5 lakh cases being reported from the private sector, and the public sector continues to identify the cases there. So we are able to capture every case that is getting notified in the private sector, and there's almost it's 7 times increase. And there were multiple strategies that were deployed with interface agencies, which we call as a patient provider support agency, that an NGO which goes to each and every private practitioner, collects the information, reaches out to the patient and provides these services. So that is because if I tell my peripheral health worker to go and take care of the private sector also, it's sheerly impossible. For the footfalls that we see in the government hospitals, it's all overflowing always, right? So there is an additional manpower required to reach out to the private sector. So there were innovative models tried, and this was the most successful model, where we can see the results with 7 times increase in the private sector cases being reported to us. So there was some of these. I mean, I cannot capture the entire TB program in half an hour, 45 minutes. So some key elements I'll just try to take
My
forward.
government has therefore decided to allocate rupees 600 crores to provide nutritional support to all TB patients at the rate of rupees 500 per month for the duration of their treatment.
Yeah, so this was in 2018 when the Nikshay Poshan Yojana was announced, where we decided to give 500 rupees per month to every TB patient for the duration of treatment, as long as he is on treatment, irrespective of the type of TB, irrespective of whether he is in public sector or private sector, it doesn't matter. The Nikshay system has been enabled to interact with the financial system. The bank account of the patient is entered into Nikshay. The amounts are then entered and then credited directly into the bank account of the patient. So that's how this system works. And over the last few years, since 2018, we have disbursed over 2,500 crores to over 95 lakh individual beneficiaries, at multiple time points over these years, around 25 lakh annual cases, and we have been able to spend so much money into the patients one, and it was meant for nutrition. And that's well known fact that nutrition is among the most important determinant factor for a successful treatment outcome. So that's what we did. In addition to that, to monitor treatment, the ashas and community volunteers who monitor dots for those patients, they also get an incentive of 1,000 rupees for completion of treatment, successful completion of treatment for a drug sensitive case or a drug resistant case. And then there is also something called as an informant incentive. If I find somebody coughing, and I say and I motivate that person to go get tested, and I encourage that person, and that person lands up being diagnosed as TB, I will get rupees 500. So anybody in the community can be an informant, from your neighbors, from your neighborhood, whatever. You can just make sure that you motivate a person to go get tested, and then so this is one of the case finding strategies to improve health seeking behavior and get early case detection. So this is another incentive that was put. In difficult areas, hilly terrains, tribal areas, there is also an additional incentive for the patient for travel support. Around 750 rupees is given for the course of treatment. So these were some of the initiatives for patient support. Now, private sector, like I had said earlier, so it's a very important sector for us. Almost 70% of the population first goes to a private practitioner. If you have cough, cold, fever, zukam, kuch bhi hota hai, we go first to a private practitioner, and then from there, ultimately, if you can't afford further, then you land up in the public sector. So 70% of the population going there, getting diagnosed. And it's the drug sales data, when we look at in the private sector, whatever number we have in the public sector, an equal number of patients are out there seeking care in the private sector. And that is why these numbers are important for us to do, because these patients, if we do not give public health actions, if we do not do contact tracing, they will continue to transmit to another person. Nobody follows up these patients. So if I have money today, I'll take 1 month's medicine. After that, I drop out. Whenever I have some more money, and when I again start coughing, I go back, take another month's medicine. So that complicates the case. It becomes drug resistant, and the outcomes suffer, and at the same time he's transmitting a drug resistant bacteria in the community. So it's important that we take private on board, and hence a lot of challenges that were there in the private sector were addressed when we started doing the innovative private sector interventions. So like I said, so the first point which we did was made TB notification mandatory. So, and of course in 2012 and all, it were executive orders, but in 2018 we came up with a gazette notification with penal provisions for not notifying a case. So if somebody doesn't notify a case, there is section 269 and 270 of the Indian Penal Code, in which there is fine as well as imprisonment for the practitioner if he doesn't notify a case. So this was made, but we also deployed a carrot and stick approach. So this is a stick. If I start mandatory and do enforcement, then people will stop seeing TB cases. They'll say, "Tumi dekho." And if everybody lands up in the government sector, we are not in a physical position to handle all, right? So there is, and we can't influence patient's behavior. Somebody wants to go to a preferred provider, that is the patient's choice. To take care of that, we also started, along with the gazette notification, an incentive to the private provider also. So if he diagnoses and notifies that case to us, then he gets a 500 rupee incentive. And then if he manages the treatment and also reports treatment outcomes to us, he gets another 500 rupees incentive. So this kind of carrot and stick approach was deployed in the private sector. And again, the TB drugs that we have are Schedule H1 drugs. So it's a class of drugs which cannot be given over the counter. It needs a prescription from a medical practitioner. And that is the reason the chemist who can sell these drugs have to keep a Schedule H1 register, where they have to record the name of the patient, the name of the provider, and keep a copy of the prescription. So that is a mandatory requirement under the Drugs and Cosmetics Act. And so that also helped, and we strengthened the monitoring of this. So that also helped to find out who is prescribing, and we could then reach out to that private practitioner who has given a prescription and say, please notify, you'll get an incentive. If you don't notify, you also have penal provisions. So that's how we got the private practitioners and the entire sector on board. And of course, like we are now working with Ayurveda and the institute, similarly with all the other professional associations in allopathy, be the Indian Medical Association, Association of Pediatrics, all all the professional bodies, because TB can occur in any part of the body. Can anybody tell me where TB cannot occur in our body? Can any part of the body not have TB? Stomach. Stomach TB तो होता है. Yes, abdominal TB is there. Anything else? Huh? Bone TB is also there. Yes. सुनाई नहीं दे रहा. Sorry, if you can tell again. सब में होता है, किस में नहीं होता है? क्वेश्चन इज कहाँ नहीं होता है टीबी? नेल्स एंड हेयर. किडनी में भी होता है मैम. यस, इट इज नेल, हेयर एंड टीथ. वाई? इन तीनों में क्यों नहीं होता है? These are dead tissues. So everything that is living, the bacteria will catch you. Right? It is as simple as that. It is the most, I would say the strongest bacteria that has survived everything. From nuclear disasters to Holocaust, it has survived everything. And this bacteria continues to be resistant, modifies itself when we come up with new drugs, it will again, find its own strategy to survive. So it's a very, very difficult bacteria to reach it. But having said that, so there is not just pediatricians or gynecologists, all specialties. So we have to interact with all the professional bodies, be it radiologists, orthopedicians, surgeons, all, everybody who is doing medicine will find a TB case at some point of his time in the country. So we work with all of them, we aggregated them. There's also association of associations, all those things we made, sensitize them. Through them we reach out to the private practitioners and do that. And to also reach out to them, like I said, the interface agencies, there are over 300 such NGOs across the country who now, as part of the program, go collect this information to the private practitioner, get that reported into Nikshay, enables the incentives to be provisioned, goes and provides the public health actions to the patients, and we could see a 7 times increase in the numbers. Now the second initiative of importance which I wanted to share with you all is the patients and the community's involvement. So what we've done is that it is such a long duration of treatment. Ourselves, if we take 5 days of antibiotics, I drop out after 3 days when the cough starts coming down. Myself, I'm still coughing, I'm not taking antibiotic at all, right? So the challenge for a long duration of treatment is that it requires a lot of counseling, a lot of patient support, and that's where we then identified some TB survivors who have successfully come out of tuberculosis, build their capacity and to act as peer counselors. We call them as TB Vijetas. So they then go and counsel these patients who have a challenge in continuation of treatment, who drop out frequently, or who have a difficult phase in the house, mother-in-law does not want to know, or there are so many stigma issues that we face as a patient in the community. To provide that support, these TB Vijetas or TB champions that we call, so we have built this network over 56,000, almost I think 80,000 of such TB Vijetas are there, and they they support the patients across this. Also, the ASHA and the network that I said, these are community. So it's not that it's only the government system who can be erstwhile we used to call as dot provider, but now we call them as treatment supporters. And it could be anybody in the community. It could be a teacher, it could be a chemist shop owner, it could be a family member who can take care of his own patient. So anybody who can take care of another patient can become a treatment supporter. So we have over 5 lakh of such people handling, roughly at any given point of time, we have 25 lakh cases in the year. So half of them are on treatment, because half of them will complete treatment in the year. So we have around 14 lakh patients, and one ASHA or one community person takes care of 2 or 3 patients. So we have over 5 lakh such treatment supporters. We also introduced, I'll have another slide on that, but it's the Pradhan Mantri TB Mukt Bharat Abhiyan, where we encourage the community to come forward and adopt one patient, and we call that donor as a Nikshay Mitra, and to provide this additional support that is required beyond drugs and diagnostics and what we provide under the program. So this was launched last September, and we have over 1 lakh Nikshay Mitras who have come forward to support almost 10 lakh current patients who are on treatment. Family caregiver also I spoke about. So anybody in the household we identify, so that the support that is required for the patient to complete his long duration of treatment is provided within the household. So these are some newer elements which we have tried in the last couple of years to improve the patient's experience, help him have a successful treatment outcome. This is the initiative I was talking about, which was launched on 9th September by Honorable President of India, and just over a year now, we have over currently around 14 lakh patients who are on treatment. Of that, because this is voluntary, so we seek the patient's consent. Do you want to be adopted by somebody who can provide you additional support? So around 10 lakh of the patients have consented, and we have over 1 lakh Nikshay Mitras who have come forward to commit to these patients. Almost every patient now has some Nikshay Mitra associated with him who provides him with additional. We give 500 rupees as DBT. This Nikshay Mitra gives him a food basket in kind. So he gives the raw materials. Basis the guidance that we have given, it will have proteins, carbohydrates, and other nutrient elements as required for a TB patient's additional nutrition. So that food basket is designed at the district level, because the food culture is going to be different in every district of the country. So they design the food basket, find a donor. Roughly around 600-700 rupees per month for one patient is the food basket's cost that we find in the way. So that donor gives that money, buys that. We don't get in between, we don't collect the money. They only buy, they give that, we link the patient and the Nikshay Mitra with each other, and then they provide that support. Some places where there are corporates or industries, so they adopt 1,000 patients or something like that, then that comes to the district TB center, and there they either find an NGO or somebody who can then get this, enable this, and deliver to the patients. So this is this initiative which has been done. This is the food basket. This is with the National Institute of Nutrition, Hyderabad. We have designed this food basket. It's an ICMR institute, and this is the minimum requirement for a patient who is suffering from active tuberculosis. 3 kgs of cereals or millets, 1.5 kg of pulses, so 250 ml of vegetable oil, groundnut or milk, or if non-veg, then yes, 1 egg a day, and some vegetables, fruits. So this is the kind of minimum requirement for one TB patient to be able to successfully come out of his treatment and have the weight gain that is required to be TB free. Coming from the patient, now a little bit of epidemiology, and as we do in public health. So we have a target of 80% reduction from 2015 to today. So where are we today? Is Kerala, Bihar, Himachal, Assam all at the same level? 196 per lakh population, I said, is it the same across the country? No, it cannot be, right? So the burden of tuberculosis is directly related to the population density. It is also directly related to the health of the population, right? So the health seeking behavior of the population, the health of the population. So we did a prevalence survey, which I said in 2018 2020, and that indicated we got state level prevalence also, right? So it showed a range of 135 per lakh population in in Gujarat and Kerala. Kerala and Gujarat was also lower, West Bengal was lower, but we also had Delhi with almost 700 per lakh population, Chhattisgarh with 400, 500, Bihar with 500 per lakh population, UP more than 400 per lakh population. So in average it comes to 196, but we have all extremes in terms of burden. So the challenge for the states was how do I understand how much of SDG have I achieved? So to push the state and also to incentivize them, what we did is we of course came up with a scientific methodology which we call as an inverse sampling methodology to find out burden at the district level. In short, if you want to understand that methodology, it is going house to house, trying to find a fixed number. Considering the burden of the country, we fix that number as 30. This is based on statistics. And to find 30 cases of TB, how much population should I screen? I'll end up screening, going testing till I find the 30th case. And basis that, then we in biostatistics calculate the burden for that district. That's in a very crude manner the methodology that we do, and by doing that we know where the district is today, where was it earlier, basis the statistics extrapolation into previous years. So we said 80% reduction in incidence is the SDG targets. So for every 20% reduction, we give an incentive to the states. So if the state reduces by 20%, state or district, we give an incentive of there's money also along with this. Apart from a certificate, last year in World TB Day, Honorable Prime Minister distributed awards to the states which had a 40%, 30% or 20% plus reductions. The state level awards was given by Honorable Prime Minister. So like that, there is, I mean, of course there is no need for money for that. Anybody would love to have, as a state come and receive an award from the Prime Minister. But apart from that, there is also financial incentives that we give to this, and we could see over the years, for every 20% fall. So we have Lakshadweep, which was already SDG levels in the first year itself in 2020. We could do that. And then we had Kerala, Diu, Daman, Dadra Nagar Haveli, Puducherry in over 40% reduction, and we have Gujarat, Himachal, Sikkim, Tripura, Ladakh, big places also. Himachal, Gujarat are big population districts, and there also we have seen significant reduction. So this variance is something which we were able to scientifically document also. At the same time, the states and districts now are in a competition with each other. Every year they give in claims and says, now I have done this much, now I have done this much, now you measure and give me an award, that type. So that's a very intensive exercise, but very satisfactory exercise for the states and districts. Coming to this preventive treatment for today, so latent TB, along with the prevalence survey which we did in 2020, apart from the burden of active TB disease, we also tried to find out how much of latent TB do we have, because very few literatures, very old literatures were available. So what we found out that nationally we had latent TB to the level of 31%, which means that of the 100 people here, 30 people have latent TB in us, right? 1 in 3 basically, right? So that is the burden which is waiting to break down to TB tomorrow if we do not do preventive treatment or do not build the immunity of the individual to prevent him from breaking down to TB, right? So there are two types of interventions that can be done. One, the drugs, chemotherapy that is available, that can be given, and that will prevent him from breaking down to TB for a certain period of time. We have to repeat that drug after 2 years, right? 2 years, 3 years. It's a newer intervention, so we are still compiling evidences on that front as to when to repeat it, but it is preventing, that is for sure. There were erstwhile regimens of INH as a single dose was given, but now we have newer drugs called INH and rifapentin as a combination, and that is given, which is given once a week, and it can be given for 3 months, and that will prevent breakdown of TB. So these newer ones, regimens have been introduced. The country has adopted, because it is 31%. Do I give TPT to all the 100 contacts that I have? Right? So 3/4 of the population will unnecessarily receive the drug even if they don't have the bacteria. So the policy that has been adopted is test and treat. First test, find out if there is latent TB. If yes, only then put him on treatment. Otherwise, maintain his immunity, and advise him for like we do for COVID appropriate behavior, household preventive behaviors for that person, and make sure that the index case is on treatment so that he doesn't transmit again. So we have done this. The testing can be done through, initially there was one skin test called the tuberculin skin test, that is now quite old, outdated, unstandardized. So there is a newer skin test that has been licensed by the drug regulators. It's called the CyTB, CYTB, and that is similar to that skin test only, and it gives us difference between latent infection and an active infection, right? And also there is another blood test called IGRA, which also can detect if there is latent tuberculosis. So these two, but whenever we detect latent TB, we have to rule out active TB, for which we once again have to check with the physician, get an X-ray done, clinically examine the patient to make sure that there is no active tuberculosis, and then put him on preventive treatment. The reason is preventive treatment is not 4 drugs, it is only 1 drug or 2 drugs. So we don't want to trigger mutation, and if there is active multiplication of bacteria, then the bacteria will enjoy. 1 drug resistance, 2nd drug resistance, So to prevent that, we first rule out active TB and then put the patient on preventive treatment. But X-ray is an important tool in this, and you'll see that over the years, suddenly last year, we have started putting a lot of people on preventive treatment with this newer interventions that were launched. this is, I mean, the journey of how, the newer evidences for TB preventive treatment came in. The national guidelines called programmatic management of TB preventive treatment has been developed. I will encourage all of you all to have a look. It's in our website. That will help you do that. And then we introduce the newer regimens, these guidelines, and then scaled up. The new drugs have been procured, so they are out there in the states, and this is now expanding across the country. And we will, that's the next 2 years strategy for us, in terms of prevention, because this tap is open. If this latent TB is not controlled, new cases will keep on occurring. And the first policy of test and detect and treat, so we will keep on detecting, but we are not done enough to prevent a person from breaking down to TB. That's where these efforts are going to make an impact on us. And IT system I have already spoken, but we have Nikshay as a tool, which is in a mobile app for the patient, for the staff, for the private practitioner. Everybody has their interface where they are able to perform their affairs, and the entire patient, from right from his first step of testing to his entire treatment journey and completion of treatment and post treatment follow up, everything is recorded in the same IT system. This is the cascade of care. Like I said, some numbers of how many patients have been tested, how many are on treatment, how many have done 1 month, 2 months, 3 months, how many we have been given DBT, how many HIV testing has been done, how many diabetes is done. All this entire cascade we are able to view from this only one single system. The multi-sectoral, this is another new initiative which we launched last March, is the TB free Gram Panchayat. So like I said, the subnational certification which we did for districts, for 20% fall which we did. Now district is also huge. We have districts in West Bengal which has 90 lakh population, 1 crore population district, right? And we have districts with, even in Arunachal, a district is there with only 5,000 population. Right, so that is the extent. So the bottommost unit for next intervention or next level of surveillance is the panchayats. And at the panchayat level, where there is a group of villages for a population of say 1,000 to 2,000 is generally what we have, and we have over 2.5 lakh panchayats across the country. And to involve them at the panchayat level, there will be 1 or 2 cases. This burden which we spoke of, 196 per lakh population, will translate to 1 or 2 case in a panchayat in the year. That is the burden that we have at a panchayat level. And if we get the panchayat to own this program and make sure that these 2 patients, one, we test whoever is required, getting them, so we give them a benchmark of 30 tests in a year for 1,000 population. So if you have a 2,000 population panchayat, you need to test 60 per year. So that type of small process indicator targets have been given, and through them we are monitoring their performance and even incentivizing them. And that, of course, when the panchayat starts taking ownership, then they make sure that drugs are available, they make sure Nikshay Mitra is there, they make sure nutrition is given to the patient, and they make sure that the patient completes treatment successfully. Health and wellness centers, I think I have already spoken in terms of the services that we do through the health and wellness centers. Multi-sectoral also with other line departments, like I said, because TB is also having a lot of social determinants, we need to work with all of them. So we have multiple MOUs with multiple line departments. We have a national interministerial task force, and then multiple departments, be it education to industries, Ayush, and there's Ayush was among the first MOUs that we had, where we knew that it's important to take care of the healthcare sector first. So all those line ministries which had their own health force, we interacted with them first. And there's one new thing coming up. This is just for information, that we will be also trying to give a booster for a BCG vaccination. Our country, we have a 0 dose policy, right? We give BCG at birth, and that prevents tuberculosis in early childhood only. It has limited protection for up to 10 years. After that, the protection wanes off, and the person, once he starts going to schools, colleges, and starts working in the community, gets exposed to the bacteria, and then latent infection happens, and then breakdown when the immunity goes down. So this is something which we are trying to do on a study mode in certain parts of the country, where we have identified from the prevalence survey who gets TB. So there were 6 categories that we identified that account for almost 80% of the new cases that occur. Right? So one was the elderly, above 60 population. Second was those people who had a low BMI of less than 18. Third was those who had a contact of TB or a history of TB in the last 2 years, and those with diabetes and having a tobacco or a smoking history. So these 6 categories, we are trying to give them a booster dose of adult BCG vaccination and see how it helps us, right? Because this preventive treatment and all these things which I said will still give prevention for maybe around 10%. It will have an overall public health or epidemiological impact of around 10% reduction in new cases in the next year. If I do vaccination, the BCG vaccination has an efficacy of around 46%, and but it is in children, and we try it in adults and in identified populations. We hope that we will be able to have at least a 2-digit decline in incidence than what we are currently doing. So that will help us accelerate our decline. Now we said we reduced by 18%. How are we going to reduce to 80% in the next 2 years? Right? So this is the last available bullet that we are also firing, and making sure that the entire community is with us. Nutrition and latent TB and vaccination. These are the 3 preventive efforts that we are going full scale in the next 2 years to try and achieve our SDG goals. I think I've spoken of all these things that we have, and thank you all for this opportunity, and happy to answer questions. Thank you.
Earlier strategy was that once the patient is detected, we bring to our center and start treatment. But because of the drug resistance and all kind of things, many patients were not giving the positive response. So, did you modify this approach that before the treatment starts, we should have a culture kind of thing to find out which one would be more sensitive?
Yeah, so that is the NAT technology that I said, molecular diagnostics. So on diagnosis itself, the sample is subjected to molecular diagnostics. The molecular diagnostic machine that we currently have is TrueNat or CBNat. Through that, we test for rifampicin resistance also. Apart from TB, rifampicin resistance. That is the first line of drug. If resistant to rifampicin, then the sample is then subjected to first line, second line LPA, line probe assay. That's the next level of investigation to look for resistance to INH and to fluoroquinolones, the second line drugs. If resistant over there, then it undergoes a full drug sensitivity test for all the remaining drugs. This entire thing takes around a month, for the culture to grow and the results to come. But as soon as diagnosed, if he is resistant, is put on an MDR treatment regimen, and if sensitive, only then. So 96% of our patients are drug sensitive, and this is what policy which we call as universal DST, which means at the time of diagnosis itself, try to find out if he is drug resistant or no. So that has changed now, sir. Yeah.
Any other questions?
ये तो टोटल बाउंसर, कुछ नहीं समझ में आया.
सर ये जो निक्षय वॉलंटियर का बताया ना, तो ये जनरल पब्लिक ही बन सकते हैं, कोई भी बन सकता है?
Anybody can be a
तो
निक्षय
गवर्नमेंट
मित्र.
सर्वेंट्स हम लोग भी?
बिल्कुल बन सकते हैं.
अच्छा, अच्छा.
It is a common portal. Just go there.
अच्छा,
In the TBC India website also, you can just go. You just write Nikshay Mitra in Google. That site will come. Click on it. Register yourself. That site gives you 3 tabs. Okay. In one tab you can see where how many patients are there in which geography. So you want to say, I'm assuming you are from Kerala, and the state that you want to choose. You want to support somebody in Wayanad, for example. So in Wayanad, how many cases are on treatment you want to see? You can go through that site, and you can also see whether he is already adopted or no. Okay, and then you register yourself by just giving your basic details of your name, address, mobile, email ID. The information goes to the district TB officer. They will then reach out to you and say, madam, you had registered, are you willing to adopt a patient? Then you say, okay, 1 patient, 2 patient, 3 patient. They will tell you the food basket, how much it costs, and then if both offline agreement happens, Then on the portal they will link you to those patients, and then the list of those patients comes to you, and you can give the food support to them. You can meet the patient, interact with them. The prior consent of the patient has already been taken by the district. So in the display you will only see the numbers, not the individuals' names in the portal site. But anybody can become a Nikshay Mitra. Yeah.
Further questions?
Hello, sir. How can we notify TB patient from our health facility, and to whom?
Yeah. So one is that there are if I talk of Ayurvedic professionals, so there are some states where Ayurvedic professionals are legally registered to even prescribe national program drugs. So then you can yourself register yourself as a health provider in Nikshay, identify the case, enter the patient details, and notify that case. On the basis of diagnosis, get an X-ray or a molecular test or a sputomicroscopy done, enter the patient's name, address, details, and notify that case. In case this is not permitted in the state where you're practicing, then you have to enroll yourself in Nikshay as a informant, right? And the case you enroll as a presumptive, I have one person who is presumptive, probably has TB, these are the symptoms, whatever, patient profile, and then you refer it. You can choose the test center. So you refer it in the drop down only, you will see the nearest test center which you want to refer it to that center. That test center is public facility. They'll test it, give the report, and then the patient will be prescribed, diagnosed there. Patient can also go there, or you can have your local linkage with that. But what you should do is reach out to your district TB officer, or at the block level there is somebody called as a senior treatment supervisor. Now these are those functionaries whose job is outreach, reaching out to the private practitioners, reaching out to the patients, and linking both these things. So they will tell that. So you just have to then directly in the system itself enroll, register, transfer the patient for a test into the laboratory, diagnose it, and the patient can continue with the doctor over there. So you can be a treatment provider yourself. The drugs are prescribed over there, it will come to you, the box is there, you do daily dispensation, and you can also do the follow-up investigations, and as per the guidelines that is there for treatment management, do that. The incentives also come to you. As a private practitioner, you can also get the informant incentive of 500 rupees, which I said earlier. Those will come. You can become a treatment supporter. Then for that case, you can again get another 1,000 rupees as a treatment supporter. If it's a drug resistant case, it can go as high as 5,000 rupees. So all this, it's just the entry point, basically, where once you get into the system, then easily it can be taken care of. Even a private practitioner, there are Ayurvedics will also be private practitioners. They also can be similarly, part of this exercise.
Detection or due to immunity factor, because public is aware of immunity, he is taking so much of
suddenly because of
diet
COVID, suddenly because of COVID, public was I would say not aware of their immunity. What happened in 2020 was in March there was a lockdown, and on 24th of March, which was World TB Day, incidentally, and there was a lockdown, and that lockdown extended till May, right? So there was total public movement restricted. So the people could not come to the health facility, and there was surveillance for cough. So there was also fear of getting COVID, which prevented somebody from going and seeking health care. They were restricting themselves to the household. But TB as is will remain in the house, and it cannot be hidden for long. Then they will have to come out and then seek care and then diagnose. So there was only a dip in case detection. Cases were there in the community. The detection, getting tested, putting them on treatment, reporting, entering into Nikshay, there was a dip over there. But in terms of epidemiology, in terms of transmission, now because one person is restricted in the household, the transmission is to the household members max. Otherwise, the probability or the chances of an infectious case, if he is not on treatment, to transmit is around 10 people in the community in a year, by the time he's put on treatment. So that broke down by half because people were restricted to the household average size was 3 to 4 per, so there was reduction in transmission. There was a spike reduction in transmission, and then but when people started coming out, again it came back to normal. So the incidence of TB, when this case detection came down, incidence went up, new cases went up, but then later on again it slowly starts. It took almost 2 years to start the decline in the incidence of TB. Detection is different than incidence. Huh? Yeah.
Sir, how will you differentiate, diagnose the case that it is latent, whether then would it be clinical parameters or any objective parameters?
There is investigations which I said, no, the tuberculin skin test, the Cy-TB test, which is the new test, and IGRA. These are the tests. If we do that, that will differentiate between latent TB and active TB, and also an X-ray to rule out extrapulmonary or shadows. So clinical judgment has to be taken on whether there is active TB or no. Good. Based on the diagnosis, you should ensure that he is on anti-tubercular treatment and any additional Ayurveda treatment. But if you want to do something like this, must be on a trial mode in a clinical setting, in a research setting if you want to do. But as an Ayurvedic practitioner, if you find that somebody has TB, then he should be given anti-tubercular treatment. That is a mandatory requirement.
So apart from that, the role of Ayurveda in treating the different conditions of the tuberculosis. So
the additives
people are having the hepatotoxicity.
Exactly. So
people
all the
are coming
additives
to
can
us
be done.
and they are referring, and the doctors are referring the patients to Ayurvedic OPDs.
Yes.
We have been treating.
Yes.
So at the same time, the patient is taking the anti-tubercular drugs, and the person is taking Ayurvedic medicine also. How it is possible to take both the medicines at a time?
So when there is some adverse event for which the TB drug, then it is briefly stopped, and then the there's a protocol for reintroducing the drug when the adverse event is controlled. Hepatitis is one of the adverse events. There could be many other adverse events that happen. Although with the newer regimens that have come in, the adverse events have dropped down dramatically. But hepatitis is among the most common ones which will come. And if there is hepatitis, treatment is interrupted for the duration of hepatitis once that is managed, and then the anti-tubercular drugs are reintroduced. But it requires a working relationship between the physician and the Ayurvedic practitioner to make sure that both work simultaneously. But without anti-tubercular treatment, as of now, we do not have any evidence to say that the patient will get cured, and he will come back to us. Almost 25% of the patients who come with TB come with a past history of TB or a history of contact, right? So it is as high as that where a person comes back with TB, and hence the push to make sure that the intensive phase and the continuation phase, the duration of treatment, patient completes in full, and there is full attempt to get a microbiological sample at the end to find that there is no more bacteria left. So that is how the protocol is as of now.
What is the role of treatment?
There again, both diabetic treatment and tuberculosis treatment have to be done. And in fact, I think I did not mention this, but comorbidities are very, very important in tuberculosis. Now, on average, when I said treatment success rate of 90%, the mortality rate that we see is around 4%. Of the 20-25 lakh cases that we put, 4% die. Now, of this 4%, when I do some detailed analysis, what I find is that if somebody has TB and HIV, somebody has TB and diabetes, the chances of mortality is 3 times higher. And hence it is very important that the comorbidity is also managed along with tuberculosis. Hence, adequate sugar control or diabetic control, adequate or patient put on ART so that the viral load is suppressed. All those things are important, and hence as a part of program, mandatorily testing for HIV, diabetes, tobacco, so that take history of tobacco and try to de-addict him, and alcohol. Both are something that we are strongly advocating, because the chances of death is very, very high among these cases. But both have to be managed. Simultaneous treatment happens. There is no reason for stopping anti-diabetic treatment.
I think it gives also a lead that if anti-tubercular treatment is going on, and whatever probable side effects are, if they can be managed by Ayurveda, it will be really an addition in the program, because the patient can have a better tolerance and sorry. No, what you are prescribing is not anti-tubercular, but you are prescribing something the outcome of anti-tubercular treatment and to manage those side effects.
We are doing something like Santarpana Chikitsa. So at that time, so these medicines reference in all these are Santarpana in nature, and we are doing Santarpana. What is the advantage? Nothing is advantage.
No, but program says anti-tubercular treatment has to be
That is why I said, as with the current level of evidence that we have,
It's a penal action involved now.
yeah, with the current level of evidence that we have, anti-tubercular drug is required for managing tuberculosis. In Ayurveda, there is a lot of research going on, and Madam will also appraise.
We would like to address that Ministry of Ayush, Government of India is doing much research in these cases. So where Ayurveda can applicable along with the DTT, and what are our scope when we have to refer the patient, what are our limitations. We are doing so much in this area, and along with Ministry of Health and Family Welfare. So sir is there to make you understand that what is the role of ATT, where we have to, what are our limitation, but we are still having so much scope in the future. So because sir, most of the patient coming to us are having ATT once in a time, once in their lifetime, but still they are positive with ISRA or a skin test. So what is, at that time, what we have to do?
Yeah, see, like I said earlier, the chances of somebody who has had TB once, his probability of having TB again is very high. He's a very clear case of getting a relapse or a reinfection, and for that it is screening again. Even if he's skin test positive, you have to once again get and rule out active TB. Because he will definitely get TB, and if he has active TB, he needs full treatment and not just preventive treatment.
Sir, basically what happens to us, that most of the patient who are positive skin test, there is a raised IgE level and vitamin D is suddenly very reduced level. So these are the confounder. So we are not considering only TFT, means skin test for diagnosing the latent tuberculosis. So what other test we can use in our practice?
Yeah. So there is IGRA test, which is immunoglobulin, finding that, and then there is a new skin test called SciTB. It's just licensed just a year back by the drug regulators, and that is similar to skin test, and TST trial that we had. Again here with a small patch and 5 millimeter in duration is to be measured. If it is more than 5, it is active, latent TB infection positive, and then the preventive treatment for that has to be given. But ruling out active TB, and in that clinician's opinion and an X-ray. These two have to be ensured before we put him on preventive treatment.
Sir, I do have a question. Sir, most of the time we found that the patient is our DNA PCR negative, but then also they have sputum positive. So what is it that means?
So what happens is, the molecular diagnostics also detect dead bacilli. So the microscopy that we do, we are viewing bacilli which is picking up the stain, but it can also pick artifacts, and you'll have some small percentage where there could be false positives. That's where the clinical opinions, the physician's judgment comes into picture, and the even for follow-ups and all, we don't recommend NAT again, because it will pick up anything that is there. Even if it is dead or alive, it will pick up. So the follow-up investigations all again, once again, microscopy, where you are able to see a live bacteria in a microscope. That's what is recommended.
One more question from my side, because what happens after taking ATT for the preventive treatment in the latent tuberculosis, we never done again ISRA. So most of the time the patient came to us and says that our consultant had told us that we don't have to do this test again, and the patient, if again screened for the ISRA, then it again came to the positive.
It will come positive only.
So how will you detect, how will you diagnose that the patient is free from the latent tuberculosis?
No. So like I said again, that there is still not much of evidence to say when to repeat preventive treatment. Okay, the current evidence says that if he is positive, put him on treatment. It gives what evidence research says is that gives a protection of 2 years, and once again after that you will have to put him on preventive treatment unless his exposure has come down. If he continues to be in an environment like where we are and has getting exposed to the bacteria, he again has to be put on preventive treatment. That is there. But the IGRA will always come. It's an immunoglobulin, it will catch it. That will always be positive. So that's where the clinician's skills and clinical judgment is what tuberculosis, like I said earlier, is a very, very difficult disease to diagnose and manage. And the bacteria is the smartest in the room. You know? Yeah. So,
Sir, earlier you said that there is a recurrence of TB. Uh, we are using bacteria since I think bacteriostatic bacterial. Why of recurrence? And if there is a resistance patient and we are giving the newer medicine, then there is a chances of recurrence or not?
there will always be a chance of recurrence is because the latent bacteria, but after treatment I am not able to stop him from getting exposed to a bacteria again, because he is living in the same community. He may get it again, and the bacteria can remain dormant in the body for the lifetime, but it will not reactivate unless the immunity of the body is stronger than the bacteria. So there is always, so there are two things there: one, reinfection, and second is reactivation of the existing dormant bacteria. Both can occur, and the probability for somebody who has already had active disease, his chances of recurrence is very high. So that is almost 25%. Like I said, he can land up with tuberculosis again, disease.
Sir, still we are using these medicines.
Yeah.
I think.
Bactericidal,
Why there is a
bacteriostatic, both.
reactivation?
Reactivation will happen because these bacteriostatic conditions also, there will still be some elements of bacteria that can stay dormant, and the drugs that we give is, the bioavailability of the drug depending on the body weight that we give, and the duration of treatment, missing doses in all these things, can have an effect. And it's not necessary that the new bacteria cannot come in. The old bacteria, that is, bacteriostatic and bactericidal, then even then the remnants of the bacteria will remain in the body and can reactivate. The Ghon's complex is there for lifetime. It is not going to go, right? So that trigger is there in our body.
Okay.
It will always multiply when my immunity goes down.
Once he has completed the treatment, after since there is chances of recurrence and they are the main source of infection in the community again.
Correct.
So for how much long they are taken care of by
So there is, for
tuberculosis cell?
2 years after treatment, every 6 months a follow-up needs to be done, for 2 years. And this is because the cases of recurrence or relapse that have occurred, more than 90% of the recurrence happens within the first 2 years. So that is the period when maximum recurrence, if it has to happen, will happen in the next 2 years. So that is the period of follow-up that needs to be monitored.
So any nutritional program should be given to that patient for 2 years, because that is a
Ideally,
chance.
yes.
There is no
No, as a
provision in
program
that
we are not
actually.
giving. We are giving only for the duration of treatment.
But that should
as
be continued up to 2 years then.
the nutrition should be there forever, because his risk of breaking
that's
down
fine.
to TB will come down again, right?
But as we have
As
to
a
take
program,
care of
I think
them
advise
also.
minimum 2 years you should maintain your nutrition and your body weight should not come down. We should do that. As a program, we are giving DBT only for the duration of treatment. Ideally, a lot of things should be part of the program, but there is always limitation, and that is where this Nikshay Mitra and these things. So they give in addition, right? So that community support and all those things. Program will have its limitations, and we will be able to give support to those who come to the program. There are half of the cases will be in the private, and we just have the numbers. They may not come for follow up with us. They will be in follow up with the private practitioner only. So there's a lot of requirements for the expansion of this program, which is happening as of now. And roughly, I think we have a budget of around 3,300 crores, for the entire country for the TB program. And around 5 years back, we had around 1100, 1200 crores only. So the investment in this program has almost increased 3 times in the last 5 years, and it is only increasing. So we are expanding, but still the sky is the limit, because the need for the patient is too much, and it requires everybody's support in coming out of it.
So, if the patient is suffering from CKD and because of steroid therapy, he will become diabetic, and if he catches this tuberculosis, then what will be the regime?
Treatment regimen for TB will be the same,
not
but
the treatment regime. I am talking about the nutrition, because where protein is restricted and here protein is needed. Then how
yeah,
can we balance?
no, CKD is a complicated case, and for them, that is why there is preventive treatment. It's one of the categories where we rule out active TB and give preventive treatment, even before, so that it doesn't become TB again.
Yeah.
And there again, nutrition, of course, in the CKD will require a CKD diet only, and with that, nutrition is basically the nutritional requirement for a TB patient is for him to be able to digest the treatment and prevent the bacteria from multiplying so that the drugs are able to act, right? And the body weight needs to improve. But when there is CKD, then obviously the individual's capacity is totally compromised and any diet will not work for him, or be it for a diabetic patient. So a diabetic diet or a CKD diet will have to be given. The job is to monitor that the weight gain or there is no weight loss, and when he is put on preventive treatment, or we detect TB as early as possible in
Is
that.
it, as you show the chart of that key, that's this carbohydrate, that's protein.
That's an
and
ideal one for
then
generic.
anything is recommended, anything is.
There are recommendations for a CKD diet. There is recommendation for a
This for CKD diet or for tuberculosis?
not. There's nothing for a CKD TB combination diet.
Okay, that is.
No, there is a diabetic diet. There is a CKD diet. There is a normal TB diet. Like that. There's no combination like that.
Combination of CKD, because there are number of patients
Yeah,
who
yeah,
are
yeah.
CKD.
We take your point back. I think we should make one. Yeah.
Any further questions?
Sir, from audience side, I would like to ask a question. What is the prevalence of the complications after taking ATT? Such, say for example, what is the prevalence of having consolidation, collapse, like these fibrosis,
Yeah.
even after taking?
Yeah,
How much
yeah,
patient
yeah,
of
yeah.
them? Sir?
That is also there. It's called post TB sequelae, and the almost 15 to 20% of the patients have some sequelae or the other. They get into COPD, they have bronchiectasis, or compromised lung fibrosis, and some of these are irreversible fibrosis and such kinds of things. But if you manage this happens more when there is drug resistance and fulminant TB, right? And so that is why early detection, managing the drug sensitive case well, is extremely important, and making sure that the treatment adherence is good so that they don't land up over there. So there is what is called as pulmonary rehabilitation post the TB treatment that needs to be done, which is chest physiotherapy, breathing exercises, yoga. All those things are advised in the wellness component at the health and wellness center, so that the post TB sequelae is handled to there. But there would be advanced interventions for pulmonary corrections required in case it becomes too complicated, like a lung resection, or handling all those things. Surgical interventions come in very few % of the cases. But yes, that is a complication that will happen in 5-10% of the population.
Further more questions?
Sure. Thank you so much. Thank you.
Dr. Rao, sir, your insightful presentation on the National Tuberculosis Elimination Program and various schemes under the Ministry of Health and Family Welfare has been truly enlightening. Your depth of knowledge, clarity in explaining complex initiatives, and your pivotal role in driving key portfolios within the NTEP have left an indelible mark on our understanding.
Your dedication to the cause of eliminating tuberculosis in India, along with your expertise in integrating innovative technologies like artificial intelligence, has set a remarkable example for all of us. The comprehensive overview you provided, coupled with your practical insights, has enriched our collective understanding of the ongoing efforts in the fight against tuberculosis. Thank you, sir.
Now, I invite our esteemed speaker, Dr. Rao, sir, Dean PG Studies, Dr. Anand More, sir, and HOD Kai Chikitsa, Dr. Jonah S, sir, to felicitate our esteemed speaker. Thank you, sir. Now we'll take a short 15 minutes break for high tea. All the participants and the faculty, please proceed on 6th floor for high tea. And please join the session after 15 minutes. We'll proceed further. प्राची कुछ बोल रहा है क्या? प्राची
Good morning. A very warm welcome to all of you to the training program on latent tuberculosis infection in an Indian population.
This workshop serves as a platform for experts, researchers, and practitioners to share their knowledge, experiences, and innovative solutions in addressing latent tuberculosis. Our esteemed guests are a vital part of this collaborative effort, and your presence adds immense value to the exchange of ideas and expertise that will transpire over the course of this event.
Today, we are gathered here to inaugurate this training program. In 2 days, we have a packed schedule of very informative and insightful session. So, without further delay, let's begin with the inauguration ceremony.
I would like to invite all the dignitaries on the dais, Professor Dr. Tanuja Nesri ma'am, our guest of honor, Dr. Raghu Arakkal sir, Dr. Raghuram Rao sir, Dean PhD, Professor Dr. Mahesh Vyas sir, and Dean PhD, Dr. Anand More sir.
Please join with me in welcoming them with the big round of applause. Now we are going to start this program with Dhanvantari Vandana. I would like to request all the dignitaries to come forward for lamp lighting and Dhanvantari Vandana.
Yes, sir. जी जी वो रही मैम आ गई।
ओम श्री गणेशाय नमः। नमामि धन्वन्तरिम् आदिदेवं सुरासुरैः वन्दितपादपद्मम् लोके जरारुक् भयमृत्युनाशं धातारमीशं विविधौषधीनां शङ्खं चक्रं जलौकां ददतमृतघटं चारुदोर्भिश्चतुर्भिः सूक्ष्मस्वच्छातिरुद्यं शुकपरिविलसन् मौलिमं भोजनेत्रं कालाम्भोदोज्ज्वलाङ्गं कटितटविलसश्चारु पीताम्बराढ्यं वन्दे धन्वन्तरिं तं निखिलगदमिव प्रौढदावाग्नि नीलम्।
Moving forward, I would like to request our respected director, Professor Dr. Tanuja Nesri ma'am, to welcome our guest of honor, Dr. Raghu Arakkal sir, Deputy Advisor, Ministry of Ayush. Ma'am, please. and Dr. Raghuram Rao, sir, Assistant Director General, Ministry of Health and Family Welfare.
Now, I would like to request Head of Department, respected Dr. Jonah sir, for the floral welcome of Honorable Director, Professor Dr. Tanuja Nisri ma'am.
I would like to request Dr. V.G. Hudar, sir, to welcome our Dean PG, Dr. Anand More, sir. Dr. Divya ma'am, please join.
Now, I would like to invite Head of the Department, Kai Chikitsa Department, respected Dr. Jonah sir, for the welcome address and share his insight into the importance of today's program on orientation program on latent tuberculosis.
Respected Director Ma'am, Raghuram sir, Raghu sir, Dean PG, Anand More sir, Divya, and other senior faculty members, Madha ma'am, Udarji, and other senior faculty, PG, PhD scholars, and today's trainees. I welcome you all to this 2-day seminar and workshop training program on latent tuberculosis and its management. So this program is literally the brainchild of Vaidya Manoj Nesri sir. Actually, he is supposed to be the chief guest for today's program, and because of other engagements, he had been to Trivandrum to attend the Global Ayurveda Fest. And on this occasion, I thank him for his support and motivation. And the next one is our Director Ma'am, who is the pivot and motivational support for all the programs in All India Institute of Ayurveda, and particularly to this program. Right from the beginning, she is behind each and every activity. And on this occasion, I welcome you, ma'am, to preside over the function. And two chief guests. One is Dr. Raghuram Rao from Ministry, and Dr. Raghu Arakal, Deputy Director General, Health Services, Ministry, and PG Dean Anand More sir, who is instrumental in making all the activities in the department, and my fellow faculty members from Department of Kai Chikitsa, PG, PhD scholars, who are taking all the risk in making the program to get initiated and to make a successful of the conduction of the program. I welcome you all for this 2 days program. And the latent tuberculosis is the topic for discussion. As you know, tuberculosis is one such a disease which is said to be Roga Samuham. Morning we had such a presentation how it is getting manifested, and the incidence when we see it is 1/3 of the population is suffering with latent tuberculosis. You and me, maybe if at all we are testing, will be having the same. But the thing is, many times we are not aware of the things, and whenever it comes into action, multiplication and replication, then we'll be knowing that one. Otherwise, we are all healthy only. And to manage the condition and to prevent further spread of the disease, the TB Mukta Bharat Abhiyan is being planned, and as a part of this one, the program is initiated, and this 2 days program will be with a lot of stalwarts who are working on this particular topic will be delivering their lectures, and we can have a feast of wisdom on this particular disease and its management. So enjoy the program, enjoy your stay over here, and once again welcoming you all. Thank you.
Thank you so much, sir. Now, I would like to request Dean PG, Professor Dr. Anand More sir, for his words of wisdom.
Namaste. Respected Director Madam, Professor Tanuja Nesri. Today's our resource persons, Dr. Raghuram Rao, and another resource person, Dr. Raghuji from Ministry, Professor Jonas Sir, Head of Department of Kaya Chikitsa, and the organizer of this today's program, Dr. Divya Kajaria, and all the senior faculties and all the trainees who have joined here for this 2 days program. As in the morning session, Dr. Raghuram Rao has been expressed their views. What are the policies of government in eradication of this tuberculosis? And there are many activities which is going on at government level. But what will be the role of this Ayurveda in this eradication of this tuberculosis? So, in 2 days program, this in orientation program, here we can discuss about this the contribution of this Ayurveda regarding the treatment of this tuberculosis, and we may suggest to even ICMR also to include these treatment models in the treatment of this tuberculosis. As we know, there are so many side effects or complications regarding while the modern treatment is going on. So, Ayurveda can play the important role in these prohibiting these side effects. So, these also can be added in the treatment model. And another, the Rasayan therapy. If there is a immunomodulator drugs, if it is used, then there may be the less chances of this latent tuberculosis. So, I hope these 2 days there will be many brainstorming sessions and discussion and interaction with this resource person and with these trainee who have joined from the government sectors, and it will definitely help to enhance these activities at the with the help of this Ayurveda. Thank you once again, and I cordially welcome all of you for this 2 days program. Thank you.
Thank you very much, sir. As, as we are moving forward with this program, we are going to inaugurate a book that is the training module on latent tuberculosis, diet chart, daily regimen, pamphlet, TB pledge, and ID card. I request all the dignitaries for the inauguration of IC material, including training module, release of book, that is the training module on latent tuberculosis, diet chart, daily regimen, pamphlets, also a TB pledge and iCard.
Daily regimen, diet chart, daily regimen, and a booklet, IC material.
वीडियो प्ले करना वीडियो प्ले चलो बोलो ना video play of the LTBI OPD of All India Institute of Ayurveda, New Delhi. Let NTPC detain.
सरकशी का परचम लहरा दो गर्दिश में फिर अपनी सरजमी का परचम
ऐ मेरी जमीन अफसोस नहीं जो तेरे लिए सौ दर्द सहे महफूज रहे तेरी आन सदा चाहे जान मेरी ये रहे ना रहे मेरी जमीन महबूब मेरी मेरी नस नस में तेरा इश्क बहे फीका ना पड़े कभी रंग तेरा जिस्मों से निकल के खून कहे
मैं रहूं या ना रहूं भारत ये रहना चाहिए देश से है प्यार तो हर पल ये कहना चाहिए मैं रहूं या ना रहूं भारत ये रहना चाहिए सिलसिला ये बाद मेरे यूं ही चलना चाहिए मैं रहूं या ना रहूं भारत ये रहना चाहिए मेरी नस नस तार कर दो और बना दो एक सितार राग भारत मुझ पे छेड़ो झंझनाओ बार बार ओ यूं ना लम्हा लम्हा मेरी याद में होके तन्हा तन्हा मेरे बाद में नैना अश्क न हो माना कल से होंगे हम दूर नैना अश्क न हो नैना अश्क न हो मैं ना लौटा आने वाले साल जो मेरी वर्दी बोले मेरा हाल तो नैना अश्क न हो ये समझना मैं हूँ मजबूर नैना अश्क न हो नैना अश्क न हो
This is a OPD running in the NTPC D10 under the guidance of Professor Dr. Tanuja Nesriji as a PI of the project. And we are catering about 40 to 45 patients daily. We are having 3 days OPD in a week. Thank you.
Now, I would like to request our guest of honor, Dr. Raghu Arakkal, sir, Deputy Advisor, Ministry of Ayush, to enlighten us with his insights. So, please.
Thank you. Respected Director of the All India Institute of Ayurveda, Ma'am Tanuja Nesri, Ma'am. Dr. Raghuram Rao, he is the nodal person from the tuberculosis division of the Ministry of Health and Family Welfare. Dr. Jonah, he is the in charge of the Kaijilsa department, and also in charge of this particular central sector scheme implemented by the All India Institute of Ayurveda. Dr. Divya Kacharia, she is also the nodal person for this training program of 2 days training program. And Dr. Anand More, he is the Dean, Academic Dean of the All India Institute of Ayurveda. And all the participants for this training, 2 days training program, particularly the medical officers from Delhi as well as Haryana. It's a great pleasure for me to address you all because in our systems, particularly Ayurveda or in any other traditional medical system, in that context, there was a general feeling that we cannot contribute into many of the communicable diseases. So that was the age-old, what you call, notion that we developed in our country. But we have to prove that it is not the fact. There are areas where there is a scope for convergence with health sector, entire health sector. And tuberculosis is one area where that convergence is that most important for the nation, because we have targeted to eliminate this disease from our country by 2025. So in that context, what Ayush, particularly Ayurveda, can contribute even in the early identification, early referral, even particularly the identification, because when we spoke with Dr. Raghuram, then he mentioned that a considerable number of latent cases in the country, and which if we can target that cases particularly, that would be the utmost contribution from the Ayurveda systems. So based on that, whatever I hope that the 2 days training program, what you gain, that you can easily translate into your clinical setting, and not only you, because you have to percolate that messages to the community, because the community participation and the contribution of the community is very much important in not only in the treatment aspect, but even the compliance to the treatment regime, and even the regular follow-up, and even after for a leading a very successful life of the patients actually. So I would not prolong my speech because we are already into the training program literally. So I wish all the success for this training program, as well as we would request all of you to actively participate in the discussions and further go ahead. Thank you. Thank you.
Thank you so much, sir. Now, I request our guest of honor, Dr. Raghuram Rao, sir, Assistant Director General, Ministry of Health and Family Welfare, for his valuable words. Sir, please.
Once again, good morning, Dr. Tanuja ma'am, all the senior faculties on the dais, and all the participants, medical officers from across. Thanks for this opportunity. It's been a wonderful morning. Although I've taken a full lecture, but once again I get the opportunity to speak, and it's something as a program or as a disease. This disease is among the biggest public health problem that we have been facing in the country, and we are taking it like a bull by the horns. And in the last 5 years, a lot of efforts have gone in to work and try to achieve the SDGs for tuberculosis. And it's not easy because apart from the diagnosis and treatment, there are so many other factors which is influencing the population in breaking down to TB disease. And latent TB, like Arakal sir also mentioned, is a very, very important area, and unless that is the pool of infection, and they will break down to TB. Even if a small proportion breaks down, it converts to lakhs in numbers when we say every year into new cases. And that's why it's important. And the simple interventions that I brush through the the IEC materials and the training packages, simple interventions which can maintain our immunity, can prevent anybody who has infection from breaking down to TB. and such interventions will go a long way. And the pool is massive. One third of the country's population, when they have latent TB, you can only imagine, how long will it take to end TB, right? If every infection has to be stopped, and this is an intervention with convergence of the two systems that we should be able to give the amplifier effect, in the efforts for prevention of TB that we are doing. And I'm sure we were also discussing, in the room in terms of the formal pathway for getting this introduced into the program. But these interventions, these studies will help us document the impact that an intervention like this can have on latent TB, and which can help in the program on the long run. So I think from the technical side, yes, look forward to the learnings and the results from these interventions, which we and our culture also were discussing, that we will be looking forward for a concept note to take it forward for consideration within the ministry and on the larger program. And as we move on, I wish you all the best for this training, 2 days, to understand, clear your doubts. Everybody has a role to play, and I'm sure that as we go outside after 2 days, we will all be enriched with the knowledge from senior experts and faculty that we have here, and make the best out of this opportunity. And once again, thank the institute, and especially Madam Tanuja Chandra for being such a gracious host, and having this morning. Thank you so much. Wish you all the best. Thank you.
Thank you very much, sir. I would like to take a moment to acknowledge our esteemed Honorable Director, ma'am. She is a driving force in each and every event. We feel blessed to have your presence with us today, ma'am. And I would like to invite Honorable Director, ma'am, for the presidential address.
नमस्कार, मंचासीन सभी मान्यवर. बेसिकली आज व्हेन वी से दैट द फ्यूचर ऑफ द मेडिसिन इज आइदर नो मेडिसिन, क्योंकि हम आयुर्वेद को स्वस्थस्य स्वास्थ्य रक्षणम कहते हैं. तो अच्छा खान पान, डाइट, लाइफस्टाइल एंड एवरीथिंग, वी से दैट वी कैन प्रिवेंट मेनी थिंग्स. द फ्यूचर इज विदाउट मेडिसिन. लेकिन द फ्यूचर इज इफ़ एट ऑल देर इज़ अ डिसीज़ विच इज़ अ फुल ब्लोन, लक्षण भी हेतु को हमने परिवर्जन नहीं किया और व्याधि हो भी गया, और व्याधि की चिकित्सा करने के लिए इवन द फ्यूचर ऑफ मेनी मेडिसिन एंड इवन especially in the public, only in the interest of the patient, not in the interest of our own pathy, but patient centric integration के लिए दोनों जितने भी यहाँ मेडिकल प्लूरलिज्म हैं, तो जितनी भी मेडिकल सिस्टम है उनको साथ में आना चाहिए. So we are really fortunate and blessed to have Ministry of Health, representation of Ministry of Health, as Dr. Raghuram Rao. He is also looking after all the entire program of the TB management and eradication. So thank you very much, Dr. Raghuram Rao, for representing Ministry of Health also, and none other than Dr. Raghu A, who is there in the ministry for last more than 1 decade, and he is not deputy, he is a joint advisor, and he is looking after as a vertical of DGHS, that is a health system where all the public health initiatives and the medical officers and NHM, National Ayush Mission, and many other activities coordination are being looked after as a one single nodal from the ministry. So we are really blessed to have Ministry of Ayush and Ministry of Health with us. So we welcome you and thank you, Dr. Raghu, both the Raghus. रघु राम का नाम है, तो हमारे लिए ब्लेसिंग्स है ये प्रोग्राम के लिए आगे जाने के लिए. सो थैंक यू वेरी मच फॉर बीइंग विथ अस, एंड प्लीज़ गिव बिग राउंड ऑफ अप्लॉज फॉर देयर बोथ support of both the ministries. And this program is being implemented as a part of Ministry of Ayush, as a public health initiative for the eradication and the management of TB in its latent phase. जैसे जो गुप्त अवस्था में ही पूर्व रूपम एव जयेत व्याधि में से कहा, पूर्व रूपावस्था में ही हमने उसकी चिकित्सा की, रसायन हो जो भी चिकित्सा है उसका स्क्रीनिंग करके निदान अच्छा किया, एंड द स्क्रीनिंग प्रॉपर होके अगर वी प्रोवाइड अ बेस्ट होलिस्टिक मैनेजमेंट, आई थिंक वी आर एबल टू सपोर्ट एंड हेल्प द पेशेंट टू बी हेल्दी, टू रिमेन हेल्दी, एंड जिसको हम रिवर्स कर सकते हैं, प्रोग्रेशन को स्टॉप करके हम दोबारा उसको अपनी पूर्वावस्था में ला सकते। तो इस प्रोग्राम को संचालित करने के लिए काय चिकित्सा विभाग के अध्यक्ष, विभागाध्यक्ष प्रोफेसर जोनास, एंड द कोऑर्डिनेटर इज डॉक्टर दिव्या काजारिया, एंड उनके जो मेन मार्गदर्शक है, क्योंकि यहाँ स्क्रीनिंग इज़ वेरी इंपॉर्टेंट, टीबी गोल्ड का पॉजिटिव निगेटिव होना, एंड ऑल दी मार्कर्स, ऑब्जेक्टिव मार्कर्स नीड्स टू बी प्रॉपरली असेस्ड, एंड जिसको हम कहते हैं आज, क्योंकि वो लक्षण मुक्त ही है, लक्षण में है ही नहीं, तो व्हेन व्हाट इज़ दी आउटकम मेजर, किस आधार पे हम कहेंगे कि हमने ठीक किया, सो इट इज़ ओनली द स्क्रीनिंग एंड द इन्वेस्टिगेशन, सो वी नीड द सपोर्ट ऑफ investigation, रोग निदान and विकृति विज्ञान. So we have the support from diagnostic labs, Dr. More, Dr. Tiwari, Dr. Shalini. So we have Dean PG, MD, who is also head of Dr. Roga Nidan, and who is also one of the co-investigator in this project. So Dr. More, and the entire idea was supported by our research advisor, who also comes from the ICMR, senior scientist, and he is from the epidemiology and public health, Dr. Anil Kumar. So we are really thankful for taking this idea. I'm sure I remember those days when you took Dr. Divya even to Agra and Mathura and TB Chest Hospital and many others. We pursued this, and all the senior colleagues, Dr. Madam from Swastha Vruta Department Professor, and she is also our NAC IQSC coordinator, and we received NAC A++ because of our committed service of everyone. So Dr. Medha, we are also thankful and we welcome you. And the senior colleagues, Dr. Huddar, Dr. Amrish, and all from Kai Chikitsa department, and those colleagues who have joined together. And I'm really happy that हम अगर कैपेसिटी बिल्डिंग कर रहे हैं तो किसका कर रहे हैं, मेडिकल ऑफिसर जो दिल्ली गवर्नमेंट में I know Dr. Pawan Mali, who is also senior medical officer, and those who are really competent enough to cater the patient more than 100 per day, 75 per day, और हरियाणा. तो हम आपको नया क्या समझाएंगे, but we will definitely like to share their experiences, especially from Ayurveda, कि हम क्या कर रहे हैं, क्योंकि ये ऑल इंडिया इंस्टीट्यूट ऑफ आयुर्वेद is the model created for providing the tertiary care as like aims for Ayurveda. तो यहाँ जो टर्शरी केयर सेटअप है वो होलिस्टिक एंड इंटीग्रेटेड मॉडल है, क्योंकि पिछले 2017 में जहाँ माननीय प्रधानमंत्री जी ने इसका लोकार्पण किया, उससे आज तक इट इज़ ओनली 6 years, बट वी हैव बीन एबल टू ट्रीट एंड द मैनेज होलिस्टिकली 17 लाख पेशेंट्स, और जिसका ऐसे तो हज़ारों लाखों पेशेंट की ट्रीटमेंट होती है, but what this data is very important, as Dr. Raghu was also mentioning, the data is very important. So we have the record of each and every patient, pre and post outcome measure. तो जैसे टीबी का अगर हम कह रहे हैं, डॉक्टर दिव्या ने ये नहीं बताया, रूम्स देखी, लेकिन ये मई 2023 में हमें ये प्रोजेक्ट मिला, जुलाई में ओपीडी शुरू की, और जुलाई से आज तक सेपरेट रिकॉर्ड ऑफ द डेटा of the patient is 18,000 patients, and we have, when we say positive to negative and cure, जिसको we can claim कि ये है कि उसको लेटेंट में से हमने और उनको ठीक कर दिया, ऐसे 200 केसेस है. So we have more to complete, but 1500 to go, but this data we want to share, what we could do. तो जो मैं गई थी वो there is a challenge, क्योंकि 42 स्पेशल ओपीडी ये 7 मंजिल बिल्डिंग में है, हमारे आपस में ही, और कोई नई ओपीडी करना है तो टीबी के लिए वी हैव अ सेपरेट आइसोलेशन होना चाहिए, सेपरेट वार्ड. सो कोइंसिडेंटली एनटीपीसी की लैंड हमें मिल गई 12 एकड़, और वहाँ अभी रिनोवेशन भी होना है, बट वी जस्ट स्टार्टेड इन द इंटरेस्ट ऑफ द पेशेंट। एक क्वार्टर में ये शुरू किया, क्योंकि काम करने के लिए हमें बस इच्छा चाहिए, और देर आर इंटेंशन इज़ वेरी प्योर। इंटेंशन अच्छा है तो काम हो जाता है, देर इज़ ऑलवेज पावर इन इंटेंशन। सो वी वांटेड टू स्टार्ट इट, जैसे भी है आगे उसको बनाएंगे, अच्छा इंफ्रास्ट्रक्चर करेंगे। बट फॉर पेशेंट ईज के लिए, जहाँ कभी एसी नहीं था, ऐसे सब कुछ करके अभी धीरे धीरे सब कुछ हो रहा है। लेकिन वहाँ क्या कर रहे हैं एक्चुअली, दैट दिव्या वॉज सपोज टू शेयर, बट वो अपना खुद के लिए में अच्छा क्या कर रहे हैं बताना, मे बी ड्यूरिंग द कोर्स ऑफ द डे शी विल एक्सप्लेन एंड एवरीवन यू विल इंटरैक्ट। लेकिन जब मैं गई थी 15 अगस्त के, ऐसे ही ले गई थी कि आप आइए करके, और वहाँ आते ही बहुत कड़वी, एक कड़वा पेय हमें दिया, एंड दैट वाज वासा का काढ़ा था, क्योंकि ऐसे कहते हैं वासायाम विद्यमानायाम आशायाम जीवितस्य च रक्तपित्ती क्षयी काशी श्वासी काशी च किम अवदितति। और इसको अगर शोष कहते हैं या क्षय कहते हैं और राजयक्ष्मा के पूर्व रूप कहते हैं, सो अडूसा वासा इज ऑल्सो वेरी गुड, एंड ऑल रसायन औषधि, रसायन चिकित्सा करनी चाहिए, जो जिसके हम रिवर्सिबल स्टेज में जाते हैं। एंड व्हाट इज़ दी रोग, जैसे निदान षट क्रिया काल की अवस्था करके फिर उसकी चिकित्सा की जाती है, पंचकर्म, डाइट, लाइफस्टाइल एंड एवरीथिंग। पेशेंट को ये जो आज आईसी मटेरियल भी जो लॉन्च किया है, उसके लिए भी आपको बधाई बहुत देती हूँ। मे बी यू विल शेयर विथ ईच एंड एवरी ऑफिसर्स, एंड वी consider this as a zero draft, because I know these are highly accomplished medical officers. I know many of them personally also. So maybe you also give your input, so that we will enrich the material to take it to the patient, and you can also replicate in your OPD and you can share the data. So big data can definitely will support to ministry, and as Dr. Raghu was mentioning कि अगर हम रिसर्च कंसोर्शियम में, या डॉक्टर रघु यू वेर ऑल्सो मेंशनिंग दैट देर इज़ अ प्रोसीजर that data is to be generated through ICMR, we can collaborate, and then to make it as a part of national program, I think we need to go, we need to follow the evidence-based data generation. I think that is the first step we have started, but we have to join all together. हम सबको मिलके ये करना होगा in the interest of nation. मेरा आपका इसमें स्वार्थ की यही है कि हमारे पेशेंट को, क्योंकि पेशेंट नीड्स इंटीग्रेशन, कि उसको एक टीबी के जितनी भी AKT या RNTPC जितना भी प्रोग्राम्स है उनमें तो उनको मिलते हैं, लेकिन जो सपोर्ट है आयुर्वेद का, हम कहते कि अडूसा कैसी एक वनस्पति ऐसी है कि वो जीवन जीने की आशा देती है, जिसके कॉम्प्लिकेशंस है, ट्रीटमेंट ड्रग के जितने भी लिवर खराब होना या कई सारे anorexia, there are many side effects, adverse effects of the drug also, and the patient becomes lean thin, और उनको अगर ऊर्जितावस्था लाना है, so integrated approach is the one, but अगर eradicate करना है, निर्मूलन करना है, WHO ने भी ये ठाना है, UN ने भी ठाना है टीबी मुक्त ऑल द वर्ल्ड, और टीबी मुक्त भारत ये प्रधानमंत्री जी की अगर घोषणा है, तो वी हैव टू जॉइन टुगेदर द हैंड्स। मिनिस्ट्री ऑफ आयुष CCRS के माध्यम से भी कई प्रोग्राम कर रहे हैं, बट दिस इज़ वन स्टेप where we would like to generate the data and support and provide to the ministry, so that the ministry would like to take it further for implementation into the public health program. So this is our main aim. और दूसरी बात, इसीलिए मैं बहुत बहुत बधाई देती हूँ आपको भी और डॉक्टर दिव्या काय चिकित्सा विभाग और आपको भी, क्योंकि nowadays investment, biggest investment is the time. If you have invested your time, and I'm sure your investment would be a meaningful. I'm sure you will enjoy. आप ऑल इंडिया इंस्टीट्यूट भी देखिए, क्योंकि ये जो NABH accredited ISO certified and NAC क्यों मिला है, and why this institution is growing with your contribution and the lead, as a team. Maybe you visit and give us the suggestion, if at all, to be incorporated for the development, because this institution is in the public domain, everyone's institution. So maybe you can find time to visit the infrastructure, HR and other departments, so that you can provide us your suggestion as well. And lastly, मुझे किसी ने पूछा था, what is the best way of popularizing our Indian system, Indian knowledge system, traditional system of आयुर्वेद। हम कहते हैं कि ये what is the strength is not in the prevention but from illness to wellness to happiness अगर हम ले जाते हैं. लेकिन the real essence of this system, any system across the world, ये कब पॉपुलर होती है एंड कब रिकग्निशन मिलता है? सो ओनली एंड ओनली व्हेन दैट रीचेस टू द प्राइमरी हेल्थ केयर. WHO भी ये कहता है कोई भी ट्रेडिशनल मेडिसिन का अगर इंटीग्रेशन करना है, जो इंटीग्रेटेड ट्रेडिशनल मेडिसिन स्ट्रेटेजी अभी 23 थी उसको एक्सटेंड किया 25 तक अभी, एंड द न्यू स्ट्रेटेजी इज अगेन बीइंग फॉर्म्ड विद द ग्लोबल कंसल्टेशन. तो वो प्राइमरी हेल्थ केयर में, पब्लिक हेल्थ इनिशिएटिव में हाउ वी रियली cater to the population, citizens of the particular country, I think उससे हमारी स्ट्रेंथ को नापा जाता है. तो हमने डबल ब्लाइंड कंट्रोल क्लिनिकल ट्रायल्स किए, पब्लिकेशन किए, उससे कोई भी मतलब नहीं होता है. आम आदमी तक आप कितने पहुंचते हैं एंड हाउ वेल, एंड दैट सिस्टम इज़ कि हमने 80,000 दिल्ली पुलिस को कोविड में काढ़ा दिया. जैसे रघु जी कह रहे थे कि नॉन कम्युनिकेबल डिसीज़ ये हमारी स्ट्रेंथ है, लेकिन कम्युनिकेबल डिसीजेस में हमने कोविड में बताया सबको, एंड वी कुड पब्लिश इट इन द फ्रंटियर्स ऑफ पब्लिक हेल्थ. जो हमारा पब्लिक हेल्थ इनिशिएटिव था, दैट पेपर 80,000 दिल्ली पुलिस को आयु रक्षा किया, बट दोज वेयर ओनली फ्यू पेपर्स. लेकिन अगर हम टीबी जैसी कंडीशन में अगर एविडेंस क्रिएट करते हैं तो आई एम श्योर विल डेफिनेटली डू सम सर्विस टू द नेशन एंड वी कैन कॉन्ट्रीब्यूट to the medical system, and this is the greatest challenge and opportunity also. क्योंकि latent condition में एटलीस्ट कन्वेंशनल मेडिसिन के लिए ये अपॉर्चुनिटी है टू जॉइन आवर हैंड्स, क्योंकि पूर्व रूप नाम की जो एक ब्लेसिंग है हमारे लिए, पूर्व रूप में कैप्चर करने का किसी भी पैथी में एक प्रावधान नहीं है, विच वी हैव. So I think we have to come forward, and this is the greatest opportunity. And as all the medical officers, I know that you have HMIS. दिल्ली गवर्नमेंट में HMIS है, CGHS में हरियाणा में है. तो ये डेटा को अगर आप कैप्चर करोगे एंड द बिग डेटा पुल करोगे तो आई एम श्योर यू विल डेफिनेटली बी एबल टू contribute more into public health system. So once again, I congratulate you and I wish all the best to everyone. Thank you.
Thank you so much, ma'am, for your appreciation. Now, before we conclude the inauguration ceremony, let's take a moment to reaffirm our commitment in fight against TB by taking TB pledge. I request everybody to please stand up. Yes, sir. Yes, ma'am. ठीक है मैम.
चलो आप पढ़ते रहिए, आप पढ़िए, आपके बाद
do this one here.
प्लस करो. चलिए आप धीरे धीरे
और ये
yes,
ये यहाँ से हाँ प्लस करना, मैग्नीफाई करना.
मैं निवासी आपका क्षेत्र आज दिनांक 1 दिसंबर 2023 अखिल भारतीय आयुर्वेद संस्थान के परिसर में ये प्रतिज्ञा करती हूँ कि मैं भारत को टीबी मुक्त करने के लिए अपनी सक्रिय सहयोगिता दूंगा या दूंगी. मैं अपने परिवार तथा अपने समाज के स्वास्थ्य के प्रति अपनी जिम्मेदारी का पूरी ईमानदारी से निर्वहन करूंगा या करूंगी. मैं अपने आसपास भी यदि कोई व्यक्ति टीबी से ग्रस्त है तथा उपचार नहीं ले रहा है तो मैं उसको उचित उपचार लेने हेतु प्रोत्साहित तथा उचित सहायता प्रदान करूंगा या करूंगी। मैं सार्वजनिक जगहों पर थूकना तथा श्वसन संबंधित व्याधि होने पर इसके बचाव हेतु मास्क का उपयोग करूंगा या करूंगी। मैं भारतवर्ष को टीबी मुक्त करने में अपने वचन को दोहराता हूँ या दोहराती हूँ। धन्यवाद।
Thank you. Now, I would like to request Vijay Uddar sir for the vote of thanks.
Namaste to everyone, respected dignitaries. It's my immense pleasure at this moment to deliver the vote of thanks. First of all, I would like to thank our guest of honor today, Dr. Raghuram Rao, Assistant Director General, Central TB Division, Ministry of Health and Family Welfare, for sparing his valuable time being with us and delivering a lecture for all the participants. And I thank our another guest of honor, Dr. Raghu Arakkal, who is a joint advisor in the Ministry of Ayush, who has agreed to come here and encourage us and guide us to run the program, and we thank you from our team. And in absence, as sir was telling, the key person behind the initiation of this program, Dr. Manoj Nesri sir, advisor, Ministry of Ayush, we convey our thanks in his absence. And of course, the driving force always for such important programs and encouraging always for us, our beloved director, Madam, Professor Tanuja Nesri, Madam. We thank you from our team. And we thank Dean PG Studies, Anand More sir, for sparing his valuable time to join this program. And also I thank our HOD sir for encouraging us always, and all the and especially Divya Kajaria for organizing this wonderful program, and all the faculty members of Kai Chikitsa, and all the medical officers who have came from Delhi NCR and Haryana part to make this program successful, and all the PG scholars. Without them, which will not be possible to conduct such a programs. Always they will be key persons in conducting those programs. So all the office staff, PRO team, IT division, I thank one and all again, and thank you.
Thank you so much, sir. Now we conclude the inauguration program and move towards the next session of the workshop by Dr. Raghu Arakkal, sir. हाँ बोलना है तू ये लगा मैं बोलती हूँ. Now I request Professor HOD Professor Dr. Jonah sir to welcome our esteemed speaker with green wealth.
It is my great honor to introduce our distinguished speaker for the upcoming session, a prominent figure in the realm of Ayurveda and a key architect in development of healthcare policies, Dr. Raghu Arakkal sir.
Dr. Arakal sir currently holds the position of Deputy Advisor at the Ministry of Ayush. In this pivotal role, he contributes significantly to the formulation and implementation of various schemes under the Ministry of Ayush, which is dedicated to the promotion and advancement of traditional systems of medicine.
In today's session, Dr. Raghu Arakal sir will shed light on the role of Ayush sector and various schemes of Ministry of Ayush. His extensive experience and expertise in navigating the intricate landscape of Ayurveda within the broader healthcare framework of the country will provide us with valuable insights into the initiatives and schemes aimed at integrating traditional systems of medicine into mainstream healthcare.
As we explore this session, Dr. Arakal sir's wealth of knowledge will undoubtedly enrich our understanding. So please come.
Thank you. So, as we have gone from the inaugural session and in the first session already over in the morning itself actually. So, what I am supposed to brief you about how the Ayush systems, particularly in the government perspective, how we can engage with the management as well as even the prevention, management, and even to the extent of long-term follow-up and rehabilitation of tuberculosis. So in that context, actually, I can say that we can only make a very broad perspective of systemic strengths of the system, particularly the Ayurveda, whether it is Ayurveda, yoga, or any other traditional system that we are practicing in the country. Whereas in the case of ministry per se, if we see, we are actually implementing various schemes or missions actually for the benefit of Ayush systems, and in that context actually centrally sponsored scheme as well as central sector scheme. And central sector scheme, as a part of that central sector scheme, actually All India Institute of Ayurveda is now implementing this program of this latent tuberculosis prevention aspect, and that kind of schematic implementation is done. And we hope that such programs has to be continued throughout the country, not only by the tertiary care institutions, even at the secondary and primary healthcare institutions also. So if you want to make a contextual setting to this training program, I would say that particularly when we speak about the Haryana, I don't know about Delhi, because Delhi in the primary health setting actually that kind of integration, that what the government of India has envisaged, unfortunately it could not happen because the National Ayush Mission is not appropriately implemented in the state of Delhi, in the UT of Delhi. Whereas in the state of Haryana state is the first state came to implement particularly the health and wellness center, the concept of health and wellness center through the Ayush systems. So that gaining that experience actually, that will become an ideal platform to spearhead this program of what you call identifying the latent cases of the tuberculosis actually. So whatever that 2 days program training strategy that we are adopting here by the All India Institute of Ayurveda, that experience you can easily communicate with your whatever the resource persons in the state, and accordingly you can see the possibility to engage with the community, because community engagement is primarily important as far as any public health program is concerned. So with that brief introduction, I would like to say in the context of the public health actually, particularly why it is relevant for the Ayush systems, because from that setting only we can say about how we can go to the cases of the tuberculosis. So the science and art of preventing disease, prolonging life and promoting health through organized efforts and informed choices of the society, organization, public and private communities and individuals. So that kind of comprehensive, holistic approach to the public health is particularly important in the case of the management of the tuberculosis. Somehow over the years actually some of the component there were weak aspect, particularly the earlier aspect of the managing the tuberculosis, the community engagement was not so robust. So here, for the last 5 years actually, the government of India has very clearly, categorically addressed this aspect of the community engagement, and accordingly even the tomorrow's session you will study about the role of the Nikshay Mitra. That means who is actually the front to eradicate the tuberculosis and adopting the TB patients by the community themselves actually. So such kind of initiative underscore the importance of the what you call this the public health perspective into the management of the tuberculosis. So as a discipline, whether Ayurveda or other traditional medicine systems are very well fit into that domain. Obviously, it is clear actually, we say when we speak about the prevention, whether the prolonging of the life or the promoting health through organized efforts, there very specifically all the Ayurvedic principles are basically addressing these issues in a very clear manner. That I need not very spelt out the details of that. All of you are the medical officers actually, you know very clearly. And even the restorative and rehabilitative aspects of the Ayurveda and other traditional systems are highly important as far as such a chronic and communicable disease of tuberculosis, this disease condition is concerned. Because even after the treatment, even after the what you call the zero presence of the bacterium, even after that actually there is a important aspect that we are actually addressing, that specifically how to preserve the integrity, how to preserve the immunity of the body. That is we can easily, the Ayush system can easily address such issues actually. Earlier also many of the Rasayana drugs were actually proposed to be continued way back in 1998 itself actually. So much studies have been conducted, but still it is a lower sample size actually. Particularly the use of the Rasayana drugs, whether it is Ashwagandha, that is the first one studied, what I remember that. Thereafter actually even the Vasha and other drugs, single drugs regimen. But what I foresee actually, instead of going through only some one or two single drugs, actually we have to make the comprehensive principles of Ayurveda and other traditional system has to be adopted if you want to really engage with even in the latent cases of the tuberculosis. Otherwise, what will happen actually, one or two drugs you will make a very limited RCT trials, and later stage you will say that it is not equally as competent as the anti-tubercular treatment regime that currently adopted. So in order to not to fall into that pitfall actually, we should very clearly engage with the existing treatment regime with the very clear-cut principles of Ayurveda and other systems of medicine. That comprehensive protocol is highly essential in order to address any kind of communicable disease strategy actually. So there from the treatment principles of the Jara, treatment principles of the Yakshma, treatment principles even in the cases of the Rakta Pitta may be highly relevant as far as the management criteria when we are making the principles, because I think actually Kayachikalsa Department of All India Institute of Ayurveda can clearly make that kind of some very comprehensive protocol rather than only depending upon one or two single drugs. This is only one initial aspect that I would like to mention. Then as far as again come back to the primary healthcare context actually, when we speak about the principles of the public health, which is equally relevant to the understanding and even the management of the tuberculosis also, equitable distribution. Because the country, as we are actually facing, the greatest challenge is that the enormous actually, particularly tuberculosis, 1.3, more than 1.3 million of the population. So over a period of time, which is actually, it is exposed to the tuberculosis. So at that context actually, the equitable distribution of the resources, equitable distribution of the whatever the interventions that we are supposed to provide to the community, that should be one of the important aspects as far as tuberculosis is concerned. Then community participation, already I mentioned, that is in the case of Nikshay Mitra, through that we are now going to do it actually. Even in the every community engagement platform, you may be knowing that under the Health and Wellness Center also there is certain community bodies like what you call Mahila Arogya Samiti, Janarogya Samitis actually. If even in Ayush institutions, I would say that if you are able to really engage with these committees, if it is not formed immediately, you can ask your whatever the appropriate authorities to make it functional, so that every aspect of the communicable and non-communicable disease conditions in that particular community should be discussed. Appropriate a plan has to be made, and based on that plan, even we often speak that we can adopt the Dinacharya and Ruducharya, but Ruducharya, how to adopt it actually in the community setting? If you want to adopt it, you have to make a plan for the entire next 1 year. Who will make the plan? Only the CHO, community health officer, medical officer in charge of that facility cannot do it actually. So who can do it actually? It can be done only through organized efforts through all the the persons who are actually having the authority, particularly the Panchayati Raj institutions, whether it is even urban, in the urban level, urban local bodies who are in charge of that actually, even the school curriculum, the school teachers, concerned school teachers should be part of that, even other institutions who are actually closely associated with the health delivery, all should be part of that. So that was the concept of this bringing institutionalized setup into just like Janarogya Samitis and Mahila Arogya Samitis. Somehow it is not happening in the states. So I request, because this is a platform that I got from because most of the medical officers, you are actually working in that particular field. So considering that, I would suggest that if it is not formed, that should be formed and it should be activated under your leadership, so that at least even not specific to tuberculosis, any of the communicable diseases, or even to that extent, even many of the non-communicable diseases also can be easily screened, easily prevented by making appropriate regime for the Ruducharya and Dinacharya aspect in the community. Another aspect is the intersectoral coordination. So intersectoral coordination, specifically, we often miss out the Ayush in that actually. We often speak about the Panchayati Raj institutions, even various school health programs, even the Women and Child Development Department. But the major stakeholder for that aspect is the Ayush department itself actually. So there, appropriate orientation of the all Ayush doctors, even paramedics, if it is available, even the ASHA workers, everybody should be part of that. So that kind of intersectoral coordination with, just like when we speak about the water, sanitation, hygiene, everything we will speak, but we will often miss about the Ayush systems actually. So that is also very well integral to the intersectoral coordination, and that also should be taken care of. Then appropriate technology. So now we are speaking about capturing the data. So when we speak about the capturing the data, the HMIS, I don't think in this HMIS part has been implemented only generally in the research councils and the national institutes. Outside the state government, they have not so far onboarded. I don't know whether the Delhi government, I don't know, but actually Haryana, I think it has not been rolled out till date actually. So if that is the case, I can only suggest that we are now coming forward within next 1 month Indian Public Health Standards for Ayush. In that, we are actually categorically saying that the state government has to link with the existing management information system, whatever, if it is HMIS, then HMIS we have to link it with that. So regular data reporting should be there. So whether it is the communicable disease or even the non-communicable disease, whatever the disease profile as reported in the primary healthcare setting, on even whatever the referrals you are doing, and even at the tertiary level, whatever teaching hospitals, if it is dealing with all such kind of disease condition, that also has to be regularly reported. And we have also tried to define the infrastructure, whatever the minimum equipment, furniture, instrument which is required for each level of healthcare institution, even whatever the essential drug list, even though the Ministry of Ayush already published the essential drug list, but even we have tried to make it separate for as per the case load, as per the proposed what you call departments which should be part of the secondary care, primary care. Based on that, different levels of essential drug list we are actually proposing, even the clinical governance and even the prescription, how it should be, what is the standard model for the prescription, and how adverse reaction, because often we neglect. Sometimes the patients may say that there is a severe itching by using this whatever even not only the scheduled even drugs, even otherwise also many of the drugs, whatever due to faulty formulation that you are getting from the market or even in the public distribution system, many of the adverse events are, even though the patients are reporting to you, due to lack of systemic reporting system, you just hear and then tell that you take this one, this may be, otherwise you withdraw for the next 10 or 15 days. But it is not appropriately recorded. For that purpose, actually, this pharmacovigilance aspect also, this we have clearly tried to enunciate in the Indian public health standards. So I hope that by adopting many of these things, actually state government can come up to the expectations of the community, particularly in the context of the Ayurveda and other drug systems actually. So in the continuum of the care, that is what we try to explain now, how the convergence mechanism currently works actually. One is the Ayushman Bharat Ayush Health and Wellness Center, that is only the number is 12,500. But now a decision has been taken even for the 1.5 lakhs of Health and Wellness Center which is operationalized by the Ministry of Health and Family Welfare. Their Ayush medicines, wherever Ayush doctors are posted actually, at least 30,000, around 30,000 of the modern Health and Wellness Center also have the Ayurveda doctors are posted in the country. So there also essential drugs of Ayurveda will be provided, and accordingly they can also prescribe the medicines. This is a significant input from both the ministries, Ministry of Health and Family Welfare and the Ministry of Ayush. And from that level, in the secondary care level actually, we are actually trying to identify whatever the 10-bedded hospitals available in the states actually, even in the rural area, even in the semi-urban area or urban area, 10 to 15 beds, 10 to 20 beds actually we are categorizing at the secondary level care, where one or two specialty may be there. For example, some Panchakarma may be there, some what you call Charasutra. If the physician is available, Charasutra can be developed, not all the other specialities. Whereas in the tertiary, our tertiary, it cannot be exactly equated with the modern system of medicine tertiary care, but our tertiary system consists of our integrated Ayush hospital, particularly 50, now almost in the country 30 to 36 integrated Ayush hospital became functional. Ministry of Ayush already supported more than 100, out of that 36 it is functional. There slowly we are actually engaging with each of the hospital to have that kind of different specialities, whether it is for example skin, there is a special OPD, geriatric care, there is a special OPD and a special ward for that purpose. Even for the purpose of the pediatrics, actually Kaumara Bhritya, there is a specific wing. And accordingly, if the state governments are asking us to have that engagement of the specialist also, that is also supported by the Ministry of Ayush. So that kind of model, wherever from the primary health care, which is represented by the Ayush dispensaries and health and wellness centers, and no more the Ayush dispensary, because we taken a decision actually in the National Steering Committee that instead of calling it as a symbol Ayush dispensaries, we will uniformly call it as Ayush Health and Wellness Center in all the states. Now again, whether we have to take a call for that Ayushma Bharat Arogya Mandir, that new word is coined by the Health Ministry. So whether we have to take that call also, that we will take it up. But currently our Ayush Health and Wellness Center, that Health and Wellness Center word we are using for the primary health care uniformly, that we are addressing to the states. Then next stage, what we are supposed to do is to the development of the integrated Ayush hospital at 50-bedded hospitals very comprehensively. There specifically all the referral cases from the lower level. So the continuum, the referral criteria that already CCRIS has for the Ayurveda system 1 referral criteria have made. Parallelly, DGHS under the chairmanship of the Director General of Health Services, we are also making certain standard treatment guidelines, and under that the musculoskeletal disorders is now going to be completed. So once it is completed, at 6 disease conditions already we have taken up actually, and once it is completed, Dr. Jonah is also part of that committee, and once it is completed, then what we suggest that even the referral criteria, everything will be based, we can make it based on that. For that we will roll out a national level orientation to the all the doctors who are working in the public health facilities, whether it is dispensaries and hospitals, so that at least they will get a clear idea about what should be the area which I am supposed to manage and where I can refer, and that system can evolve only when states are very clearly onboarded in it, because at one level it is complete, but another level if the referral facility in a, then how we will do it actually. So that also we have to create parallelly, everything we have to create on that ground. So in that way the continuum of the care as envisaged in the comprehensive primary health care and even the PMJY. PMJY, the second component of the PMJY is we expect that that will also be rolled out soon, because now it is under discussion stage, consideration stage to include the Ayush systems under the PMJY insurance part actually. So that also I hope that sooner or later it will be resolved. Then whatever discussions we emanate from the Ministry of Ayush based on the convergence issues, as you know that it is emanate from the National Health Policy, that is 2017. So here very specifically whatever the pluralism is mentioned, the three-dimensional pluralism, everything is mentioned, but currently what we understand that for co-location that kind of pluralistic objective is not being fulfilled. That means physically it is there actually, the manpower is there, deployed is there, and they are actually conducting, they are putting their entire efforts, but somehow the Ayush system cannot showcase so far at that level. So for that purpose, even in the IPHS also we are actually addressing that issue. So hopefully if in engagement with the Ministry of Health and Family Welfare, if appropriate guidelines are very clearly spelt out, then definitely that kind of what you call Ayush strength also we can exhibit at the co-located facilities at the PHC, CHC and district hospital. Then the research. So as far as particularly in the context of the tuberculosis also, our research councils, whether it is CCRIS or CCRUM, they have already initiated any of the research work. Somehow it could not be completed actually, at various stages actually, particularly one of the, I will come to that slide particularly the hepatoprotective activity, whenever the ATT is actually provided actually for a long term actually, as we know that there are chances of that hepatic issues will be there actually obviously. So many of the traditional medicines can, the combinations can provide immediate protection to the liver problems actually. For that some kind of research works are already done by the research council, so that also should be part of that. Then yoga at every level, that is also pronounced by the National Health Policy. So as we know that at every level we would like to integrate yoga, whether it is not only in the tuberculosis, because just now I discussed that even after the treatment regime is completed actually, there even the rehabilitation stage also the yoga is supposed to be integrated actually. So there is a immense scope for yoga in a particularly the respiratory, what you call the volume or even the lung capacity, to enhance the lung capacity of the patients actually. So there we have to make very cautious protocols, because each and every patient may not be having the same level of what you call compliance to the yoga protocol. So based on that, different patient entities has to be understood, and based on that the protocol has to be developed. So I hope we will take that lead also by the All India Institute of Ayurveda also, then and the Morarji Desai National Institute of Yoga also. Then mainstreaming already mentioned. So as far as the schemes are concerned, I won't have much time to dwell, because this is a very long topic. As far as if the schemes alone, if I want to discuss, that may not be relevant to you also. So I will very just brush upon what are the schemes wherein we can say that some kind of engagement in terms of tuberculosis is concerned that we can make. For example, the National Ayush Mission, this is the only flagship scheme where the ministry is supporting the states and UTs actually, because there is no other direct instrument for the ministry to directly engage with the states and UTs. So National Ayush Mission is the centrally sponsored scheme. There we are supporting, as I told earlier, to infrastructure development. Once this IPHS is completed, then we will insist the states that whatever your proposals you are sending to the central government should be based on the IPHS standards actually. So I want to comply with these kind of IPHS standard. For that I need financial support. So based on that, ministry can clearly give certain targets for each of the states and UTs for achieving that target. For example, within 5 years, I will bring to 60% compliance of the IPHS. Yeah, 80% compliance. So based on that, the financial support also can be provided. This is not now already made, not complete actually. This is the plan that when we speak about the IPHS. Similarly, another scheme is the central sector scheme of Ayurveda. This is a research project that is directly ministry supports the various research organizations, even the state governments where you are working actually. There also you can send the extramural research, particularly if you say that there is a scope for even the latent tuberculosis or even the rehabilitation at that stage. Some kind of research project if you can design, and through the state government, if the funding requirement is there, then under extramural research that can also be assisted by the ministry. Similarly, Ayur Swasthya, the Ayur Swasthya Yojana, this is a public health initiative, and even the Center of Excellence. There are two schemes earlier which ministry was implemented. So both the schemes has been clubbed together into a broad umbrella of Ayur Swasthya Yojana. So there the current public health initiative and many of the state government has already availed the non-communicable diseases and even the communicable disease, particularly anemia, malnutrition, or even some state, 1 or 2 states, even the prevention of the communicable disease, tuberculosis, malaria eradication. So many of the such communicable disease program has been already been projects have been taken by the many of the states and UTs under the Ayur Swasthya Yojana. Another one is Champion Sector Service, Champion Service Sector Scheme. This scheme is basically for in order to the medical value travel, to enhance the medical value travel in the country, particularly to set up certain benchmark hospitals, hospitals and clinics where the physician can have that kind of what you call the basic standards, so that to attract the foreign clientele in the country. Under that context, actually, this champion services sector is actually mentioned. Another one is information education communication scheme. As you know that it is basically for our behavior change and easy activities, and the ministry is supporting even the states also. Many of the state Arogya, many of you are already maybe participated in the Arogya fairs and other things, and even very specific targeted exhibitions and fairs and everything is actually supported by the ministry. Then the last what I mentioned here, the Ayush Aushadhi Gunavatta Evam Utpadan Samvardhan Yojana. This is nothing but actually to enforcement mechanism, the quality control of Ayurveda, Siddha, Unani, homeopathy drugs actually in the country, supporting the state pharmacies, the laboratories to strengthen their capacity, even the enforcement mechanism as far as the supporting the drug inspectors, and all these aspects are actually part of that schematic provision. And in addition, Ministry is also running the international cooperation scheme, which is not relevant in this context. Therefore, I have not mentioned here actually. Another one is medicinal plant cultivation, central sector scheme for the medicinal plant cultivation. So that scheme is it is a part, because it can be as a promotional avenue, but otherwise it is not specifically relevant to this context. So National Ayush Mission का context में suppose tuberculosis में what we can do. I can say that the healthy living, our Ayush Gram, that concept. Suppose the state governments can adopt certain villages specifically under the Ayush Gram component. There we can see over a period of time, if you see some cohort studies, if you can initiate there actually, over a period of time, how the community is adopting to the principles of Ayurveda, and in that community, not only the tuberculosis, what I am saying that in spite of all the communicable diseases and non-communicable disease, over a period of time, what happened, for example, 2 years or 3 years, is there any change? So that kind of things you can study under the Ayush Gram actually. So it is a holistic, healthy living of the entire community. So it is a very huge task. It is easier said than for implementation. But actually it is a huge task. If your entire machinery of your dispensary or hospital can be motivated, and entire community, for particularly the community peer groups, the school teacher, the headmaster or headmistress, or the panchayati, the president of the panchayat, or even the whatever the urban areas in the sanitation department, women and child level, everybody is motivated, and if you are able to implement that program, then it can be a successful model. Otherwise, if you are only standalone manner, if you are going to implement it actually, that kind of success may not be available actually, because your wings are actually should be supported by many other parallel departments. So that is another one is mobile medical units and school health program. Under school health program, we have a component under the public health initiative which is called as Ayurveda. There we are actually suggesting the states to adopt 75,000 schools throughout the country. So that I think if that component is successfully implemented, definitely the even the school children, particularly, that would be more beneficial to prevent the non-communicable disease context actually. That will be very useful for the entire community. Another one is already Ayush Gram I mentioned. So this is the service delivery norms under Ayush Health and Wellness Centers, because I thought that because many of the medical officers may be working in the health and wellness centers also. So under that context, these service delivery framework, which in fact have the everything, whether it is antenatal health promotion, neonatal infant health promotion, childhood and adolescent health services. So what we try to integrate certain public health components with this service delivery. For example, Supraja, there is a component that under public health initiative. So Supraja, what we try to implement, how this program is implemented at the teaching institutions, to enhance, to increase the number of deliveries in the teaching institution. Somehow we know that when we study the undergraduate courses, BAMS, or even in the MD in many of the institutions, literally there is no antenatal checkups and even the postnatal checkups, and many of the deliveries are very rare actually. Only selected institutions, they are doing it actually. So we would try to enhance the number of deliveries so that the competency of the, including the teachers and including the students, has to be enhanced. For that purpose actually, Supraja component introduced for the teaching institution. Thereby we are actually suggesting to link it with even Janani Suraksha Yojana and other aspects, so that pregnant ladies can come to the Ayurveda hospital for the delivery purpose and enhancement, the quality enhancement, even the posting of the very specific medical officer for that purpose. So everything is supported under that. So there the HWC will become a gatekeeper for that actually. The first any of the pregnant ladies reported to that, you can encourage them to the teaching hospital where this Supraja is actually being implemented. So I think Haryana and Delhi, now it has not started to implement, but actually other states, they have already doing it actually. Similarly, in the NCD already you know that most of you are actually participating in that. In the NCD portal also you are actually putting the data, so there is no problem for that. Geriatric care, and we are another geriatric care is also one of the public health initiative that ministry is supporting through the states actually. There even the referral system also we have asked very specifically to the teaching institutions, so that the patients coming for the Panchakarma and other therapies, Rasayana therapies can be enhanced. Similarly, common eye and ENT problem, so there also we are actually supporting the state. Then some kind of emergency care, this is mainly for the health and wellness center of the modern medicine actually. We are saying that only if a first aid if you are able to provide to the patients actually, there that is only initiative that we are supposed to do. Then as far as tuberculosis is concerned, actually infection prevention control already mentioned, enforcement of biomedical waste management. All the healthcare institutions, we have to implement the biomedical waste management rules actually. Somehow we are actually now engaged to National Accreditation Board of Hospital team to accredit the Ayush Health and Wellness Center in the country. So there, wherever they are going, the first one of the observations are that the complete lack of the whatever the even the common dustbins in the health facilities actually. So that should not be happen actually. So as far as one of the finite principle of the prevention of the tuberculosis, in that case any of the communicable diseases is actually the enforcement of the biomedical waste management rules, and accordingly this should be very clearly implemented in the all the dispensaries and hospital. Then the dhubana, that is frequent because we often preach about the dhubana, but somehow it is not done in our healthcare institutions. So that should be very mandatorily we have to do, particularly abrajita dhuba or any, in that case any kind of such dhubana should be done to reduce the microbial growth in the healthcare facility. Environmental surveillance is also important. Judicious use of Ayush Center for optimizing the use of antimicrobials in health actually. So many of the repeated use of the antibiotics actually, so that can be prevented once you judiciously make the treatment plan as far as Ayurveda is concerned actually. So based on for that you need an appropriate treatment protocol, not only in the tuberculosis, but I am saying that in each and every case. So Government of India is now, there is a national action plan for such kind of what do you call this microbial diseases, particularly the prevention of such cases actually specifically. So in that context actually what we from the Ayush fraternity we can suggest that the many of the repeated use of antibiotics can be avoided provided a very clear-cut protocol is implemented from Ayush systems at all these healthcare institutions. TB elimination specifically, we have actually, there's a national strategic plan के अनुसार 2019 में Ministry of Ayush and Ministry of Health and Family Welfare has signed an MOU. So on that MOU, basically most of the things are basically awareness generation, training program and research. Only 3 aspects has been focused. So under that, the training program, now we are taking it up actually. So ministry has now in consultation with the TB division of the Ministry of Health and Family Welfare is shortly giving the training to 180 medical officers from the field level medical officers, research council persons and from the national institutes, everything is 180 persons are immediately we are going to be giving the training. As far as the research is concerned, actually now this has to be materialized. Now whatever the research works are going on in standalone manner. So standalone manner, what is the problem is actually that there is no very specific peer review and the outcome, whatever the outcome generated is not addressed, not appropriately populated into the mainstream treatment regime. So only if we are doing with a very convergence, one kind of consortium level of implementation, then only that outcome will be percolated into the mainstream treatment regime. So for that purpose also, we hope that through this MOU, we can easily have that kind of research works. capacity building of the in-service people. So this you can consider as one of the capacity building measures for the in-service doctors. Similar, not only here actually, in each and every part of the country, this has to be percolated, then only it can have that. Then promotion of the adjuvant use and adjuvant use actually, many of the single drugs, as I told earlier, actually many of the single drugs we are actually try to popularize, but rather than that actually very clear cut protocol should be there to use judicious use of the treatment principles of the Ayurveda. In TB, certain, this is the last slide actually, certain studies, research studies actually already initiated by the Research Council, particularly CCRIS under the Ministry of Ayush has taken research study on Ayurveda and hepatoprotection as an add-on to anti-tubercular treatment. Another one is Ayush PTK, there is a coded formulation, particularly in the case of the concomitant use of the Ayush drugs in the tuberculosis. So for that, the earlier aspect of the drug development, the standardization, preclinical studies and clinical study is now going on. Another one is evaluation of hepatoprotective activity of Ayurvedic formulation in the patients of pulmonary tuberculosis as an add-on therapy. This is a RCT, double-blind RCT. This is along with KLE. You may be knowing that KLE institutions in Belgaum. Along with that institute, it is also undergoing by the CCRIS. Council also undertaken the preclinical studies on Amalaki, Guduchi, Avasha, and as a therapy in tuberculosis. As I told that these studies may have certain limitation, but otherwise very systematically, if you want to do it, actually the protocol has to be done. Recently, the council has also undertaken projects to study antimicrobial activities. Okay, antimicrobial resistance AMR is one of the things actually. So on that ground, actually, the use of prebiotics of Ayurveda plants and formulation, that studies also is undertaken by the CCRIS. And lastly, this public health initiative, whatever the All India Institute of Ayurveda, they have undertaken this study. Based on that, this training program is being conducted. So with this, I end up my this small brief insights into what the ministry is currently doing. So you can imagine that tuberculosis, the subject is, if you want to very clearly engage with the mainstream health system, actually first of all you have to clearly delineate a very clear-cut protocol in which at various stages, whether it is in the case of prevention. So one attempt is, now we are doing this one, the latent tuberculosis, where we can clearly target the patients with that. Another one is the community engagement. Second one is at the time of rehabilitation or the long-term follow-up, how the Ayush can be easily integrated with that. Thank you. Thank you very much. So if you have any discussion points or that we can have.
Anyone have any question?
Just how I mentioned that Ayush PTK is by the Research Council, CCRA, this is a coded formulation. बाकी जो individual drugs के अनुसार many Vasha, Guruji, Ashwagandha, like that, but that is not very specifically only for the TB. It's a concomitant use, particularly to the promotion of the immunity and other things the research councils are doing it. Individual institutions, I don't think much has been done. You can, if you search the Google Scholar and other thing, Devnath Banerjee from the Kolkata, which he has studied in 2012. So that is one study that which is easily reported. Before that, in 1998, also some isolated efforts were done. But very comprehensively, as per the strict protocol for a comprehensive formulation-based study, in concomitant, whether it is a concomitant use in the tuberculosis, whether, for example, reducing the active tubercle formation in the tuberculosis, in the reduction in that, for that such kind of studies is yet to be done actually. That is what, yes, in the teaching institution that have been done, but until and unless it is scaled up to that level, and under the rigorous, what you call the clinical protocol, if it is not monitored, we cannot claim into that in the public domain. So obviously there is a large what you call scope for particularly Agastya, whether it is Agastya Haridagi, whether it's Chitra Haridagi, even many of the what you call early stage हमारा जो decoctions are having a very important role as far as the this disease condition is concerned. Sagulatham, Sayavam, Sanagaram, Sapipali. So that is the finite formulation that we, when we study our principles, the basic principles in Ayurveda, that formulation as per the principle, based on the principle, if you can make a protocol and that will put into the public health research domain, that would have more value addition for that.
Any more questions?
No, that is what I am saying. That is what I am saying. See, when you study it actually very, very clearly, a very specifically highest level of research consortium, if you design that kind of studies, and if they consciously decide that a concomitant use of Ayurveda, traditional medicines should be part of that, and a treatment regime, and only at present, what I perceive that actually only with Ayurveda medicines alone, that kind of research studies, if you without any comparison, if you are going to do, that may not be coming into the public domain. So current treatment regime, while following the current treatment regime, along with whether there is any scope for the treatment, that is the first attempt that we are supposed to do. So I think that would be the one of the things. But obviously I have a clear role that one single drug, just like up you say that Guruji de denge, Ashwagandha de denge, that kind of, I don't think that would have much value addition to that kind of studies actually.
Mike?
Sir, since morning, as far as I can understand, we are talking about latent tuberculosis. We are not talking about the treatment purpose, but we are talking about the measures which by which the Ayushvi Ayurvedian, we can help to boost up the immunity so that the recurrence, we can stop the recurrence, right? So, sir, my question is that we just, as you say that we are talking about only Vasa, only Chitra Kharidki, these are somewhere the treatment sort of things, right? So, when we are talking about treatment, because my father was, one of the patient of tuberculosis, and he was a complicated case of CKD, diabetes, and I have treated, I have the evidence. I have, because ATT, because after giving the ATT, SGPT, SGPT or SGOT was above than 2000, and because he has a complicated, we can say the syndrome that we can't do anything. So at that time, only Deepan Pachan Chikitsa, because his weight becomes from from 60 kg to only 42 kg. So what I did, I gave Deepan Pachan only, and after that Chagalyadi Ghritam, which matlab tremendously, matlab I can say extraordinarily, which I see, I could saw see the result कि with Chagalyadi Ghrit he put on his weight. और तो हम लोग जो हैं वो केवल एक वासा या अश्वगंधा, मतलब हर चीज़ के लिए, इम्यूनिटी के लिए हम हर चीज़ में गिलोय खिला दें या हर चीज़ में अश्वगंधा खिला दें और उसको एक बिल्कुल वो कर दें कि बस सब चीज़ में, बिकॉज अश्वगंधा और गिलोय के अपने भी वो चीज़ें हमारे को नहीं दे सकते. तो इन दैट केस क्या हम केवल दीपन पाचन पे काम करके, क्योंकि इम्यूनिटी एक नॉट अ थिंग कि एक दिन में आ जाए, किसी को हमने खिला दिया, एक दिन गिलोय पिला दे तो हम कहें कि इम्यूनिटी आ जाती है. इट इज़ नॉट लाइक दैट. तो अगर हम दीपन पाचन पे काम करें आफ्टर दैट इन द लेटेंट फेज ऑफ दैट थिंग, आई थिंक इट विल हेल्प अ लॉट.
That is what I am saying. Suppose आपको बता रहे दीपन पाचन, I would say that not only the even pardon, even small annuloman, but as per the principle we have to adopt. That's all. Even the Guduji can be useful. I am not saying that Guduji, Ashwagandha, whatever, everything can be useful. But Ashwagandha at the right place, what you call the principles when you study Chikilsayam tu Pradhanam Avasthanu Vidhanam. The stage of the disease is very important actually. So in every stage there is a principle is adopted. Just like modern medicine also, they have the certain principles in treatment. Similarly, what is the public opinion when we speak about the public domain as a populism? We say that ashwagandha hum cure karenge. That should not be the way in which a medical system, yeah, even a health system should adopt actually. For that, as you told, the even pajan, aniloman, even the rasayana, everything will be part of that actually. Yes, exactly. That's what.
Any more questions? Anybody?
Okay. Thank you very much.
Thank you. On the behalf of all the participant and organizing committee, I extend my heartfelt gratitude for very informative and very insightful sessions, sir, uh, on the topic role of Ayush sector and various schemes of Ministry of Ayush. Your wealth of knowledge, clear articulation, and your dedication to advancing the integration of traditional system of medicine in a broader framework, which have a long-lasting effect on us.
Thank you very much.
Thank you very much, sir.
I would like to invite I would like to invite HOD Kaichikitsa Department, Professor Dr. Jonah sir, to felicitate sir.
Thank you, sir. Now, I request everybody to please proceed for lunch on 6th floor and please be back by 2:30. We'll proceed for the next session.
दिव्या मैम की
आप ये बोल लो फिर उसके बाद
Sure, ma'am. Sure, ma'am. It will just take.
yeah, take your time, no hurry. पीछे रख दो.
Ma'am, please sit on the dais. Yes, ma'am, please. स्टार्ट करते हैं. टाइम आ चुका है, अच्छा नहीं लगेगा. आप स्टार्ट करो. दिव्या मैम नहीं. दिव्या मैम नहीं है. दिव्या मैम कहाँ है? कोई नहीं यहीं पे दो रहने दो बस. विधि दिव्या मैम कहाँ है? दिव्या मैम हम ना पहले मैम का सीवी पढ़ना चालू करते हैं. सीवी यही है ना, इतना ही है ना. इतना मैम इसमें सारा है. खड़ो कर सकते हैं. 3 घंटे में हम आ जाए हम क्लास स्टार्ट करते हैं. बिकॉज कोई एक हमारा टीचर तो रहना चाहिए ना. कॉल करो ना फिर. मैम बैठी हुई. वी कैन नॉट वेट. नाउ लेट्स स्टार्ट. वेलकम बाद में कर देंगे, कोई दिक्कत नहीं है. बोल देंगे मैम.
Good afternoon, everyone. Now let's start with the third session of the today's afternoon of Dr. Urvashi Singh, ma'am. She is a professor and in charge of tuberculosis division in Department of Microbiology, All India Institute of Medical Sciences, New Delhi. Her extensive research portfolio span various critical aspects of tuberculosis, including adult and pediatric tuberculosis, treatment regimen of tuberculosis, drug-resistant tuberculosis, epidemiology, diagnostic tools, and various biomarkers.
Her groundbreaking research includes an in-depth exploration of Mycobacterium tuberculosis, focusing on understanding its epidemiology, drug resistance mutations, molecular typing, and whole genome sequencing. Dr. Singh ma'am's pioneering work in detecting viable TB bacteria in treatment failure patients, coupled with her research on therapeutic drug monitoring, has direct policy relevance. She is at the forefront of developing novel diagnostic methods such as cost-effective tests for the rapid detection of multi-drug resistant and extensively drug-resistant TB.
Ma'am have a numerous contribution in a scientific field. Ma'am have a various patents with one cost-effective diagnostic test for MDR and XDR TB already validated by the ICMR and set for implementation.
Beyond her research and diagnostic advancements, Dr. Urvashi B. Singh ma'am is actively involved in national committees and expert groups, shaping policies and strategies for elimination of TB in India. Please join me in extending a warm welcome to ma'am. I request Dr. Divya Kajaria ma'am to welcome our esteemed speaker, Dr. Urvashi B. Singh ma'am. Yes, ma'am. I'll take the laptop.
क्या करें? पेन ड्राइव में ले?
Good afternoon. What I bring to you today is the current thought process of latent TB infection and not what we used to think about, say, 10 years ago. So that is why I have named the lecture as Evidence Revisited. I'm going to bring in the tests available to us a little later and also deal with the issues we face when we do these tests. The idea is to actually widen our perspective. You must have seen, must have experienced a lot of infectious diseases, and you must have used different diagnostic methods for diagnosing infectious diseases, which involves a lot of immunological tests, where sometimes you're using antigen tests, sometimes you're using antibody detection to call a disease as being caused by one particular pathogen. So why are we treating TB differently is the question that I ask you right in the beginning. And hold that question till I come to the tests and we deal with it. I think the hosts, Dr. Divya, in fact, I must thank Dr. Divya and the Institute for having me here. I am an MBBS, MD, and PhD, and I've been at AIMS for 30 years. But I never knew till I met her that Ayurveda is having such a major influence for our patients, for our community. And, personalities like her, actually such a strong-willed, committed researcher as her in the field of Ayurveda. I'm sure there are others, but knowing her has been a pleasure indeed. And it's always good to get the best of both worlds. So if we can actually have the other sciences, medical sciences in the sense of allopathic sciences, Ayurveda, and if possible, any others, especially where the understanding is common, and make the most of it. So I'll try to do justice to specialists in the field of Ayurveda by bringing in the basic concepts. So, WHO once estimated that approximately 1/3 of the world's population had been infected with Mycobacterium tuberculosis. This is the concept which is very widely held today. Now, remember the question I asked before the lecture started. What is this based on? These are actually estimates. If you look at the recent reports, they don't write this. So, till a few years back, WHO was writing 1/3. Earlier, they used to say 1/4 of world population has infection with MTB. They moved to 1/3, and recent reports do not talk about what percentage of the population. So if you look at past 2, 3, 4 years reports, they don't mention it. So what I want to bring to you today is the basic pathogenesis of TB in its molecular terms. So all of us are clear. This is a pathogen which is a very tricky pathogen, has umpteen number of antigens, very smart, knows how to play with our immune system, knows where to hide and where to duck and where to stay quiescent for years together. Why do we say older age group people get more TB? Because their immunity will go down, several factors. So what can happen if there's exposure to TB occurs? For example, if you're sitting in your OPD, there is air currents are not controlled properly, you don't have a window and the air is recirculating. The aerosol generated by the patient is staying inside the room. So what is the frequency of no infection after exposure? So this is again an estimate. 2/3 of TB contacts don't test positive, So what I would also like to bring in here is stone in the pond principle. If you throw a stone in the pond, there are ripples. So which of these ripples is actually getting infected? This was said by Snow several years ago. We do not know which of these patients are actually getting infected and why. I will come to that shortly. So whether the bacteria are dead at contact, which is unlikely because this is a patient who has active TB, is most likely shedding live TB bacilli. Second situation could be that there is exposure, there is infection, but there is no disease. So 90%, this is an accepted fact traditionally being taught to the students, that 90% of those who are exposed to infection will get rid of the infection by a good immune response. The immune response includes both the innate as well as the adaptive immune response. If that is strong, 90% patients will get rid of the disease. So this is many times more the scenario than those getting disease. As you can say, 90% are able to get rid of the disease. Now, the latent period, like I said, could vary from a short period, even 1 month, to several years. So, the latent period is variable, and the chances of reactivation can be 5% in the rest of the life, 5% in the near 5 years. This is the age-old concept traditionally taught, right? I will probably, so this is the summary of what I said. Person is exposed. In 90% there is no sequela. So the innate immune response is strong. Innate immune response just involves the airways and the cells like macrophages, dendritic cells, mucosal epithelial cells in the respiratory mucosa. All these will engulf the bacteria. If these cells are able to remove or kill the bacteria completely, these macrophages, dendritic cells and the other cells in the mucosa will not go to the lymph node. So the classical characteristic path is to actually macrophages will engulf. So here, if you may appreciate, I think I'll use the mouse as the pointer. So this is the alveolar sac where the macrophages, the other cells are actually engulfing the Mycobacterium tuberculosis. These then pass into the interstitium. These are infected macrophages which pass into the interstitium. From the interstitium, so in the interstitium, of course, here's a granuloma shown here, which is the classical teaching, but actually adaptive immune response will be generated once these macrophages come into the interstitium. They will infect other macrophages in the interstitium. So these are interstitial macrophages. If you may notice my mouse here, these along with the macrophages which have moved from the alveolar sac will go to the lymph node and activate the T cells. Now, what can happen is if the innate immune response is strong, it may just dispense of the bacterium without any CMI. So you do not even have a marker of cell-mediated immune response because it never went to the cell-mediated immunity in the lymph nodes. It has got rid of the infection completely. So there is no memory. Memory, I mean the CMI memory, the cell-mediated immune response memory. Nothing is there. So in these patients, if you test tuberculin skin test or interferon gamma release assays, there will be nothing. It will be all negative. So that is when the immunity is very strong. If not, the lesions will be healed, or there may be latent lesions which in the future could get caseated and lead to secondary tuberculosis. In some instances, there may be primary progressive TB. And also, when I said the macrophages move around, so they can move around through lymphatics and through blood to different organs and involve almost all other organs. This is where I'd like your attention. Now, so what we are getting is if there's infection at the, exposure to infection could get eliminated if the innate immune response is strong enough. If not, patient will get latent TB. The line here indicates latent TB. If the patient's immune response is so weak that the innate does not activate the adaptive, the patient may get primary TB, primary progressive TB, which happens in small children. Now, latent TB of late has been described as a cyclical disease, and that is what I want all of you to be aware of. It is not a black and white, but a grey zone. The grey zone is influenced by our immunity, and that is where Ayurveda can actually help. Where the allopathy may not benefit, we have treatments where immunity can be enhanced. So to clarify it further, that from the latent TB bacilli, what I showed could lead to a granuloma which is completely fibrosed, which cannot reactivate. Fibrosis is ensured by the immune response. The immune cells followed by fibrosis will keep it together and will not let it caseate or spread. While there may be instances, what we call as incipient TB. So there may be activation from latent TB and follows the steps of incipient, subclinical and then active TB. In incipient TB, there will be no microbiological or radiological test that will show it as active TB. But in subclinical TB, we will get, you will appreciate this here. So if we have these 4 groups, One is infection has been eliminated, where we will not have any sign of cell-mediated immune response like TST or IGRA. No culture, no sputum smear. There is no infection practically. Patient has no symptoms, and we don't need to treat this patient. But in latent TB, what we find is TST in IGRA is positive. Patient may not have any symptoms at all. So this is a misnomer. A lot of people think that patient with LTBI will present with some symptoms. No, the patient will not present with any symptoms if the patient has only latent TB. If the patient has active TB, there will be symptoms, and in subclinical TB, there may be mild or no symptoms. But how we differentiate between latent to incipient to subclinical is by looking at the microbiological test, which will be positive in subclinical TB, and they're intermittently positive. Unless you are screening the patient again and again for, say, sputum culture, you will get it is intermittently positive, and the patient has very few or no symptoms. So the patient may not volunteer to come to you. Now, when we talk of TB elimination, we need to target these patients, because if they are positive in microbiological tests, they're obviously disseminating infection. So, of course, the burden of disease is the active TB disease, which needs to be clearly targeted, and for now, we are not doing active case finding. We are treating patients who come to the clinics for treatment, which of course needs to be done, but we must actually be looking for active TB disease actively. We were discussing earlier during the lunch that active case finding is something that we need, but with a large population like ours and a large endemicity like ours of TB disease, that is an added challenge. Of course, incipient TB is one of the steps towards active TB, and we do not have a signature of incipient TB really. So this is what we call as incipient TB. Like I said, from LTBI activation, the immune response, immunity could actually enable a disease to progress or control it. So here so what I want to highlight again is, the culture may be positive and radiographic abnormalities may be seen in subclinical TB, while in incipient TB, these are not there. There is no radiographic abnormality, and so on. So for the sake of definition, how is latent TB infection defined? It is a state of persistent immune response. Now, I'm reiterating, it is a state of persistent immune response to the stimulation of Mycobacterium tuberculosis antigens with no evidence of clinically manifest active TB disease. It is the presence of Mycobacterium tuberculosis in the body without signs and symptoms or radiographic or bacteriologic evidence of TB disease. These are WHO definitions, right? But I want to open your perspective, widen your perspective to the fact that there is something called as incipient TB, there is something called as subclinical TB, and there may be something called as just a cell-mediated immune response. So all TST positive or all IGRA positive do not actually signify live bacteria inside the patient. I'll come to that with more evidence. Give me in a few minutes. So this is what is classically said: 1/3 of world population infected, prevalence of 50% to 60% of LTBI. This, of course, again is an old fact: lifetime risk of activation of 5% to 10%, which changes in people living with HIV, PL-HIV. This is much higher. So what is said is this represents a reservoir of TB. But what I showed you a little earlier was, if our immune response is strong, we may be actually able to eliminate it. And now these are a few risk factors that I mentioned. One was PL-HIV. Close contacts of TB will be a higher risk. Organ transplantation recipients, because they are given immunosuppressants. They are given immunosuppressants so that they do not discard the transplant, right? So it's called graft rejection. Then patients with chronic renal failure, on dialysis or even off dialysis, their immune response is affected due to other molecular factors. Patients now in allopathic medicine, a lot of TNF blockers are being given because that is the only treatment in some of the rheumatoid disorders, some of the disorders like Crohn's disease in the gastrointestinal tract. The catch is that these patients have no other option, so they're given TNF alpha blockers, which is an important mediator of response to TB. Hence, these patients can get reactivation or even reinfection. Another group is silicosis, patients who are working in, cement factories or working with sand, brick factories, silicosis may be there. In these patients, because of the scar tissue, because of the fibrosis in the lungs, these patients may be predisposed. Fibronodular disease on chest x-ray, immigrants from high TB prevalence countries. We are a high TB prevalence, in fact, the highest TB prevalence country, and at least we acknowledge some other countries cover their data, so we do not. So this is just a Venn diagram to share with you. What we are detecting is the smallest circle, which is microbiologically confirmed, while the true active TB is the pink circle, which is bigger than that. To you, it's appearing as orange here. Now, true active TB may not be microbiologically positive. Not all with true active TB may have clinical symptoms consistent with TB. So what I'm trying to say here is, in a certain population, we need to treat them based on the clinical symptoms. So these are clinically confirmed cases of true active TB. A bigger circle still is the percentage which is infected, and the outer circle that I showed you is the ones exposed. So this again reiterates, not all those who are exposed are infected. Not all those who are infected will develop true active TB. Usually, I'll come to this later, true active TB occurs within 2 years and so on. And a smaller percentage still are microbiologically confirmed, primarily because we do not have all, the best of tests possible. We have wonderful tests. For example, in pulmonary TB, we have nucleic acid amplification tests, which can give us, almost close to 90-95% sensitivity. But for extrapulmonary TB, we may have issues. And also in different conditions, for example, like I said, in predisposing conditions, the presentation may be different. For example, in PL-HIV, people living with HIV. Now, immune response to TB doesn't only control the disease. In people living with HIV, you will understand what I'm trying to say. Since the immune response is weak, there is poor granuloma formation. The granuloma formation is meant to contain the disease, but in turn, sometimes the immune response overshoots and the granulomas lead to formation of cavities. Cavity formation is beneficial for the TB bacilli because the cavity can lead to spread and transmission around. But for the patient, it can sometimes be difficult to treat and so on. Now, what I was actually trying to say was that this immune response which overshoots, in fact, it's because of that we also need to add steroids to TB meningitis patients to contain the immune response so that it doesn't lead to, excess of immune response, which can lead to fibrosis, which in the case of TB meningitis could be very, very harmful. So, I think I'm going to come back to these facts again and again. Now, this is something that I just wanted to bring in to again widen your perspective. Like I'm saying, what the basics you're all aware of. You need to know what is the current evidence assembling and accumulating. So, in 1939, Kennedy, who's a well-known name, reported that majority of primary lesions become sterile over years, and most episodes of recurrent TB are due to reinfection, other than the patients who are at risk, where there may be reactivation. But again, that is also under debate. So, an alternative hypothesis is, therefore, that a primary infection primes the immune system in such a way that it responds differently and more violently with a tissue-destroying hypersensory reaction as described by Koch. Now, what is also important for you to know is persistence of MTB leading after an undefined incubation period to clinically manifest TB is an undisputed reality. So, whether the persisting bacilli were actually persisting or it came afresh. So, a persistent subclinical or latent infection with such a small number of bacilli that is insufficient to produce clinically manifest disease unless some changes in immunological response allow these bacilli to metabolize and multiply at a high rate, reaching such numbers that overt clinical disease ensues. This can only happen in immunosuppressed people. Now, why are we talking so much about latent TB? Because of the age-old concept that the latent TB is the progenitor of active TB, which may not always be the case. And I just want to correct the age-old belief with the new evidence. Now, this is the need for diagnosis. Now, as you can clearly see, early diagnosis plus DST is to be done for all active TB cases. But diagnosis of at-risk patients, the list that I gave you 3 slides earlier, is very important because you will catch the disease before it becomes florid. So like I said, if you can screen patients of, PL-HIV, those on TNF-alpha treatment, with chronic kidney disease, those with diabetes, if you screen them for active disease by simple culture, you could actually catch them when they're having subclinical TB, which is not yet recommended even under the program because, like I said, the burden is too high. Now, what is the relevance of diagnosing LTBI? Again, the relevance of diagnosing LTBI and treating LTBI is in the at-risk population. I think Dr. Ankita is going to speak after me and she will delve more into the burden. Let me come to the tests available for diagnosis to us. Now, like I said, all possible tests for the best diagnosis of TB are also not in hand. We are only focusing on detecting the live bacilli by looking at the culture. We can do smear microscopy, which will pick up both live and dead bacilli. But of course, once the active TB is cured, the dead bacilli will not be there, even the live bacilli will not be there. The other mainstay of diagnosis for active TB is the detection of nucleic acid amplification test. What we are not able to look for right now is maybe 20 years hence, maybe when you are my age, there will be tests which pick up the immune response using better antigens or using better methods. Things like, I have a few slides later where people are looking at gene signatures. So gene signatures actually tell us what is the immune response of that patient at that particular point in time. So let us come to that in a short while. Now, this is classically doing what? We are looking at the response of the T cell to an antigen stimulation. So whether we do a tuberculin skin test or we do interferon gamma release assay, which is an ex vivo test. Why ex vivo? Because we are extracting patient's blood. From the blood, we are exposing the lymphoid cells, the white cells, to an antigen inside a tube. We call it ex vivo when the cells are live. So here, the lymphoid cells or the white cells are live and we are exposing it to an antigen and we look for the release of interferon gamma from these T cells. I hope I am clear. It's not an in vitro test, it's an ex vivo test, and the other, which is we inject tuberculin into the forearm of a patient, that's a tuberculin skin test, which is an in vivo test. Right? So the difference between the two is only that here you are stimulating the white cells outside, while in TST you are injecting the antigen into the body to look for the response to the cell-mediated immune response, which is measured by the the width of the response after 2 days. Here in the IGRAs, what are we doing is we are taking blood from the patient, we are exposing the antigen presenting cells to an antigen, reading it again after 2 days. So they are almost similar to each other. Here in tuberculin skin test, or what you call as Monto's test, there is intradermal inoculation of antigens, which is nothing but a purified protein derivative. We look for local immunological recognition of antigens in previously sensitized patients. Local inflammation or induration in these patients is seen. By previously sensitized, they would only be sensitized if they are infected. In quantiferon, we stimulate blood cells with antigens, we incubate the cells overnight with antigen, and we detect interferon gamma produced, and we look at the units of the interferon gamma produced. Or we can also do what is called as T-spot TB assay. As you can see, this the T-spots are looked for. And so these are, like I said, are similar. Just a repeat of what I've already said. Now, these are publications which have compared the three to each other. In this particular study published in 2008 by Madhukar Pai, they've shown that sensitivity of T-spot TB was slightly higher than that of quantiferon golden tube test, GIT's golden tube test, or TST. These were early studies in 2008. I will also bring to you, let me come back to this IGRAS conversion reversion, but first I want to compare the different tests, sharing with you different studies. In 2011, this study was done in PL-HIV, where they showed that T-spot TB was again better than quantiferon, and in HIV negative they were almost at par. Head-to-head comparison of these two was done. And in children, this is a study which showed that pooled sensitivity of tuberculin skin test, quantiferon golden tube test, and T-spot TB test were almost similar. Pooled specificity varied because what they say is in quantiferon, the antigens used are just two, ESAT6 and CFP10, while in tuberculin we have the whole tuberculin, which is composed of more than 200 antigens. So That is why a lot of industry-driven push is to stop TST and use IGRA. But we, in our studies, I think I have some of our studies here also, have shown that in India, in children, we found them both at par. Now, this is a study from CDC, Center for Disease Control in the USA, TB epidemiological study consortium, who did interferon gamma release assays in healthcare workers, and longitudinal study of healthcare workers has been done in 4 sites. And what they showed was, now what Dr. Divya earlier was discussing was reversions and conversions, and here is what I want to bring to you. In this study, like I said, was done in 4 centers: Baltimore, that is Johns Hopkins, Denver, New York City, and Houston. And what they did was quantiferon golden tube test, T-spot TB, and TST every 6 months, 4 times in healthcare workers, mind you, healthcare workers including nurses and doctors. So what they showed was reversions happened in TST positive. By reversions, what would we know? The patient was TST positive to begin with, and if they repeated after 6 months, the patient became TST negative. So in quantiferon GIT positive, also there was percentage with status change among those retested. In 57% there was reversions. In T-spot TB, in 64% there were reversions. So differences between these 3 was not significant. If we looked at TST negative patients, there were conversions again, that is from negative, they became positive. In TST negative, numbers were quite high, these conversions were noticed. And in GIT, again, these conversions were noted. Here what they've highlighted is statistically significant difference between TST and the other 2, which are based on the ex vivo test. And so basically the point I want to drive home is if there's a change of status with time, within 6 months, without treatment, so these patients were not treated, what does that tell us? That these tests are not adequately reliable. And there's enough evidence, enough data to actually say TST and IGRAs more or less go hand in hand. About 70 to 80% they go hand in hand. This is another study published in 2013, which is a retrospective study of quantiferon golden tube in healthcare workers at Stanford, similar to what we showed earlier. Here they took healthcare workers. So initial quantiferon positive were about 1223 patients, which were 13.4% patients. Initial quantiferon negative were about 85.6% patients. Of the quantiferon positives, 67% remained positive and 32.3% reverted. They became negative. While in the quantiferon negatives, 4.3% became negative to positive, and while 96% almost remained negative to negative. So discordant results on subsequent testing, conversions were to the tune of 6.3%. and reversions negative to positive to negative. So here, if you may notice, they converted back. So they became from positive to negative, and then they became positive again in 6.3% of these 32.3%. Here again, they reverted from negative to positive. What they turned negative here, positive again, and again negative. So this is, I'm sure, quite confusing for you, and I actually did not want to go into these many details. The only message I want to bring to you is you cannot blindly trust any of these tests. Your clinical acumen, your clinical assessment of the patient is what is most important, and to base your treatment on a test that does not even stay positive if it is positive is something which I would not recommend, and most people agree here. Now, this is again another study, serial quantiferon GIT testing in healthcare workers in North American settings, a non-systematic sampling. So, percentage of conversion after initial negative was 4% in Slater et al. 2013, 6% in Susan Dorman's paper, in 5% in Zwirling's paper. So, practically these were, in the range of about 3 to 6%. Reversion after initial positive. So you may have, once you got a positive, you may have decided, okay, let me treat this patient, and look at the results. So 32% to about 80%. Fong et al. Published in Chest 2012. These patients, of course, the numbers here are small, and here the numbers are 1200, close to 1200. So this many patients actually reverted, and this was done as retrospective routine practice. So if they wanted to treat based on this, they may have realized it was an error. But not all the tests are useless. Now this is a study done in Korea where the investigators actually looked at confirmatory quantiferon added to a positive TST. So they reviewed pre and post course of sequential TB outbreaks in a high school where massive 43 active TB cases had been found. So for them, a number of 43 is massive. So I want to awaken my colleagues. For us, active TB is something that really needs our attention. So, investment in terms of time, energy to actually diagnose active TB and treat them will take care of the epidemic. Latent TB is something we must be aware of. These tests we should know how to put them to use, but we must not be depending on them blindly. So these are the strong messages I want you to carry home. So they investigated TB development in relation to initial TSC and quantiferon during 3.9 plus minus 0.9 years. So what they did was, now I want you to pay attention here, this is very beautiful. They also did contact investigation for 2 subsequent TB outbreaks. Amongst 925 contacts, which is a good number, they made it into 3 groups. TST in 632, TST positive, quantiferon positive. TST negative was the first group, second was TST positive, quantiferon positive. Third was TST positive, quantiferon negative, which is again a substantial number. Now why I bring this here is a lot of you may perfect and we possibly may have better tests in the future. So of these 3 groups, what they found was quantiferon negative was more prevalent than quantiferon positive in contacts with TST less than between 10 and 15 compared with TST more than 15. So when TST was more than 15, which is a marker of treatment for us, we treat once it is more than 15. Here quantiferon never failed. One message is that. So if you are struggling with lower TST values, lower TST diameters, there quantiferon was playing tricky. So there was no debate. TST more than equal to 15 is signature of active TB and you will treat them. Among 258 TST positive quantiferon negative subjects, 256 received no latent TB treatment, but 7 contacts developed TB during follow-up. So what does that tell us? That TST positive contacts develop disease. So TST positive, so what, I don't know, traditionally we have actually had the rule of the whites for a long time, so we tend to trust them more than ourselves. TSC was our test while quantiferon came in much later. So a lot of people tend to trust the quantiferon test more. This is an awakening call for you. The TST actually gave us the signature of active TB which was coming later. Among these 7 patients, 4 had initial TST more than 15 millimeter and 3 had 10 to 15 millimeter. So to conclude, the delayed contact investigation for LTBI in a high school resulted in continued TB developments because we did not treat those where TST was giving a signature result. False negative quantiferon performed late among the TST positive reactors should not be considered criteria for so basically contacts who had TST more than 15 millimeter should be considered for LTBI treatment in congregate settings of intermediate burden countries. Now they speak for themselves. The message I want to bring in here is trust your test, especially when it is giving you a clear demarcation, and do not worry if the other test is not giving you the demarcation. Now this is something new. CTB test just got approved by ICMR about a year or 2 ago, and this is in fact being tried in phase 3 trial, and so this was shown as safe and showed similar test positive rates compared to TST and quantiferon in children and HIV infected persons. Please remember these are the at-risk group. Children I probably did not include there because traditionally they will not be called as at risk, but they have lower immunity as compared to all right. Now this is again what I have said earlier, and these are the newer tests for diagnosis where I'll just like to quickly run through these. I don't know how much time I have, but I'd like to still bring this to your knowledge. Now what we are coming up is RNA signatures, interferon gamma release after T-cell stimulation with newer antigens. So earlier we just had these two. Now several new antigens are coming. Then we are looking for cell differentiation markers, for example CD27, cytokines levels in blood, IP10, STREM2, our publications, some of them are under communication. Now this is a paper I actually wanted to bring in to talk about biomarkers of disease progression from latent to active disease. There are definite biomarkers which are being looked for. Now this is a complicated slide which you may not appreciate. So I have a summary later where they've looked at markers which, for example, the red markers here are increasing in progressors, and the blue markers are actually reducing in progressors. So we just utilize the same cytokines we've been talking about in the pathogenesis and look at their levels to predict whether which patient is going to relapse into disease. Now these are microRNAs which have been incriminated with disease or control of disease. So microRNAs, this slide summarizes in latent TB infection where the focus has been properly walled off. We've used microRNA 21 SP and 155 SP and so on and so forth. Now this paper talks about detection of MTB DNA in peripheral blood mononuclear cells of asymptomatic TB contacts. So again, what we are looking for, DNA in sputum, for example, in GeneXpert or TrueNAT test, the nucleic acid amplification test. This paper talks about looking at the DNA in the peripheral blood mononuclear cells. And this paper talks about detecting methylated HBHA in patients with, this paper talks about the TAM-TB assay. So when I talked about host immune response, so for those who are getting bored, I'm coming to my conclusion. But it will be good to know that on the horizon we have several tests which are using host immune response as signatures of disease progression. So what we are looking for is gene signatures and 3 gene signatures, and so there is a new cartridge, GeneXpert HR, where few papers have come in which gives very good results. It's the Cepheid has taken the Sweeney's 3 gene signature. So the signature of the genes, whether they are overactive or underactive, like I showed you in this previous picture here, that these markers are either increased or decreased, and by their pattern we can say the patient. So in a few years time you will get such a pattern as a report from the lab, and you will have to assess for yourself what is going in favor of disease and what is not. So to conclude, I have about 2-3 slides. I'll stress on each of the points. It is not known what proportion of individuals who had once been infected remain persistently infected. That is a very important message, that though we may say, okay, the cell-mediated immune response is there, whether that signals, so you're aware IgG in certain certain infections or diseases is not a signature of active disease. Immunoglobulin G is not a signature, while immunoglobulin M, IgM, is a signature. Classical example is torch, where you cannot say just by looking at the IgG that the patient has disease. So why are we doing that to TB? We see the cell-mediated immune response, we say, oh, the infection is there. Infection may have been cleared off. Maybe the antigen just came, hit and ran away. But the CMI is there. The cells have been exposed and they're active to, they have active memory which can deal with a new antigen assault. Detection of an adaptive immune response towards mycobacterial antigens is only an indirect measure that represents a footprint of a contact of the immune system with these organisms. Again, a repeat of what I've been saying. Whether long-term persistence of adaptive immune responses depends on the presence of living mycobacteria is an unresolved issue. So this is something where the debate is on, and I hope we will resolve this debate. Now, latent infection with M. tuberculosis may best be defined as a state of persistent immune response to prior acquired MTB antigens without evidence of clinically manifest TB. IGRAS and the TST detect lasting TB immune response. Again repeating, it is only picking their immune response, but not necessarily identify true latent TB infection, which we would say has viable bacilli and potential risk of developing active TB by reactivation. Right? So we recently published something else which actually showed us polyclonality in a patient. By polyclonality, we had different strains of TB, different lineages of TB in almost every patient. Earlier this was known in MDR TB patients. We showed in sensitive TB patients also. So if a patient has different clones of different lineages, how can you ever prove that the same lineage was present earlier? So those earlier studies which showed reactivation because it was the same lineage which caused disease 20 years ago is again put to null, right? So this is something we need to have more studies on. So the current thought though is that M. tuberculosis frequently establishes a latent infection, following which there is a reactivation process that leads to active TB disease after a long and variable incubation period. Rather, the incubation period of TB is typically several months to max 2 years. That has been shown. So most likely instead of reactivation, there may be only reinfection or a fresh infection occurring. There is no evidence for a bimodal distribution of TB that distinguishes primary progressive TB from reactivation TB. Immunoreactivity to TB does not necessarily indicate the presence of live bacteria, as reactivity can persist after infection has been cleared. So if we are classifying 2 billion people in the world with evidence of immunoreactivity, that is all the evidence that is there, and some of it is estimates actually. We do not really have the true numbers of how many are TST positive, those are estimates. So if we want to say 2 billion people have latent TB infection, we would be running after them, trying to treat them or trying to diagnose them, and we will actually stop worrying about the major killer, which is active TB disease. So of course, one could enhance the immunity in patients who could have possibly had latent TB infection, and especially those at higher risk, but our target should always be active TB disease and those who may be progressing to active TB disease. Thank you so much for your patient listening, and I can take questions now.
Do we have any doubts, any queries?
Any questions? Either I was too clear or not clear at all. Any questions from your experiences in your OPDs, your wards, your patients? Right. Complications of?
Tuberculosis infection, and
So-
we are getting.
So tuberculosis infection or TB disease? Because TB infection is the term used for latent TB infection. So, I mean, I can start and not stop. Complications of TB per se. So if you remember this, when I showed that, the macrophages, once they're laden with TB bacilli, they will go anywhere. They will go involve any tissue. So practically it could involve any tissue. And what is the sad part is, it can have hematogenous dissemination, it can have lymphatic dissemination, it could involve your lungs, your liver, brain. So the problem of this extrapulmonary TB can be several fold. One, of course, to diagnose extrapulmonary TB is tricky because to get the right sample is not always easy. Then the treatment in itself is very tricky. We have published some papers on pharmacokinetics, pharmacodynamics. The treatment given to extrapulmonary TB is the same as given to pulmonary TB. And not all these drugs may be penetrating these compartments very well. Especially, we just concluded a study in TB meningitis where the mortality is to the tune of 30 to 35%, which is a very well-known fact. And forget about this, may be just the tip of the iceberg. Only those who are diagnosed, we lose 30 to 40% patients. What we have just shown on the paper is under communication, that rifampicin, which remains the mainstay of treatment. I'm talking of allopathic treatment. I'm not really aware what Dr. Divya would be using in such patients if they are. Rifampicin stops penetrating does not get into the CSF after 1 month because the blood-brain barrier closes as soon as the inflammation is gone, and rifampicin doesn't get to penetrate. So what we are treating these patients with is intensive treatment. We have 4 drugs: rifampicin, pyrazinamide, ethionamide, and INH. After intensive phase, we will give them 3 drugs. That also started now, but these 3 drugs, the main effective drug is rifampicin, and INH resistance, which is common in our community, common in our country, 20% plus now. So the point I'm trying to drive home is treating extrapulmonary TB can be more tricky. We may not even have signatures of endpoint when to stop treatment. Complications can be several actually. Disease per se, the patient if not treated will not survive. Especially in these extrapulmonary TB, the patient will not survive. So complications of disease, then there are complications of treatment. So it is a topic in itself. There is so much. So disease, that is why I say extrapulmonary TB does not come de novo. The pulmonary TB is the only source of entry. So often the patients may ignore an episode of pulmonary TB considering it may be a common cough and cold and they may not come to you. That is when they may come back to you with extra pulmonary TB at a later date and they are not aware that they've had pulmonary TB at one point in time. That is why when a patient with extra pulmonary TB comes to you, you will always look for pulmonary nidus also, and 50% of the times the pulmonary nidus may still be there. So the bottom line remains, if we have active case finding for these active TB cases, we may be able to curtail the epidemic much more.
Any further questions?
Thank you so much, and thanks to the organizers for having me here. Thank you.
On behalf of all the participants, I extend my deepest gratitude to your illuminating session. Your dedication to tuberculosis research and innovative contributions to diagnostic methodologies have left an indelible mark on our understanding of challenges faced in diagnosing tuberculosis. Your pioneering work in detecting viable TB bacteria, developing cost-effective diagnostic tests, and leadership in tuberculosis laboratory at AIIMS exemplify the kind of impactful research that drives progress in the field. Thank you, ma'am. I request PG Dean Sir, Dr. More, to felicitate our guest.
मैम की पेन ड्राइव प्रोजेक्ट कर देते हैं। हाँ अंकिता गुप्ता मैम की अंकिता गुप्ता बाजू में बैठे मैम क्या मैम अंकिता गुप्ता हाँ मैम हाँ कौन सी है एक सेकेंड अंकिता गुप्ता मैम का नाम पीडी ले लूँ मैं एक बार हाँ ले लूँ मैं पहले इसे कॉपी पेस्ट कर देती हूँ
It is my immense pleasure to introduce our next speaker for the fourth session of this today's program, Dr. Ankita Gupta. Ma'am, her dedication towards the respiratory medicine in the her dedicated professional contributing significantly in the field of respiratory medicine. Dr. Ankita Gupta ma'am serves as an assistant professor in the Department of Respiratory Medicine at the University of College of Medical Science, GTB Hospital in New Delhi. Her concomitant to respiratory health and her role as an educator make her a valuable asset to our academic community.
In today's session, Dr. Ankita Gupta ma'am will guide us through the crucial topic of understanding the latent tuberculosis burden in India. Her expertise in respiratory medicine, coupled with her research contributions, positions her as an authority in unraveling the complexities surrounding latent tuberculosis and its impact on the Indian population. As we delve into the nuances of latent tuberculosis burden, Dr. Gupta ma'am's insight will undoubtedly provide a comprehensive understanding of epidemiological landscape, challenging and potential solutions specific to India. Now, I would like to request Dr. Anil Kumar sir to welcome ma'am. ये ले लीजिए, मैं मैम की पीपीटी लगा देती हूँ, है ना? यस मैम.
Good afternoon, everyone. Thank you so much, Department of Chikiৎসা and the esteemed faculty for inviting me here and giving me this opportunity to throw some light on the latent tuberculosis and our understanding what we have at present. And thank you, Dr. Urvashi ma'am, for the insightful presentation. Coming to the topic what we have today, latent tuberculosis has been, as we know, how much tuberculosis has invaded our community, and it is actually hampering our day-to-day life, and so is the health as well as financial as well as social structure. So, as already discussed before, that what we understand by the definition, it's a state of persistent immune response to stimulation by Mycobacterium tuberculosis antigen with no evidence of clinical manifest TB disease. We now call it as TB infection because the term latent tuberculosis has been discarded as because it cannot always be latent, considered latent, as has just been discussed in the previous presentation. So this is just a brief of what we understand. What we get to know is just the tip of the iceberg. What we diagnose, what we see in our OPDs, in our admission, because those are the patients who are coming with you with some clinical features, symptoms. So those you are able to diagnose. But what about the patients who have not yet have any symptom, but still they have some infection? So as per the latest guideline, what we know that it is almost 35 to 40 crores of Indian population have latent tuberculosis. 26 lakhs approximately it has estimated develop TB disease annually. So it's a almost percentage, by a percentage we say it's almost 5 to 10% of people who have got infection develop TB disease within next 2 years of their lifetime. 75% of people who develop TB disease after contact do so within 1 year of TB diagnosis, and 97% do within 2 years. Molecular fingerprinting, as we have the advancement now, confirm the probabilities of developing disease within 1, 2 and 5 years as 45%, 62% and 83% respectively. Now, what is more important here to understand, it's a huge population we have, so whom to target, whom to consider, whom to evaluate. So there are two categories which we have to see. First are those who are at risk of exposure. The second are those who have the risk of progressing from latent tuberculosis to tuberculosis disease. So coming to the first category, who are those? Person living with the close contact with the active tuberculosis infection. Resident employees of high-risk congregate setting, like we have the workers, congregational facilities, homeless shelters, healthcare facilities, where we are more prone for overcrowding with the people who might have disease and we get exposed to them. Recent immigrants from TB endemic regions. India is one of them. Persons more likely to progress from latent tuberculosis to TB disease include HIV infected because they have immunosuppression. Immunosuppression itself predisposes us to have any infection. We know HIV has lots of opportunistic infection which it can have. TB is one of the most common, causing increased morbidity and mortality in such patients. Those with a history of prior untreated TB or fibrotic lesion on chest radiograph. There are a lot of patients who come to you and they say that we never had TB in the past, but when you do their investigation on chest X-ray, you might find some old healed calcified lesions, cavity, and those are the patients who might have the recurrence because already they had some infection previously. They must have taken some medicine, knowingly, unknowingly, or they must have just got self-resolving of the disease. Children less than 5 years with a positive tuberculin skin test. Yes, those are also children. Now TB does not limit to any age. It is as prevalent in the child, as prevalent in the adulthood, as prevalent in the elderlies. Yes, their fighting capacity to the disease is different depending on their immunity, but we need to consider all the age group. Underweight or malnourished person. It has been proven with various guidelines and the studies that undernutrition is one of the foremost issue which we have to target when we are treating any patient with tuberculosis, because immunity is one thing which we need to boost up, and there we need to join our hands and consider how we can do that, because once that is there, yes, we can fight back, because there's a lot of issue with patient who actually have active TB disease. They are not able to eat well. One is psychologically they are disturbed with the disease because of the long duration of treatment and long duration of symptoms. Second of all, their eating requirement, their wish to eat also reduces because of all the symptoms they have. They might have abdominal symptoms, they keep on having nausea and vomiting, and that's make them not to able to eat properly. Injection drug users, IV drug abusers, they also have lots of chances because again their immunity is very low. As discussed in the previous presentation, those receiving TNF alpha antagonists for treatment of rheumatoid arthritis or Crohn's disease or any other immunity depressive diseases in which we use these medicines, those are the patients also in which we need to consider to detect latent tuberculosis. Now, those with certain medical conditions like silicosis, diabetes mellitus, chronic renal failure, or patients who have been going on for hemodialysis, patient planned for solid organ transplantation, cancer, various cancers, gastrectomy, jejunal bypass, these are the other patients. Directly, indirectly, they also have higher chance of developing active TB. Now, coming to a little bit of data, what we have, it is being shown that patients who have contact or bacteriologically confirmed TB cases, they have almost 25 times higher chances of getting the infection compared to the normal public. 16 to 21 times the chances in those who have HIV co-infection, they develop active TB who already have the infection. 3 to 4 times in other immunocompromised status like diabetes. In a recent study published in July 2020 from India, 71% household contacts of pulmonary TB patients had baseline tuberculin skin test greater than 5 mm or quantiferon gold in tube test of greater than equal to 0.35 international unit per ml. So that's what is we need to understand. Household contacts are patients who offer positive active TB case who need to be evaluated right from the very child to the elderly, whoever have been in close contact to them, they need to be evaluated for latent tuberculosis and to be managed accordingly, because there are high likely of chances that they catch the infection and they might develop disease in their whole lifetime. Overall, 2% household contact develop incident TB cases, that is almost 12 cases per 1,000 person year. And it has been shown that HIV infection and undernutrition were independently associated with incident TB disease, while age, diabetes mellitus, smoking, alcohol, and baseline tubercular infection, regardless what was the measurement on tuberculin skin testing or quantiferon gamma immunoassay, cutoffs were not associated. Now, this study supports the new WHO recommendation to offer TPT, that is tuberculin preventive therapy, to all household contacts of pulmonary tuberculosis patients residing in a high burden country like India. They do not suggest any benefit of tubercular infection testing at baseline or during follow-up to risk stratify recent exposure to household contact for TPT. See, the issue is obviously we have limitation of testing we have just tuberculosis skin testing or IGRA. IGRA being costly is not available everywhere. So what we are left with is tuberculin skin testing. Obviously, it is not 100% sensitive or specific, but what we have right now is we don't need to treat all the patient who have good nutrition or immunity, but these are the patients which I have discussed before. These are the patients if they have positive TST, and specifically if they have the value of more than 10 or 15 these are the patients where we can give preventive therapy, so at least they don't land up into the active TB disease, because they already are dealing with one of the disease already, some comorbidity like HIV or diabetes or any other diseases, or maybe they are planned for some solid organ transplantation, and at that time if they have TB, active TB, they can't have the transplantation at that particular time. Surgery has to be delayed. So what is the magnitude of the latent TB problem in India? We know it is a high TB burden. India has constantly had been one of the highest burden, and it has been increasing. We have our targets, we are trying to fulfill, we are doing our best, but because of the high density and the population and overpopulation, poor nutrition and the hygiene, this is one of the tricky area where we are dealing with. The sheer number of TB cases contributes to a substantial pool of individuals with latent TB. The large population at risk, with densely populated, a significant portion of the population is at a risk of exposure to TB, leading to latent infection. Transmission and close living quarters. We know how we are densely living in an overcrowded condition. Almost sometime in some places there are 10 to 15 people living in a small household. So anybody who have active TB, and by the time they come to our center to get treatment, by that almost 15 days to 1 month, they have already exposed to a lot many people around in their surrounding, in their neighborhood. So they all are having chances of latent infection. Socioeconomic factors like poverty, malnutrition, lack of access to healthcare contribute to the persistence of TB, including latent infections. High rate of TB HIV co-infection, it almost go hand in hand. A HIV patient has increased chance of catching TB. A TB patient have, if going with that, with not maintaining that particular inhibitions, they might have chances of getting HIV also. So there, if both the diseases are there simultaneously, treating them becomes very difficult, because both the disease suppress their immunity very much, and because of the innumerable symptoms they can have at that time, and both the medicines are heavy, they are and it's all much very long duration of treatment. For digesting that much of medicine and for counseling them to take the medicine for in continuity for that particular duration what is being advised is sometimes very, very difficult in such patients. So shifting to what has changed, what was before pre-COVID and post-COVID era, what has changed? We have faced a big pandemic, and we witnessed it, and it was a respiratory symptom which it started. Eventually we got to know how much it was involving the lungs and the immunity, and how it changed with respect to our TB programs. Pre-COVID era, we had high TB burden, we had the challenges in TB diagnosis because of the limited awareness and stigma associated with TB. We still have the stigma. To be true, we still have the stigma. Patient doesn't want to accept, they don't want to discuss, they don't want to tell anybody. Even if they get to know, they tell you, don't tell my family, they don't want them to tell their surrounding people. They don't want that, because they still carry the stigma. If they have TB, people will isolate them. Yes, see, we have pulmonary tuberculosis, we have extrapulmonary tuberculosis. Pulmonary tuberculosis is the one which can spread to other people, not the extrapulmonary tuberculosis. A lymph node TB, a brain TB, a spinal TB, a skin TB cannot spread to anybody else. So, first of all, if the patient have extrapulmonary tuberculosis, we can make them understand that that won't spread, but we need to keep you under isolation in the way that you might carry active infection in the lungs in future, during your treatment. So, if you have cough or expectoration anytime during your treatment, you need to come to us, and you need to get evaluated well and treated well, and you need to understand that till you are not considered negative, you need to maintain certain respiratory hygiene practices. Inadequate healthcare infrastructure and resources hinder the effectiveness of TB control programs. Latent TB infection. Many individuals in India harbor latent TB infection where the bacteria are present but not causing active disease. Latent TB can persist for years, and the risk of progression to active TB is higher in individuals with weakened immune system. Now, what has changed in post-COVID? What we learned by the pandemic, what we should do. Now, there was obviously every I think healthcare professional was into treating COVID because we didn't have any option. We had innumerable number of people who were suffering from COVID and they were dying, and therefore all the services were being directed towards treating COVID. But then that hindered the TB control programs. First of all, because of the lockdown, patients were not able to come to reach to the healthcare centers, and there were also fear of visiting healthcare facility because of catching COVID. And relocation of resources to manage the pandemic affected TB control efforts precisely. Now, there was increased vulnerability also. COVID-19 has disproportionately impacted vulnerable population, including those with pre-existing health condition, as what TB does. So there was high likely chances that, and the symptoms are also similar initially. Even the COVID patient were having symptoms of cough, expectoration, fever, almost similar to TB. So by the time they realized that it was not COVID or TB and coming to us, there was a delay in the investigation and the treatment. Health system strain. It led to challenges in managing both TB and COVID-19 cases simultaneously. So, but there was one benefit, what we gained. Now, patient understand the need of respiratory health and to maintain respiratory hygiene. What they have understood that to wear a mask, making a TB patient to understand to wear a mask before COVID was very difficult. They were like, okay, I'll isolate, I won't cough in front of anybody, I won't sit with anybody, but it was very difficult. But post-COVID, one thing has changed. Now, when we advise them, you are supposed to wear a mask, they do understand. At least few of them do understand, they wear it, at least at their home, where it's required. You don't need to spread to the other people who are coming to your house or they're living with you. So, coming to some myths and facts related to latent tuberculosis. Some myths might be there surrounding when you treat patients. They come to you with some questions. So, there are a lot of questions happening which are not true actually. Like one is, it is contagious. Latent tuberculosis isn't contagious. It's not contagious because it's not active TB. It is just an infection which is not shifted to a proper disease pattern, and there's no active disease at present. So it won't spread from person to person. Active TB, a pulmonary tuberculosis is contagious. That we need to know. But not a latent tuberculosis. Second, latent tuberculosis always progress to active TB. As we have seen before, it's not always. It depends upon the condition, any predisposing factor present, any low immunity, or any other diseases, if there is present, then there are more likely chances of converting from latent tuberculosis to active TB. Latent tuberculosis always causes symptoms. No. That's the problem is, it's asymptomatic. That's why we are not able to diagnose them, not able to isolate them, or not able to understand who can have. But yes, we have few, as discussed in the previous slide, we have few people who we can evaluate if they are exposed to active TB cases. And therefore, it's difficult to counsel them to get evaluated first. Because they say, I don't have any symptom, why I need to get evaluated? Why I need to be treated? But you make them understand that we are treating you, evaluating you, so that you don't turn up into active tuberculosis if you have latent tuberculosis infection. It requires isolation since it's not contagious, it does not require any isolation. They can lead normal life, they can do day-to-day work. Latent tuberculosis infection is lengthy and complex. This is where we benefit with. It is not lengthy, it's not complex, it's simpler, and it reduces the chances of getting active TB by a largely percentage. So we can advise them that generally what we use is isoniazid monotherapy for treatment of tuberculosis preventive therapy, or we use isoniazid with rifampicin or rifapentin. So that is used for 3 months if we use the combination therapy. So it is a simpler therapy comparative to the other drug sensitive and drug resistant tuberculosis treatment. Latent tuberculosis infection is irrelevant in low TB burden. It is as relevant there in cases like where there is contact of TB cases, healthcare workers, they have obviously increased risk chances. So in low TB burden, these are the people whom we need to consider. It is not necessary in children. As we have said, as active TB is important to be evaluated and treated in children, it is as important in the adults. Latent tuberculosis is also important to be evaluated in children. A child born to a mother with active TB need to be evaluated, need to be ruled out with active tuberculosis, and need to be given preventive therapy if there's no active tuberculosis and there's a contact with the mother with active TB. Latent tuberculosis screening is unnecessarily older adults. It is as significant, again, because they generally have some comorbidities and they might land up into active TB soon enough. So there are certain specific conditions where I need to throw some light on, like female infertility. It's being said that the latent tuberculosis is directly linked to female infertility. It's not so. While active TB can impact fertility, the association with latent tuberculosis and infertility is not well established because it's not active disease. It's not involving any part of the genital tract. However, in cases where TB affects the genital tract, it may contribute to infertility. When there is active TB, when there is endometrial tuberculosis, or it's involving any part of the genital tract, it can cause infertility then. So is in chronic kidney disease. Patients we have already discussed who are on immunosuppressive therapy or on dialysis, they also have a high risk of TB reactivation. Heart failure, we were discussing during our break that they have found there are cases who have heart failure and they have ruled out every other disease. Myocardial TB, though very rare, can be one of the possibility of causing active tuberculosis and causing heart failure. So we need to keep that in mind that even it's rare, it can be possible. TB can involve any part of your body. That's one thing. So though the percentage might differ depending on the system being involved, but it can always do. Relationship with HIV immunocompromised conditions. I have discussed elaborately that how this dual burden is impacting, and dual disease is difficult to treat, difficult to evaluate, sometimes difficult to follow up, because most of the time patient compliance towards treatment of both the diseases is very low. I want to also enlighten a few points around of multi-drug resistant tuberculosis. We have preventive therapy for that also. 3 in every 1,000 people globally carry MDR tuberculosis infection. Prevalence of MDR, MTB in those with TBI infection is more than double among those younger than 15 years. What is alarming is now we even have primary MDR cases. Primary MDR means they have never had history of anti-tuberculosis treatment in the past, and they are coming to you for the first time, and when you evaluate, you diagnose them with rifampicin resistance or with and without isoniazid resistance. And this is very alarming because now even that incidence is increasing very high. Household contact of patient with MDR rifampicin resistance or H. mono resistance are at higher risk of tuberculosis infection than the contacts exposed to drug-sensitive tuberculosis. Recent evidence from systemic review and meta-analysis has suggested cost-effectiveness of treatment of latent tuberculosis to reduce progression to multi-drug resistant tuberculosis. And it has also suggested that a reduced risk of TB incidence with treatment of MDR TBI, suggesting effectiveness in preventing of progression to MDR TB and committed cost effectiveness. Now, what is the need of awareness? Why we are discussing all this? What is the need of the hour? Because being a high burden country, India, it is a reservoir, latent tuberculosis infection is a reservoir for future active TB cases. So what our target is to eliminate the disease. For that, we need to eliminate the active TB as well as the latent tuberculosis. Only then we can achieve our targets. Risk of progression is always because latent tuberculosis infection may not show symptoms, but they carry the risk of active TB. As and when the condition is available, early detection and treatment of latent tuberculosis can prevent progression. Co-infection comorbidities, as discussed, is very much relevant, and therefore that is why we need to be aware and we need to make people aware of the condition. Transmission prevention, awareness about latent tuberculosis can lead to better infection control practices, reducing the risk of TB transmission in communities, household, and healthcare settings. Vulnerable population need to be made aware. There need to be targeted awareness campaigns that can help identify and manage latent tuberculosis in these conditions, especially in healthcare workers, household contacts of TB patients. Pregnancy and pediatric concerns. In pregnant women, latent tuberculosis may pose risk and awareness is needed. If the patient, pregnant female who has TB, there are high chances of growth retardation intrauterine, and therefore it is very much required to treat the pregnant female very well if they have active TB. And additionally, addressing latent tuberculosis in children is crucial as they are more vulnerable to TB progression. And obviously, we need to remove the public stigma and misconceptions, as we have discussed about the myths and the facts. Being healthcare professionals, it's our duty to make them aware that what are the myths, what are the facts, what are the options they have, what are the healthcare facilities they have, what are the symptoms, when to reach the healthcare facility and when to get them evaluated, and what is the importance of continuing the treatment. So, impact of COVID-19, the COVID-19 pandemic has disrupted healthcare services. We have already discussed. Treatment adherence. For those diagnosed with latent tuberculosis, completing the prescribed treatment is essential. Awareness campaigns can educate individuals about the importance of adherence to prevent progression. Global health commitments. India, like other countries, is committed to global health targets, including the End TB strategy. Raising awareness about latent tuberculosis aligns with those global efforts to eliminate TB. To promote awareness, what we can do? We have community engagement. We can have engagement of communities through local leaders, community health workers, grassroots organization to disseminate information. We cannot reach everywhere, but we can guide these people who can further can reach to the community, and they can guide them. What is the importance and what can be the opportunities they can have, where sometimes they don't even know what is the nearest healthcare centers available to them. When they come to there are we don't have any TB center, but they do have, but they're not aware. So they need to be evaluated and made them understand that the medicine is free of cost. They can be evaluated free of cost. There's an opportunity when required, they can reach to the healthcare professionals as required. Media campaigns. Media, we know how much social media is prevalent nowadays. Every small to big news becomes a big news, even a small news. So how we can use them, that's very important. How we can utilize these medias in form of television, radio, social medias and print to reach to the wide audience and to share key messages about latent tuberculosis. Healthcare provider training, yes, training is required so that at least we get educated well, so that we can educate further the community, and further we can disseminate the knowledge well. School and workplace program. Even the school and workplace need to be the students. There need to be educational programs at the school level and the workplaces to increase knowledge about the latent tuberculosis. We had lockdown during COVID. Why? And there was work from home started for people who could do that, and they understood that what is the importance of how the respiratory infection spread through aerosols and how they can spread from one to the other. So therefore at the workplace also we need to require to educate them for all the infections we can have. Collaborative efforts foster collaboration between governmental and non-governmental organizations, healthcare providers and the community to create a unified approach to latent tuberculosis. Now just a brief of what future strategies, as we have all discussed in the previous slides, that's what I want to emphasize on. There need to be have an improved diagnostic tool, which we are working on, a better genomic biomarkers or what can be used to further have a specific diagnosis to diagnose latent tuberculosis well in advance. Screening and testing programs need to be having widespread programs so that we can reach to the rural areas as far as possible. Public awareness campaigns need to be done, integrated healthcare approach. Therefore, it has to be a collaborative efforts. All the healthcare professional, be of any branch, need to be has to join together, to work together, to understand and to fight against TB. Research and innovation, that's always important. How we can further make any further innovation regarding with respect to the diagnosis and the treatment for to fight our infection. Prevention of TB disease by treatment of tuberculosis infection is a critical component of National Strategic Plan 2017 to 25 for ending TB in India by 2025. It proposes a detect, treat, prevent, build approach, and scaling up tuberculosis preventive therapy would be key to hasten the rate of decline in TB incidence from 2.5% at present to 10% required annually. Rigorous, expensive and accountable TB contact tracing and investigation for secondary TB patients detection and treatment coupled with active TB screening for TB among high risk group and tuberculosis preventive therapy is one of the key activities under the prevent component of the National Strategic Plan. So active TB tracing is very much important, though not feasible because of the high burden we are into, but that is one of our chance to detect earlier, diagnose earlier and treat as early as possible, and even to see the compliance toward the treatment. Now, so just to end my topic, some take-home messages. The preventive measures, good respiratory hygiene is the foremost. Proper ventilation and vaccination, which is being need to be told to everybody that vaccination, BCG vaccination is very much required in the childhood. There are a lot of people who even don't get that. So we need to emphasize on that. Healthcare access is available near to their countries, near to their locations, everywhere is possible. All over the world it is available near to this household. So that is what they need to access well. Community awareness is the foremost, and collaborative efforts where we can make our effort well. So with this, I just want to say we need to join our hands and work together to fight TB in India by spreading the right information and motivation. And one step in treating TB can make a huge difference. Thank you. I can take any questions if there are any.
Session is open for discussion.
Ma'am, have you any screening method or in GTB hospital that all the HIV patients should be screened for LTBI latent infection?
Actually, we do, because we have to rule out the active tuberculosis before starting. Suppose a patient comes to you for the first time, have no symptoms of TB, and their first time diagnosed with HIV. So before starting their ART, they are supposed to be evaluated for any active tuberculosis. If they don't have, we have to do we ask them proper symptom, we do all the investigation like X-ray, ultrasound as required. And if they don't have any active tuberculosis, then only we ask them to start with, and we get TST done. We get that done, and if it is raised, we even now it's being implemented that we need to give tuberculosis preventive therapy to all if they are positive. So we do that.
Okay, thank you.
Yes.
Any further questions?
Ma'am, as we don't have any specific test available in our government setup for this latent tuberculosis,
yes,
because it is too costly. So, don't you think it is so difficult to diagnose to latent tuberculosis and to counsel them, to make them understand? I can't understand ki we are here to work on that latent tuberculosis. So, is it that much easy?
Ma'am, TST is not that costly. It's IGRA, which is very costly, and it's generally not available in the government organization.
Is it available in GTB? I am from
IGRA is not available. TST we have.
TST. I am from GTB hospital.
Acha, we have TST. We have TST. Yes, yes, we get it done. And sometimes the PPD is not available. That's a different thing. But mostly we have available, and we get it done as and when required.
I will definitely meet you.
Sure, sure, sure. You can come to my OPD anytime. Yeah.
Okay.
Thank you.
बहुत अच्छा presentation किया आपने. I just wanted to know, I was working in ICMR in Agra, Jalma Institute, you might have heard.
Yes, sir.
And our microbiology team has worked in Kanpur. That time, it is 2008, around that time.
Okay.
And MDR TB prevalence was 7 to 8%. Although our DG that time, underscored it to please the ministry people and reported as 4 to 6%, because that was the national average. But you said it is 3 per 1,000.
So this is for latent patient with latent tuberculosis of MDR, with MDR organism. This is about latent tuberculosis.
Okay,
this
okay.
Is not for active,
That is what I was.
This is not active patient.
Okay.
This is all data for the latent tuberculosis.
Okay. Second thing is, does our long time constipation in individuals has anything to do with developing TB?
Sir, if there's a long time constipation, there has been not particular, I would say, data precisely on that, but what can happen is the erosion of the mucosa, which can impact and can have the exposure and can have the increased chances of getting the infection. If there is latent infection, it might develop into disease.
So there is a probability.
There is probability.
Thank you.
Any further questions? Any further questions?
Your presentation was not only informative but also thought provoking, shedding light on the prevalence and challenges associated with latent tuberculosis in India. Your commitment to advancing respiratory health and your academic leadership in this field is truly commendable. Thank you for sharing your knowledge, ma'am. I now invite Dr. Divya Kajaria, ma'am, and Dr. Anil, sir, to felicitate Dr. Ankita Gupta, ma'am. Amrish, Dr. Amrish, sir, please join. जी 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 एक सेकेंड क्या
I would like to request Dr. Ishan Bharti sir to please come on dais. State Gay sir for the green welcome of Dr. Ishan Bharti sir. It is my immense pleasure to introduce a speaker for the fifth session of the today's workshop. He is an expert in radiology and key contributor to the field. Ishan Bharti sir is a radiologist at All India Institute of Ayurveda, New Delhi. Expertise to the realm in the medical imaging. Notably, he has played a pivotal role in a teleradiology project of a Government of India, a pan-India initiative for TB screening. This groundbreaking collaborative program involves ICMR, National Institute of Research in Tuberculosis, and World Health Organization.
In today's session, Dr. Ishan Bharti sir will share his insights on reading chest X-ray and CT in tuberculosis and its complications. His experience in teleradiology project, coupled with his expertise in interpreting radiological images, will provide valuable perspectives on the diagnostic aspect of tuberculosis and its associated complications. Dr. Ishan Bharti sir's session promises to offer a comprehensive understanding to the role of radiology in diagnosing and managing tuberculosis. Sir, I invite you on.
Thank you. Good evening, everyone. So the topic I'm going to discuss today is pulmonary tuberculosis, particularly the radiological review. So what is the role of imaging in pulmonary tuberculosis? Mainly for diagnosis, then for treatment evaluation, that is to assess the response and if there's any residual activity, and lastly for detection of disease complications and sequelae. So the main question which we come across is when should we go for a chest X-ray and when should we go for a CT in patients suspected to have tuberculosis. So the basic indication for a chest X-ray is to evaluate patients suspected to have tuberculosis, for evaluation of patients with unexpected cough and expectoration, evaluation of unexpected fever or constitution symptoms like loss of weight and appetite, in a patient suspected or diagnosed to have extrathoracic tuberculosis as a baseline workup, in a diagnosed case of pulmonary tuberculosis, After completion of intensive phase for assessing the treatment response, after completion of treatment regimen in selected cases, if any intervention has been done previously, and in evaluation of symptomatic patients having symptoms like hemoptysis, dyspnea, cough with expectoration, or any past history of tuberculosis. The indication for going for CT is for diagnosing pulmonary tuberculosis in cases of sputum negative patient with equivocal chest X-ray or equivocal clinical profile, initial contrast enhanced CT for complete disease assessment in patients suspected to have additional extrathoracic involvement, in a diagnosed case of pulmonary tuberculosis for assessment of disease activity in case of persistent lesions, which may be pulmonary lesions, presence of nodes or effusion on chest X-ray, radiographic worsening, equivocal chest X-ray in absence of clinical response, in evaluation of symptomatic patients with suspected tubercular sequelae when no prior radiographs are available for comparison, or if there's evolution of new findings. Lastly, in imaging of suspected complications of pulmonary tuberculosis. The imaging modalities in radiology are the basic chest X-ray, which we go for a posterior, anterior, or a PA view for the initial investigations performed in adults suspected to have tuberculosis. Now, the chest X-ray is frequently employed as the initial or a screening test to evaluate unexplained cough. Earlier, before the advent of CT, or at places where CT is not present, we can even go for an apicogram or a lordotic view for the lung apices, and the lateral view, which are obviously now of limited utility. The multi-detector CT is an important tool in detection of radiographically occult disease, differential diagnosis of parenchymal lesions, evaluation of mediastinal lymph nodes, assessing disease activity, and evaluating the complications. It not only enables earlier and more accurate diagnosis of pulmonary lesions, but can also be used to differentiate the different etiologies of pulmonary pneumonia. The CT enables evaluation of bronchiectasis, cavitation, associated fungal balls, and assessment of necrosis in lymph nodes, identifying pleural, airway, diaphragmatic pathologies, and evaluating the visualized bones. The contrast enhanced CT is the investigation of choice for evaluation of mediastinal lymph nodes and also aids in depicting pleural enhancement, particularly in cases of empyema. The high resolution CT reconstructions are especially useful to detect miliary tuberculosis, centrilobular nodules, ground glass opacities, and air trapping. The value of CT lies in the fact that it enables not only one but suggests the diagnosis of tuberculosis in patients particularly having negative sputum examination and those without sputum production. And moreover, it is done in a non-invasive manner. The CT findings may permit empirical initiation of ATT until time culture results are obtained. So tuberculosis we divide in two phases, the primary and post-primary tuberculosis. The primary tuberculosis may involve lung parenchyma, the lymph nodes, the tracheobronchial tree, and the pleura. Classically, the four entities are described are the gangliopulmonary tuberculosis, the tubercular pleuritis, miliary tuberculosis, and tracheobronchial tuberculosis. Only the gangliopulmonary form is characterized of primary tuberculosis, and the rest may be seen in the post-primary disease as well. The primary parenchymal focus, known as the Gons focus, and the combination of Gons focus and enlarged draining lymph nodes constitutes the primary complex, or the Ranke on the Gons complex. So let us discuss the gangliopulmonary tuberculosis, which is characterized by the presence of mediastinal or hilar lymph node enlargement with associated parenchymal abnormalities. The right parahilar, paratracheal, hilar, and the subcranial regions are most commonly infected, and the nodal involvement are most commonly seen at these areas. On CECT scan, that is contrast enhanced CT, the enlarged lymph node show highly characteristic rim sign. That is, the center is hypodense because of the low density necrotic area and this peripheral enhancement. The parenchymal opacities are usually located in the peripheral subpleural region. On CT, the air space consolidation in primary tuberculosis is dense, homogeneous, and well defined. So here are two examples. One is a chest X-ray and the other is a contrast enhanced CT. If you look at the chest X-ray, there are two findings here. We can see that there is enlargement of the right hilar region, plus a well-defined homogeneous opacity is seen in the left lower zone with an air bronchogram, which is typical of consolidation. If we look at the CT, we can see again a well-defined homogeneous opacity is seen in the left lung with air bronchogram, which is very characteristic of consolidation on a pneumonic patch. Whereas if you look at the mediastinum, we can see that multiple conglomerated necrotic lymph nodes are seen in the mediastinum as well as in the left hilar region. Now, this is the typical example of the rim enhancement. You can see that these are all multiple necrotic nodes. So there's no enhancement in the center because center has the necrotic component, whereas we can see the enhancement in the periphery, and this is called the rim enhancement sign. In this example, we can even see there's bilateral pleural effusion present. Out here also, we can see a large nodal mass having heterogeneous enhancement. Post-primary tuberculosis is characterized by liquefaction of the caseous necrosis, formation of cavities, progressive fibrosis and lung destruction, and lastly the bronchogenic spread. Again, we can see a chest X-ray having multiple nodular opacities with fibrotic bands in bilateral lung fields. If we look closely, we can see a well-defined thick-walled cavity having a fluid level in the left upper zone. If you look at the CT images, we can see homogeneous ground glass opacities in bilateral lower lobes with a thick wall cavity in the left lower lobe having a fluid level, which signifies that the cavity has been secondarily infected. The features of active endobronchial infection are consolidation, alveolar opacities, clustered nodules, centrilobular nodules on CT. Bronchogenic spread manifests as multiple ill-defined micronodules in segmental or lobar distribution, distant from the site of cavitation and usually involves the lower zones. On CT, it is identified in 95% of cases, making HRCT the imaging modality of choice to detect early bronchogenic spread. Typically, we see 2 to 4 mm centrilobular nodules giving a typical tree in bud branching appearance. Cavitation is also characteristic of post-primary tuberculosis, and the walls may be thin and smooth or at times thick and nodular. The thick wall cavities and cavities surrounding consolidation indicate active infection. The air fluid levels within the cavity occur in 10% of cases and can be seen due to superimposed bacterial or fungal infection. The fibroparenchymal lesions causing distortion of the lung parenchyma and traction or secondary bronchiectasis develops in phase of healed or active infection. Healing of post-primary tuberculosis occurs with fibrosis and calcification. So the basic radiological patterns which are encountered in both primary and post-primary tuberculosis are the miliary TB, the pleural involvement, the tracheobronchial TB, and tuberculoma. The miliary TB results from hematogenous dissemination of the tubercular bacilli, leading to development of innumerable small granulomas in the lung and other organs. Early in the course of the disease, chest X-ray may be normal in almost 25 to 40% of cases. CT, especially HRCT, can demonstrate miliary disease before it becomes radiographically apparent, and the presence of 1 to 3 mm nodules, either sharply or poorly defined in a diffuse manner in random distribution in bilateral lung fields with interstitial septal thickening is characteristic of miliary tuberculosis. Now here's an image of CT, HRCT, where typical findings of miliary tuberculosis can be seen. If we look at the image closely, we can see multiple small nodules which are distributed in random distribution involving bilateral lung fields, and out here we can see septal thickening is also present. So this is a very typical example and appearance of miliary tuberculosis. The pleural involvement. So there are 3 phases in the exudative effusion in post-primary tuberculosis. The first phase is the exudative phase, where contrast enhanced CT typically shows smooth thickening and enhancement of the visceral and the parietal pleura with loculated effusion within it, which gives a typical sign called the split pleura sign. The second phase, or the fibrinopleurin stage, is a stage where the effusion may consist entirely of pus or empyema, when there may be associated rib crowding on imaging as well as volume loss. This empyema may break through the parietal pleura to form a subcutaneous abscess. Appearance of air fluid level in the empyema may suggest communication with the bronchial tree, resulting in a bronchopleural fistula. The final phase is the organizing phase and includes chronic empyema and fibrothorax. Chronic empyemas appear as a persistent local fluid collection with pleural thickening and calcification. Fibrothorax manifests as diffuse pleural thickening with volume loss but without effusion and suggests inactivity. Pleural thickening and calcifications are frequently encountered features of healed tuberculosis. Now, here are the two examples. The one on the left, we can see that a typical split pleura sign where there's pleural effusion and only peripheral enhancement of the parietal and the visceral pleura, right? So this is the split pleural sign. The image on the right, we can see that if you look closely, that this complete enhancement of the pleura, which is thick walled, and there is lung volume loss, which can be seen because of the rib crowding. So this is a typical example of empyema. Here we can see another example of a thick walled cavity with fluid level. Tracheobronchial tuberculosis. Now, CT in acute tracheobronchitis may reveal circumferential narrowing of the involved segment associated with smooth or irregular thickening. Abnormal enhancement and adjacent adenopathy may also be seen, and less commonly, an ulcerated polypoidal mass or a peribronchial soft tissue cuff may be seen. Involvement of the small airway is in the form of acute bronchitis or bronchiolitis with centrilobular tree in bud nodules. So this image here, where we can see the vascular marking and multiple small nodules right adjacent to the vascular marking, is what is called a tree in bud appearance. Now the centrilobular nodules can either present in a tree in bud appearance like the image here, or can form mass-like coalescent nodules involving both the lung fields. Now, the tuberculomas are persistent nodules or mass-like lesions which can be seen both in primary and post-primary tuberculosis. The pulmonary tuberculomas can range in size from being subcentimetric to 5 centimeters in diameter and may be either solitary or multiple. They are most often associated with healed primary tuberculosis and usually are smooth-walled and sharply defined. Again, we have two images here. Out here, we can see a well-defined nodular lesion having specks of calcification, which is very typical of a tuberculoma. This is the image of the same patient in an HRCT image, where we can see a well-defined homogeneous opacity noted in the right lower lobe, again typical of a tuberculoma. So what are the complications of pulmonary tuberculosis? The complications include the parenchymal complications, aspergilloma colonization in pre-existing tuberculous activities, destructive lung changes, scar carcinoma, which can coexist or develop secondary, air complications like the tracheobronchial involvement, vascular complications, which include pseudoaneurysms, hypertrophied bronchial arteries, and systemic collaterals, which present with hemoptysis, pleural complications like chronic empyema, fibrothorax, bronchopleural fistula, and pneumothorax, and lastly, the mediastinal complications, which include mediastinal fibrosis, esophageal involvement, which could be either in form of stricture, traction diverticuli, or fistulae, pericarditis, pneumothorax, and spondylodiscitis. So this table shows the imaging findings in 3 different phases of tuberculosis. First is the active phase, the second is the intermediate phase, and lastly the heal phase. So a chest X-ray in case of an active phase of tuberculosis can show A-space nodules, clustered nodules in the upper and middle zones, consolidation in the upper mid zones with ipsilateral lymph node enlargement, presence of miliary nodules, thick wall cavities, cavities with surrounding consolidation, unilateral hilar paratracheal lymph node enlargement, and effusion or presence of empyema. On CT, we can again see A-space consolidations or nodules, centrinobular nodules, clustered nodules in the apical and posterior segments of the right upper lobe, the apico-posterior segment of the left lower lobe, the right middle lobe, the lingular segment, the superior segment of any lung lobe. Consolidation in the above mentioned regions with ipsilateral lymph node enlargement, miliary nodules, thick wall cavity, cavity with surrounding consolidation, enlarged lymph node with central necrosis, giving the typical rim enhancement or at times heterogeneous enhancement, conglomeration of lymph nodes or obscuration of the perinodal fat, effusion and empyema with split pleural sign. So these are the typical findings which we can see in active tuberculosis, whereas in a case of intermediate disease, the chest X-ray can show consolidation air space nodules or clustered nodules in the lower zone, equivocal nodules, that is miliary or air space nodules, cavity with air fluid level, equivocal hilar prominence, that is widening of the paratracheal strip. Again on CT we can see consolidation, centrilobular nodules in the segments. Ground glass opacities may suggest superimposed secondary infection or aspiration. Cavity with air fluid level usually indicates secondary infection. Borderline enlarged discrete lymph nodes with homogeneous enhancement or preserved perinodal fat. The findings which can be seen on heel tuberculosis on a chest X-ray are a thin walled cavity with or without an aspergilloma, presence of bronchiectasis, fibroparenchymal or reticular opacities, atelectasis or collapse, calcified lymph nodes, and pleural thickening or calcification. On CT again, we can see thin wall cavities, bronchiectasis with or without bronchial wall thickening, fibroparenchymal opacities, atelectasis or collapse, well-defined small nodules with or without calcification, subcentimetric lymph nodes again with or without calcification, and pleural thickening or calcification. So these are the different appearance of tuberculosis on chest X-ray. The first one, we can see that there is a patchy area of haziness noted in the right upper zone, which is very typical of consolidation associated with hilar enlargement of the right hilar enlargement. The second image again shows that there are multiple nodular opacities in the right upper as well as the middle zone, again typical of tuberculosis. The third image shows multiple reticulonodular opacities, more common in the basal segments. Image D shows that the multiple nodular opacities with patchy areas of haziness or consolidation, and as well bilateral hilar lymphadenopathy can also be seen. The last image shows a typical pleural effusion which is seen on the right side with multiple nodular opacities involving bilateral lung fields. Again, the different appearances on CT. The first appearance is a typical train bud appearance where we can see multiple small centrilobular nodules adjacent to the vascular markings. The second image has two findings. Firstly, we can see centrilobular nodules in random distribution, and out here we can see a thick walled cavity on the left side. Image C shows wedge-shaped consolidation present in the lung zones. Image D is again typical of a miliary tuberculosis where we can see multiple small nodules which are diffusely present in bilateral lung fields with interstitial septal thickening. Image E shows typical well-defined necrotic lymph nodes in the mediastinal window in the subcarinal and paratracheal region showing peripheral rim enhancement. Image F shows the characteristic split pleural sign where we can see pleural effusion and enhancement of the parietal and vesical pleura, giving a typical split pleural sign. And the last image shows a normal pleural effusion in the left lower zone. So these are the appearances of heel tuberculosis. The first one in the chest X-ray, we can see multiple fibrotic bands. There's no evidence of any centrilobular nodules as such, and fibrosis is an indication of heel tuberculosis. The second image of CT shows that there is tractional bronchiectasis because this fibrosis adjacent to the bronchiectatic changes. So bronchiectasis has happened secondary to fibrosis and therefore is known as tractional bronchiectasis. Image C shows that there is bilateral apical pleural thickening with possible atelectasis in the right upper zone. Image D again shows few fibrotic bands in bilateral upper zones. Image E shows calcification of the pleura out here. We can see the calcified pleura, which again signifies heel tuberculosis. And the last image shows bronchiectatic changes with volume loss as they shift of mediastinum towards the left side. And if you look up closely, there's even evidence of rib crowding, which signifies that there is volume loss, which is again very typical of heel tuberculosis. In this image, we can see that there is partial atelectasis in the right upper zone. On the CT image, we can see that in addition to atelectasis, there is patchy area of haziness or consolidation also present, with a calcified node present within the area of consolidation. This is another example where we can see a case of active tuberculosis where there is patchy area of haziness with a thick walled cavity in the right upper zone. On CT again, we can see that there are multiple fibrotic bands as well as patchy area of haziness in the right lung field and a well-defined thick walled cavity. Out here again, we can see that there are multiple fibrotic bands in the chest X-ray. But when the CT was done, we can also see that because of this fibrosis, there's presence of bronchiectasis also. So this is again typical of tractional bronchiectasis, which occurs in patients of tuberculosis in the healed phase. Out here again, we can see patchy area of haziness, which is active tuberculosis with multiple centrilobular nodules and A space consolidation. In the second image, we can see a thick walled cavity with a fluid level, which again shows that this is an active tuberculosis and the cavity has been secondarily infected. In the last image, we can see that there is a well-defined necrotic lymph node present in the right hilar region. In the first image here, if you look closely, we see that there's a cavity, well-formed cavity, and within the cavity, there's a well-defined round opacity. So this is very typical of an aspergilloma or a fungal ball, which are very commonly seen in patients of tuberculosis. Again, in the second image, this also is again an example of aspergilloma in a well-defined cavity. Now, image C shows a healed or the phase where there's calcification of the pleura with loculated effusion within it. Image D again shows a well-defined cavity with thick walled fibrosis and consolidation. And the last image again shows you calcified nodes in the paratracheal and right hilar region. Thank you. So, if there's any question.
Section is now open for discussion.
Anyone? Any questions? I think sir explained very well.
Either I explained very well or no one understood.
Everybody understood.
On the behalf of all the participant and organizing committee, I express my heartfelt gratitude for the very informative and insightful session. Your expertise in radiology, especially in the context of TB screening through the teleradiology project, provided valuable insights into a diagnostic aspects of the tuberculosis and its associated complications. Your presentation also highlighted the role of medical imaging in the diagnosis and understanding of the tuberculosis. Thank you very much, sir. Now I request respected Dr. Jonah, sir, for the felicitation of Dr. Ishan Bharti, sir. Hello. I also request Divya ma'am.
एक सेकंड हटियो। अरे यार ये नेक्स्ट करो ना। रहने दे, एस्केप कर। as we bring the curtains down on this enriching day of insightful discussions and shared knowledge. We are filled with gratitude for the collective wisdom and expertise that has graced our workshop. Today's sessions have been a testament to the collaborative spirit that defines our pursuit of understanding and combating latent tuberculosis through the lens of Ayurveda, modern medicine, and diagnostics.
We extend our heartfelt thanks to all our esteemed speakers, Dr. Raghuram Rao sir, Dr. Raghu Arakal sir, Dr. Urvashi B. Singh ma'am, Dr. Ankita Gupta ma'am, Dr. Ishan Bharti sir. Your expertise, dedication and willingness to share your insights have been the driving force behind success of today's workshop.
To our participants, your active engagement, thoughtful questions, and eagerness to learn have created a vibrant and dynamic learning environment. Your presence here is a testament to your commitment to advancing healthcare knowledge and exploring innovative solutions for the challenges posed by latent tuberculosis.
As we reflect on the diverse perspectives presented today, modern medical approaches from diagnostic challenges to national screening initiatives, it is clear that our collective effort holds the potential to make a significant impact on the understanding and management of tuberculosis.
We invite you all to return tomorrow with the same enthusiasm and curiosity as we delve into the remaining sessions of this workshop. Together, let us continue to build bridges between traditional and modern healthcare, fostering a holistic approach to combating latent tuberculosis.
Thank you for a day filled with valuable insights, engaging discussions, and the spirit of collaboration. We look forward to our continued journey tomorrow. Good evening. See you bright and early for another day of exploration and discovery tomorrow.
I request everybody to please proceed for high tea on 6th floor. आपके सिग्नेचर रह गए थे जी सर एक सेकंड रमनीक मैम सिग्नेचर्स